Good morning to everyone present here. I, Dr. Sunita, Assistant Professor Cardiology, take the privilege to warmly welcome the esteemed guests, faculty and delegates on behalf of Department of Cardiology for the Pediatric Cardiology Workshop. A conference is a celebration of knowledge, and this conference is built with an intent of active and interactive learning. I would like to take a moment to extend my warmest greetings to each and every one of you for making the effort to be here today. It is indeed a golden opportunity to each one of us to enrich and enlighten ourselves on interventions related to pediatric cardiology. We are deeply honored to have with us a panel of eminent faculty who have shaped the landscape of pediatric cardiac care in our country. Their presence here today is a source of guidance and inspiration for all of us. As the saying goes, knowledge shared is knowledge multiplied. We hope this platform opens doors to meaningful discussions and clinical insights. Once again, I welcome you all and wish you a fruitful and engaging experience. Now, with immense pleasure and deep respect, I invite our esteemed dignitaries to grace the dais. I request our beloved Director, Professor Dr. Shri N. Birappa Sir, to kindly come up onto the stage, please. I request Dr. B. Srinivas Sir, Professor of Cardiology, who is the guiding force behind this conference, to please come forward and join the dignitaries. I invite Dr. Sai Satish Sir, Senior Professor of Cardiology, to please join us on the dais, please. I invite Dr. Bharat Dalvi Sir, renowned pediatric cardiologist, to please kindly join us on the dais, please. I invite Dr. K. Nageshwarao Sir to please join us on the dais, please. May we have a big round of applause as we warmly welcome our dignitaries. We are honored to have your presence. Without any further delay, let us move to lighting of the lamp. I request Dr. Seshagiri Rao Sir, former head of the department and Professor of Cardiology, to join us on the dais, please. Light symbolizes victory over darkness and defeat ignorance. It marks the beginning of auspicious moments and events. On this note, I request the dignitaries on the dais to do the honor. We extend our heartfelt gratitude to our respected dignitaries for lighting the lamp. This marks not just the beginning of our event, but also ignites the spirit of learning and enlightenment that this conference stands for. Now, I request the audience to kindly raise for the prayer. I invite Dr. Manikrishna, Assistant Professor Cardiology, to lead us in prayer with a song.
Varavina Mrudupani Varavina Mrudupani Vanaruhalochanurani Suruchiravam Paraveni Suranuta Kalyani Nirupama Shubhagunalola Nirata Jaya Pradashila Varada Priya Ranganayaki Vanchita Phaladayaki Sarasija Sanajanani Sarasija Sanajanani Jaya 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 Pradasila.
Thank you, Dr. Manikrishna. With this auspicious start, may I now request our Director, Professor Dr. Shri N. Birappa sir, to kindly address the gathering.
Good morning, everyone. Respected Professor Seshgir Rao, Professor Sai Satish, Professor Srinivas, and other dignitaries on the dais, and the cardiologist delegates from all over the country and from Hyderabad, dear students, ladies and gentlemen. It's a privilege to have this conference or workshop in Nizam Institute of Medical Sciences. I thank Dr. Srinivas' team and Professor Sai Satish's team for having been conducting this kind of workshops, especially pediatric cardiology camps, which I heard very rarely done in this country. And we had some discussion few days back. What is the future of the surgery? I'm a surgeon. So future of the surgery is a dying branch, because you've been doing a lot of interventions. You've been doing a lot of valve replacement percutaneously. Then where is the question of doing a thoracotomy and valve replacement, bypass surgeries? So with chat GPT, whatever you call it as, I don't know all those things. And I feel after 5-6 years, there is no surgery. You have been doing everything. Unless patient has some congenital anomaly, I'm sure that is also you have been tackling. Multiple cardiac like TOF, I don't know, that's also being done nowadays. But lot of interventions are being done. Credit goes to our cardiology team and Sai Satish Garu and Srinivas Garu for an excellent job. They are the great cardiologists any time Nims can produced. And thanks for conducting this kind of workshops. And Nizam Institute of Medical Sciences is a front runner in doing this kind of a CMEs or workshops. Thank you very much and all the best. I hope you enjoy entire day with new deliberations and new learnings, and have some sympathy towards the cardiothoracic surgeons also. Don't do all those things, that's only. Thank you very much. Thank you very much.
One by one, Sai Garu, Sai Satish sir, then roll it through, then finally I'll talk, okay?
Thank you, sir. I request Dr. Sai Satish sir to please address the gathering.
Respected dignitaries on the dais and all the delegates has come all from different parts of our country, and the distinguished faculty, especially Dr. Bharat Dalvi, Dr. Nageshwar Rao, who are internationally renowned for their pediatric interventional work. We are very happy that they have participated in this workshop. I congratulate Dr. Srinivas and Dr. Birappa for giving us the opportunity and giving us all the administrative help for doing this workshop. We hope this workshop will be going to be a very successful program and will enlighten all the young and also senior interventional cardiologists all the tips and tricks in pediatric interventions, especially the device closures. Hope everything will be gone. I pray God think everything will become a success. Thank you.
Thank you, sir. I request Dr. Seshagiri Rao, sir, to kindly come forward and address the gathering.
Good morning. Dr. Birappa, Dr. Dalvi, and Dr. Nageshwar Rao, Dr. Srinivas, and Dr. Sai Satish. I am extremely happy to be here. It's my parent institution. I have been here almost for 30 years, and after that also I am regularly in touch with these people. I congratulate Dr. Srinivas and Dr. Sai Satish for organizing such good workshops in this institution. I always like to participate in such workshops, and we initially started the device closures and all long back in almost 1989 in Nizam Institute of Medical Sciences. So far, I think we have done more than around 5,000 device closures in the ASDs, PDAs, all these things. We learned a lot from all these things, but with new developments, I think people should be aware of new approaches and all. I think Dr. Bharat Dalvi and Dr. Nageshwar will be enlightening us on some of the important new developments in this field. And some of the cases like transjugular ASD device closure, myself and Srinivas, we did long back. That was almost 12 years back. It was the first case that was demonstrated. I think all these things will be discussed soon. I think all of you interact with the people, faculty, and I think we should get a good knowledge out of this workshop. I congratulate once again the organizers of the workshop, and I am very happy to be here. Thank you.
Thank you, sir. I request Dr. Bharat Dalvi, sir, to kindly address the gathering.
Good morning, friends, dignitaries on the dais, and ladies and gentlemen. I mean, at the outset, let me thank Dr. Srinivas for having taken this initiative to organize this workshop and actually inviting me, because this is an institute which I have always been looking forward to visit sometime in my life, because I have heard so much about this institute. And really, when I came into this branch of pediatric cardiology, Nizam was really a powerhouse in cardiology in general and pediatric cardiology in particular. I think success of any workshop depends upon the interaction between the audience and the speakers. So what I would request all of you is to ask questions. And many times, you get a little scared or perturbed in asking a question. But what I learned from some of my teachers, that if you ask a question which, let's presume, is stupid, you are foolish for 5 minutes. But if you don't ask a question, you are foolish for the entire life. So be sure that you want to ask questions, clarify your doubts, no matter who says what. Get up, go to the podium, and that is what will make this workshop a success. I wish you all the very best for this workshop, and thanks for inviting me once again. Thank you.
Thank you, sir. I request Dr. K. Nageshwara, sir, to kindly come forward and address the gathering.
Very good morning, and thank you very much. I am very much honored to be part of this program. I thank Dr. Srinivas and Dr. Sai Satish, Seshagiri Rao sir, and Director Dean of this institute. Starting from my PG days, particularly to this incident, I got inspired by two aspects. One, I read an article by Dr. Bharat Dalvi, percutaneous transcatheter perforation of the pulmonary valve. I took that paper to my professor J.M. Tharagan. We want to do this. He laughed at me and said, it cannot be done here unless you have a strong ICU care. So we were not having at Sri Chitra any kind of intensive care. Then I understood it is very vital to have the crux of the program is the intensive care. Second, they asked me a question during our routine program, what is the balloon mitral valvotomy Nims results? So I learned that Nizam Institute was the first center. They did the balloon mitral valvotomy and published in NEJM. Still we teach that, and it became a very, very landmark article. So I used to closely follow Nims, and it used to be very great feeling whenever I interact with the people. So therefore, when they asked me, immediately agreed, then I thought we should be part of this program. Thank you very much, and I wish you all the best for this program. Thank you.
Thank you, sir. To welcome is to show honor, to welcome is to establish integrity. On this note, I request our beloved Professor Dr. B. Srinivas sir to deliver the welcome address and brief introduction about today's conference.
Good morning, everybody. I extend my warm welcome to all of you. And you have taken your time out on a Sunday to make to this conference and make it a success. And I assure you, you will be immensely benefited at the end of the day. What with the kind of dignitaries we are having here, Dr. Dalvi sir, Dr. Nageshwara garu, and all other speakers who have vast experience in pediatric cardiac interventions and who are leading the way and the field, not only in India, but in Asia Pacific and even in the bringing recognition to India on the global map of pediatric cardiology. Trust me. Now, we have here with us Professor Seshagiri Rao garu, who is my teacher, who is my mentor, and who means a lot to me in my life. And many of you might not be knowing him personally. Let me tell you about him. He is a clinician par excellence. He is a great pediatric cardiologist in his own right, as I have seen him during my DM days. And I am very sure those who are trained under him would agree with me readily. Then, as many of you know, he is a very great pioneering interventional cardiologist, and beyond all this, he is a compassionate doctor to his patients. This is one trait I always try to emulate from him, and I should honestly say that I have not been very successful. So that kind of compassion for the patients and the equanimity he will have during the most extreme situations, either in his life or in the professional career, the things he would take with such equanimity, that is one thing to be emulated. So thank you, sir. Thanks for taking time to come here. And Dr. Bharat Dalvi, sir, just now, a few minutes ago, I was telling him, I'm a very diffident person. Usually I don't go forward, introduce myself and make relations happen. But he is one person with whom I myself went and talked to him. In 2012, I went to Frankfurt to attend Sivert's program on congenital and structural interventions. I saw him there. I felt an irresistible attraction to go and talk to him. So I introduced myself to him. I don't think he would be remembering that. I invited him to Nims then. He readily agreed and promised. But it took almost as much as 13 years for that to happen. And I have seen in that conference great legends like Shakil Qureshi, Neil Wilson. They are always referring to him, asking him about his opinion about a particular. This is all I can say. You try to kind of make your own estimation about sir. So he is truly a legend, and we are deeply honored and privileged to have him with us in our midst on a Sunday like this. When I told Anindya that we should have him, Anindya was a little skeptical. He said, sir is very busy, sir, you might not be able to travel and come. Then he said, no, let me talk to him. Then I asked him, sir, 20th we are doing a program. I called him and I introduced myself and talked to him. Then he said, that was in March. He asked me, was it this 20th? No, sir, April 20th. He readily said, I am there. I am there for the program. And he, as he himself said, he has very high regard for Nizam's Institute of Medical Sciences. Please give him a big hand for that. Whenever I called him, whenever I messaged him, this is what he told. He said, privilege is mine, Srinivas. It is mutual. I always wanted to come to Nizam's. That's what he said. Thank you, sir. And Dr. Nageshwara garu, I don't have to introduce him to you. He is a household name in Andhra and Telangana, so far as pediatric cardiology is concerned. He has really taken it to a very great heights in this part of the country. Please give him a big hand. And what more, he is a very innovative person with a great innovative mind. He has innovated his own devices, made them happen, and LifeTech has been producing them. MF Corner, you know. Now, he will show you, I think, in his talk, the map in which, the world map, the countries in which the MF Corner is being used. So we should be proud of him, period. He is one of us. He is one amongst us. Whatever his achievement is achievement of all of us. Thank you, sir. Thanks for that. And coming to Dr. Sai Satish, sir. Sir is my teacher along with Dr. Seshagiri Rao Garu, and he's a mentor to me. And he's always there for me to guide me, illuminate my path, give me his great wisdom. Whenever I approach him with some problem, he'll always have the department and institute's interest in his mind when he advises something. He will never have any selfish angle to his advice. So I always go to him. During my tenure as HOD for 2 years, for everything related to the department, I consulted him and I was benefited by that. Thank you, sir. Thank you very much, sir. Now coming to today's program, I briefly introduce the program to you and then we will get started with the program. So the program will start. Sadly, we recently lost one of the greatest legends of interventional cardiologists, hailing from our own South India, from Chennai, Dr. Samuel Matthews. The program will start by paying homage to the great man for his soul. And then actual program will start with Dr. Bhargavi's eco-assessment for ASD device closure. Yes, I agree, ASD device closure is a simple procedure. But a simple ASD device closure is not always that simple if it is not properly planned and properly imaged, and technique is not decided beforehand. So there is a variety of issues related to ASD device closure, for which echo is immensely useful. Nowadays, most of us are doing the procedure with transthoracic and subcutaneous echo guidance. Most of us have done away with the TEE, but I would like to know from the masters about that. So she will guide us about echo assessment for ASD device closure. That's the most important sine qua non talk so far as that session is concerned. And then Dr. Raghu, a very senior interventional cardiologist from our city, he will talk about ASD device closure step-by-step approach. He has readily agreed to talk on such a simple topic, so-called apparently simple topic, but unless it is not done very meticulously and in a thoroughgoing fashion, that can land you in troubles. So I think Raghu is going to tell you and caution you about all that. And then the great master himself will talk about ASD device closure in complex anatomy and special scenarios, Dr. Bharat Dalvi sir, and who else than him to talk about that. So that's all. Wait to listen to sir. Then Dr. Sudeep, a very good friend of mine, very humble. What I love about Sudeep is his humility and humbleness. So he will be talking about complications during ASD device closure and troubleshooting. I cannot overemphasize the importance of that talk. Then coming to the next session, there will be a tea break followed by that VSD session. Dr. Usha ma'am will talk about relevant anatomy and echo assessment for VSD device closure. And as you know, ventricular septal anatomy is as simple or as planar as atrial septum. It's a non-planar structure with so many other structures surrounding it. So one needs to know all these things before contemplating device closure. So her talk will throw a flood of light on that, I'm sure. And then Dr. Nageshwara Garu has done pioneering work in muscular VSD device closures. So sir has agreed to talk about that. So we cannot wait to listen to him. And he has published his own technique in cath cardiovascular interventions. So he'll be talking about that and also the standard approach. And then Dr. Soumya has readily stepped in. Thank you, Dr. Soumya. In place of Dr. Srinath Reddy, who got suddenly indisposed and could not attend the program, to talk about perimembrance VSD device closure, step-by-step approach and tips and tricks. And then we'll be going on to PDA session. Dr. Anuradha Sridhar ma'am will talk about anatomy, clinical and imaging assessment for PDA device closure, followed by senior pediatric interventional cardiologist from our city, Dr. Kavita, on PDA device closure, step-by-step approach and tips and tricks. And then Dr. Bhargavi will be talking about pediatric device closure in preterm babies. I requested Dr. Nageswara Garu that his team should talk about this. In fact, we wanted Dr. Sweta to talk about that because she has done a lot of work. But they're all team. They're all together in this work. So sir has allotted this talk to Dr. Bhargavi. She is taking that double burden of talking on another topic also. Thank you, Dr. Bhargavi. And then Dr. Krishna Kumar sir and his team have done pioneering work, as I understand, as I knew, about the approach to hypertensive duct and balloon occlusion test and thereby separation of aortic and pulmonary pressures and thereby deciding about device closure, etc. So I requested Dr. Navanita Seshkumar Gari, senior faculty from that institute, to talk about hypertensive duct intervention approach, and she's doing that. And finally, we will close up that session with Dr. Amitav Chattopadhyay's RBOT or PDS stenting. This is something counterruns to the previous talks. They are all about closing the duct. This one is about keeping the duct patent. So, but that's also important in the setting up pulmonary atresia. Then we will have lunch break followed by coarctation session. Dr. Prashant will be talking about anatomy and imaging assessment for coarctation. I have seen Dr. Prashant giving a talk in Kim's Hospital, a program conducted by Dr. Sudeep Verma. I was amazed at the collection he has shown of angios and caths of pediatric this thing. So I loved that talk of his. So he will be talking about imaging assessment of coarctation. Thank you, Dr. Prashant, for agreeing for that. And Dr. Nitin, he is not here. He will be joining us in the afternoon. He will be talking about coarctation stenting. And after every session, briefly we'll be running our own data, Nims data, about that particular device closure intervention. Then, as sir has told, and everyone has told, Dr. Sashigirao sir also has told, please get involved. Time is not the constraint. We are not going to be bogged down by the time limitation. Time is mentioned there because it has to be mentioned. That's all. We are going to end it when it ends. So you need to get benefited, get illuminated, get wiser and better by the end of the day. Thank you all.
Thank you, sir. I request Dr. Niyusha, Assistant Professor Cardiology, to kindly come forward and deliver a speech regarding the legacy of Dr. Sam Matthew, sir.
Gather here today with heavy hearts, yet deep gratitude to honor the life and legacy of a remarkable man, Dr. Sam Matthew. Born in 1948, his contribution to cardiology, particularly in interventional procedures, changed the course of cardiac care in India. Often referred to as father of angioplasty in India, he introduced techniques and practices that have saved countless lives. Dr. Matthew was more than just a physician. He was a mentor to hundreds, a teacher to thousands, and an inspiration to entire cardiologists. Even in his final years, he continued to teach, guide, and serve. Though he has left us in physical sense, his legacy is alive. May we continue to be guided by his example, and may his soul rest in peace. Let us now take a moment of silence to honor the remarkable life and enduring legacy of Dr. Sam Matthew.
I kindly request everyone to be seated. With that, we have come to an end of the inauguration ceremony. It is now time for us to formally commence the sessions.
Moderators for this session, Dr. Sunita ma'am and Dr. Hemant sir and Dr. Uma Devi and Dr. Prashant Patil sir to occupy their respective seats. Now I invite speaker for the first topic, Dr. Bhargavi ma'am. welcome her with big round of applause.
Good morning, everyone. So I'm very happy to be at Nims. Nims is my childhood dream actually. So every day we listen Nims. I am from Siddhartha Medical College, Vijayawada. So our target is only cardiology means Nims. I know many of our alumni are there here. I thank Srinivas sir for this opportunity, and I'm very happy I'm presenting to Bharadalvi sir here. Coming to our topic, echo assessment of ASD device closure. We know atrial septal defect accounts for 15 to 20% of the congenital heart defects. Most of the time they will be asymptomatic, only murmur. Spontaneous closure, if you see an ASD at birth, if it is less than 8 mm, we can expect a spontaneous closure. We have the guidelines, Indian Pediatric Association guidelines are there. So in this, ASD closure in an asymptomatic child is around 2 to 4 years of age, only symptomatic ASDs. What I mean symptomatic ASDs in infancy means something is there, either pulmonary venous anomaly or mitral valve left heart lesions, or there is a posterior ASD which causes heart failure. There we have to close the ASD early. So pertaining to the echo diagnosis, echo in ASD is transthoracic, esophageal and also eyes. So we will divide echo into pre-procedural, intra and post. What is the need of pre-procedure echo? First is to understand what is the type of ASD. 75% of the ASDs are ostium secundum, but there are like sinus venosus, coronary sinus, primum ASDs. So what is the size of the defect? Number of the ASDs are there? Is it fenestrated? What is the shunt? Is it left to right, bidirectional, right to left? Location and the margins, and to know the rims. And also most important is the down part, which we neglect. Evaluation of pulmonary arterial hypertension, to know about the pulmonary veins. So many times PAPVR, left upper pulmonary vein to innominate, may be missed during the evaluation. And also important thing in is mitral valve assessment, LV assessment. Most of the time in adults it is very important, adult with a hypertension. We don't have any diastolic dysfunction because there is a significant ASD there, but once you close the ASD, your LV EDPs will rise, pulmonary edema will be there. So it is very important to assess these things. So how echo helps in during the procedure? To reassess and how your catheter, if there is a fenestration, how your catheter crossed. Is it crossed through the bigger fenestration or the smaller fenestration? And also balloon assessment and balloon stretch diameter, that is top flow technique, we will again discuss. And also confirmation and the post deployment, how is your LA disc, any complications. So for example, you have taken a bigger device. Normally now they are telling like 150 times also we can take percentage. If you are crossing the 200% and taking a bigger device in a smaller child, you may erode you may cause the pericardial effusion because of SVC and aortic erosions. So that is the need of intra-procedural echo. And post-procedural, again for the device assessment, residual shunts, how are the pulmonary veins and systemic veins. So these things are very important. So I'll just tell the basic. Most of the time we write in the reports deficient rim, absent rim and widely spaced. What are these things? So deficient rim means if your rim is to the adjacent structure to the rim length is less than 5 mm. Absent means less than 3 mm. So you have multiple fenestrations and it should be, if it is we are telling as widely spaced, that means the distance between those things should be more than 7 mm. Then we should think, is it a 2 devices are needed or single device? So thin and floppy is, means your movement is there, the rim is moving very floppiness, or it is a sturdy. This is very important because when you are taking a device, you should include your floppy rims. So, and malaligned septum. Malaline means you have the posterior and anterior rim, but they are not, imaginary line is not meeting together, it is diverging. So this is called as malaline septum. So this nomenclature is very important to begin with. So now how the rims are named. Actually this is Dr. Savitri ma'am. In 2003 she has named about the rims. So this is based on your adjacent structures. So you should have a 3D imagination of interatrial septum. So when we are seeing the adjacent structures, I will start with the red. So here we are seeing here the torus aorticus will come. So this is a aortic rim. Then clockwise when you are coming down, there are AV valves, that is called as AV valve or mitral rim. Then the inferior where your coronary sinus and IVC is there, that is the IVC rim. And this purplish is the posterior rim, which is again divided into postero-inferior and also postero-superior. Postero-superior again called as like atrial rim also, and also the upper part will be the SVC rim. So this nomenclature should understand so that we can assess how are the deficient rims, because two opposite rims should not be absent or deficient if you are taking for a device closure. So how to assess? So here we have equal, like transthoracic view equivalent to transesophageal view. In children, transthoracic will have a better image quality, but in adults or grown up you may not have that much good quality in the subcostal. So your TE apical transthoracic apical view will be equal to your 0 degrees view, and that is here. So we are visualizing the heart through the AV and also here SVC and the atrial septum. So in short axis view is a 45 degrees view where you are cutting from the aorta and towards the posterior. And subxiphoid view will give you the 90 to 110 of the TE. So these are the views which are equivalent to each other. So now coming to the transthoracic echo, the subcostal views. In the subcostal view, what will happen? Your beam is perpendicular to your atrial septum. So the best views are subcostal view to assess the interatrial septum. And so the subcostal view is the better view for the interatrial septum. And you have two views in subcostal. This is a sagittal view and all the coronal view. So how the sagittal view runs is, it is running from your SVC and cutting here the posterior. So you can see the SVC part and also your IVC rim. And this is very important to know about your SVC will be opened and the sinus venous defects will be known. So coming to the coronal view, here also you can see the SVC. And also you can see the AV valve rim or the mitral rim can be visualized. If it is any deficiency, we'll understand. So same thing, another important thing I would tell, why the subcostal view. So what is this one, this structure, the movement of the structure. So this is actually SVC, this is the IVC rim, but the arrow pointed is your eustachian valve. This is very important to know your eustachian valves. Sometimes we have in kids long eustachian valve. We should not entrap with the device the eustachian valve. That is the reason visualizing eustachian valve in subcostal and also TE is also important. So the 4-chamber view, in this 4-chamber view what will happen? This is like you are parallel to the septum. So if your AST is bigger in size, more than 8 mm, you will understand, or else it will be like a dropout. Second important thing is, here we can visualize how are the dilatation of RA-RV, how is left heart, how is mitral valve. So that is very important in 4-chamber, and what we see in the 4-chamber is your atrial rim, and if you go more tilt more posteriorly, the pulmonary venous rim or the atrial rim, and your mitral valve or AV valve rim will be seen. So the most important another one is the short axis view. Short axis view, here you are cutting from the aorta and also your postero-inferior septum. So this is my aorta trileaflet. So here my aortic rim is there, and this is the postero-inferior septum. So this will tell about how are the opposite rims. So is it deficient or not, we will understand so that we can plan further. So this is mainly the kids, if rims are adequate, transthoracic is enough. But if rims are deficient or in an adult where you can't see a subcostal window, then you have to go for the transesophageal. So in the transesophageal, most of the time what will happen, what are the probe movements we should understand first. So the probe movements is advancing and withdrawal. I'll tell you why it is important. And the anteflexion and the retroflexion will come one by one. So this slide, actually I like this. This is same patient, same view picture. So what is the difference here? So you have a 32 mm measurement here. You have only 17 to 18 mm measurement. So it is very important when you are measuring the AST, we should scroll and get the maximum diameter and include your floppy rims. So don't see at one point only, but you have to scroll to understand, or else embolization risk will be very common. So it's of practical one. And here we are showing the withdrawal and advancing. Here I am advancing my probe. So in the same view to understand the posterior thing. So in a 0 degree view, you have to go and advance to see coronary sinus, and then you come out to understand the AV valve rims. And here also you are withdrawing to show the anterior, and in the same 0 degrees I am withdrawing and I am showing the rim here. And when you are withdrawing, you will see the aorta also. Actually aortic rim also will be seen in the 0 degrees. So the probe movement and taking the measurements is very important practically to understand the size of the defect. So TE, as we all know, transesophageal, most of the time we take a mid-esophageal views. This starts with the 0 degrees, where we can see the 0 degrees view to understand the 4 chambers, and also we will see the AV valve rim and the atrial rim, and also color interrogation demonstrates the shunt, how it is, and small fenestrations. If you have a bigger AST and another small fenestration, you may miss it. So entire septum you have to do a color interrogation. And the same view, and the same, so in the same transesophageal 0 degrees view, if you again turn anti-clockwise and you open up, then we can see the pulmonary veins. So right upper pulmonary vein can be seen in the same transesophageal 0 degrees view, and we'll understand the flow. And also the pulmonary vein recess will be understandable, so that when your device is there, if you are taking enlarging the size of the device, then is it causing pulmonary vein obstruction or not can be dealt in the 0 degrees view. Just a second. So after doing the 0 degrees view, actually in the TE of AST, every 15 degrees you have to see to understand the overall AST rims and all. So if we are dealing with only now, I have done with 0, come to 15, 20, 35 and 45. But the important views are the 45 degrees view, where we will see the retroaortic rims and the posterior septum. Is it deficient or thing we have to understand. So after 45 degrees, not working.
Issues or anything they want to know about the rims and the imaging of the atrial septal defect. I think, yeah, please go ahead.
So one of the challenges is always to actually image the IVC rim. It's always a struggle. We cannot get a good view in the subcostal or and then in the TE also we're not able to interrogate it that well. Probably any feedback on that, sir?
Yeah, I think it's a great question, and looking at the IVC rim can be quite difficult. And that is the reason, because the probe is very close to the IVC. So it's kind of a blind spot. So I think many years back, maybe more than 15 years back or 20 years back, Dr. Krishna Kumar from Kochi and his group described what is called as the retroflexion of the transesophageal probe. So you take the probe away from the IVC. If you take the probe away from the IVC rim gets out of that blind spot, as a result of which you are able to image it better. The other way of looking at the IVC rim when in doubt is look at the catheter which crosses the interatrial septum. If it is away from the bottom of where the IVC enters the right atrium, probably there could be a rim. Intracardiac echo is far better in looking at the IVC rim. And in children, sometimes transthoracic can give you great images of the IVC rim, as was shown. One thing I wanted to emphasize is many times you see some tissue and then you wonder, oh, this looks like an IVC rim. So be sure that if in doubt, please consider that there is no IVC rim. And many times IVC rim is mistaken for coronary sinus rim. So you have to be careful that this is IVC and not coronary sinus. Because if you rotate your probe clockwise and look at the SVC, that is the time when you are looking at the IVC rim. When you rotate clockwise towards, counterclockwise towards the tricuspid valve, what you are looking at is a coronary sinus rim. You have to be sure that the IVC rim is present, otherwise you will end up with embolization. One important aspect of any rims is not a point. It's not 0 degrees there is a rim. It's a sector. So interrogate the entire sector before saying that there is a deficiency. If you have a deficiency in one particular angle, doesn't mean that the rim is deficient. If there is a good rim, when you move either to the lesser degree or to the more degree. So important aspect of assessing the rim is not a point, but a sector. So this is what please go ahead.
Sir, this IVC rim, can you push the probe to the transgastric and then flex it? Then also sometimes you can see the IVC rim.
Absolutely, but looking at the IVC rim when you go transgastric, I think what you need to do, go transgastric, go retroflex and come up slowly. Look at the IVC, trace the entire IVC, and then you will know what lies posteriorly is the IVC rim, what lies anteriorly is the eustachian valve. And this mistake is not only made by the echocardiographers looking at the it is made by the surgeons on table. There are people, when you have connected the eustachian valve, considering that as IVC rim, letting the IVC drain into the LA, producing cyanosis. So you have to be very careful that it is IVC rim and not a eustachian valve, and very careful that it is IVC rim and not the rim of the coronary sinus.
I think she is ready. Only one point, 70-degree retroflexion in adults at TE. Children, you do the subxified sagittal plane, see the color. If the color is going to IVC, that means that there is no IVC rim. This is a very important point. Bhargavi, ready.
So I will show this probe, that is our TE probe. So we are flexing anti-flexion and retroflexion of the probe. So as sir told, it's very important to assess IVC. So transthoracically, if color interrogation flow is coming to IVC, that means IVC rim is completely deficient or absent. But when you are doing a TE, 70 to 90. So 70 to 90 go in, and when you are coming out, if you retroflex, what happens? It is called as near field artifact. So IVC is very close to the esophagus and you have a near field artifact, you will not see IVC rim. When you retroflex, then that near field artifact is gone, then only we will assess IVC rim. So many times we will be doubt in the IVC rim assessment, but retroflexion is very important. So after the retroflexion and doing the 70 degrees view, then we have to come to 90 to 120. Here 90 to 120, there are two things. When you are in clockwise rotation, you will see your IVC rim and also the SVC rim. After that, when you anti-clockwise rotate, what happens? Your aorta will be seen. So that is the aorta is called as torus aorticus, and it is very important to visualize that part so that we'll understand how much our device will encroach onto the aorta. So that is very important to avoid erosion. So we should not take a higher device that will encroach onto the torus aorticus and causes aortic erosion. So the rims, it's a chart which we know that TE equivalent to the transthoracic fourth chamber, and what rims we see, the mitral and pulmonary venous rim, or the atrial rim also, and 45 degrees view, we will understand the transthoracic it is a retroaortic rim and the posterior rim, and the subcostal of transthoracic is equivalent to your 90 to 120. So this is the assessment about the rims and how many defects are there. So is it important to do in the intra procedure? Yes, it is very important. You have to understand your wire crossing, how it is, and sometimes you may have a larger defects with deficient rims. That time we use a stop flow technique where you will take a balloon and inflate the balloon and see the balloon stretch diameter at the intratrial septum, and that is the reason we can understand. And there is another paper from Baradalvi sir, when you have multiple fenestration taking a single device, so where we will take the balloon and stretch it and we will see the second defect is closed or not. So that is also important to understand. So this is a case example. We can see the 0 degrees, 45 degrees and 90 to 120. You are seeing there are multiple fenestrations, but at least 2 defects are there, large. So how do you assess? Here the important things are, you understand, is it in the same plane or it is in the different plane. So for understanding not only 2D, we have to have 3D pictures also to understand, is it in the multiple, how much distance it is there, is it more than 7 mm, or we can take 2 devices or a single device. So 3D echo plays very important when we are dealing with fenestrated multiple VSTs to understand. Second, if you don't have 3D also, we should understand every 10 to 15 degrees you see all the rims, so that in your, we have a 3D picture in ourselves that how the rims are deficient. So that is another important thing. So we understood how to assess, but what are the contraindications of a device closure? You have an AST with severe pulmonary hypertension, large AST, or a moderate AST with a severe pulmonary hypertension in an young adult, like 16, 18 years old lady is coming with a moderate AST, 10 to 12 mm, but you have a severe pulmonary hypertension. That is a disproportionate thing. So we should not go ahead and close that AST. So we should understand why there is a pulmonary hypertension, are there any other causes? And primum ASTs, common atrium, these are also not suitable for a device closure. It should go for the surgical one. So I am not keeping sinus venous AST here because there are challenges are different and different things are happening transcatheter. So relative indications are, if you have a deficient rims orthogonally opposite, then will be a relative contraindication. For any beginner to start, you think weight should be more than 15 kgs and the device to BSA ratio should be 20 mm, and also the deficient rims more less than 5 mm don't take in the initial stage. Once you are understanding the rims, how to size the defect, then we will have an opportunity to do a larger device in a smaller child, but I don't recommend in the initial things. So these are the actually our Indian pediatric recommendations where weight should be more than 15 kg to take for the device closure. So we will have one case. This is a 42 years old gentleman came to us with grade 2 dyspnea. We have evaluated, there is a significant AST, no pulmonary hypertension. He was good. So we have ECG was also not showing any abnormality, only RSR dash pattern. So we have taken for a AST device closure. AST device closure was done. He is happy, patient is happy, we are happy same day. After 48 hours, he started to have dyspnea. So this is increasing, and when we did an echo, it shows our TR velocities are around 4. So what is happening to him? So because everybody in the adult forum, so we have again did the echo. We are seeing the LV mass is 50 grams per square, and ejection fractions were normal, but E by E dash is 26. That means there is a significant diastolic dysfunction that is causing the pulmonary hypertension. So what is the causes here? So as initially also I told, though they don't have LV will be normal when there is an AST. When you closed it, then you will have diastolic dysfunction. We have taken him again to the cath procedure. So baseline blood pressures are stable, arterial. After that we gave oxygen, Lasix. At the end, when we gave NTG, then only your capillary wedge pressures came down, PA pressures came down, and everything was normal. LV-EDP was almost 40 in the initial, which came to 10. So something, there is a missing link here in this case, what we have not seen on the echo. So again, we went for the evaluation. So when we have done the CT, so we can see from the base to apex sweep, you are seeing in the apical HCM is there. So that is the thing which caused all these problems, diastolic dysfunction of LV when you just close the ASD. So this is very important. This case shows the left heart is needed to be assessed meticulously. So we have another, I'll just run down one more case. It's an 8 years old, 24 kg, 15 mm ostium secundum AST. Every will be very happy. It's a juicy case where you can go and put the device. So when you saw the pedigree, if you see pedigree, you see so many congenital heart disease are there in the maternal family. So what we have done an ECG. ECG shows sinus bradycardia around like 60 to 50 heart rate for a 8 years old child. And then we have done mother ECG also. In the maternal ECG, PR interval almost 220. So this is there. When we ask them, so we ask the mother what is there. So she says all our family members has a low heart rate. So this is her statement. And child underwent a thumb reconstruction surgery. So here you should understand the importance of ECG and family history because it came as TBX5 positive, it's a Holt-Oram syndrome. So meticulously see ECG also before going for a device closure. So another example, here is a 6 years old girl, moderate AST, PA pressures were normal. When you sedated the child, suddenly transthoracic echo, TR gradient was normal. When you taken on table, sedated, and we check every time PA pressures on table. AST definitely check PA pressures. PA pressures are 2/3 systemic. So we did not understood. We went back and checked our echoes everywhere. We wrote normal TR gradient. We saw all the images. It is normal. So what is there? And you can see blood gases showed PCO2 retention is also there. Only grandmother told she will be agitated by evening. This is the only history we have. So we did blood gases in the awake state and now the sleep state. Sleep state, there is a PCO2 retention. Awake, she is absolutely normal. When we showed evening time of drowsiness, so what we have done is we understood something is abnormal. We consulted our neurology team and also sleep studies also done. So in that, what we understood it's a myasthenia gravis of milder variant. So what is happening? Awake state, she is happy. When you are sedating, PCO2 retention causing increment in the PA pressure, she is not having PA crisis because there is a AST which is shunting. So that is the reason it is very important. So these three cases tells about LV function, ECG, family history and the PA pressure assessment during your AST device. So summarizing, the meticulous evaluation is needed, understand the rims and also the left heart assessment is must. Thank you. Thank you.
Thank you, Dr. Bhargavi, for a lucid presentation. I think how many of you are relying totally on echocardiographic measurement to go for device closure? Because in the initial stages, we are sizing the defect with a sizing. Yeah, initial stages we are using a sizing balloon, and then we are 100% sure when there was a proper waste. When there is no waste only, there is a lot of uncertainty in the balloon sizing and all. But now the people are relying totally on echocardiographic measurements. Up to 22 to 25, it's okay, we will be able to get away. But once the defect is approaching 30 and odd, then there are a lot of uncertainties involved in the echocardiographic measurement. That's what I asked Dr. Bharadwal also. He says 90% of the times he reverted back to balloon sizing. And he is using the balloon for the balloon assisted delivery also. I think that point has to be considered. In the bigger defects, I think that bigger defects, I think we have to revert back to the balloon sizing and use the same balloon for the positioning of the device also.
Do you routinely size by balloon, sir?
So the thing is that I'll tell you very frankly, initially when we started the ASD closure program, there used to be a circular balloon from Boston Scientific, and we used to actually pull the balloon through. That was the pull-through diameter, what we used to call it. Then came the concept of stop flow technique with the advent of understanding of cardiac erosion, because with the pull-through technique, we usually oversize the defect and therefore the device. As we went on doing only with then with stop flow, then many people said that even with stop flow you tend to distend the defect and maybe oversize, and then there is a waste of time and then extra cost of the balloons. So many centers went on to do with transesophageal alone, and we also followed the suit. But what I realized is that on transesophageal alone, when you do it, it is an approximation. Some groups will add 2 millimeters, 4 millimeters, whether a child, whether an adult, aortic rim present, not present, IVC rim floppy, not floppy. And then I said that rather than approximating in this fashion, adding 2, 4, 6 or 15%, 20%, why not me put a balloon and see what the probable diameter is, and then based on the surrounding rims decide. So everything in ASD is an approximation, and it is up to you and the group you are following with to decide what kind of approximation would you like to follow. In our practice, we have come back to balloon sizing. The argument against balloon sizing in large ASDs is the stability of the balloon. Many people believe that the balloon becomes very unstable and getting a diameter is very difficult. But I think giving it a shot is not a bad idea, and that has been our practice.
Nageswarar, your comments.
I think we stopped the balloon sizing many years back because of the tendency of oversizing in the presence of floppy septum and other things. I do agree with Bharat sir, when you are doing multiple ASTs, especially we do balloon sizing, multiple ASTs. When you intend to do balloon assisted technique, where too much of floppy rims are there, that's what present practice in our scenario. But it's as sir said, it's a purely institutional based practice, how you are comfortable. But without balloon sizing, let me also tell you, 20% of oversizing is possible, whoever is the operator.
Sir, we'll go on to the next speech.
We'll move on to the next speaker, Dr. Raghu.
How many people are still calculating QP by QS during the procedure? Just some fundamental questions. Okay, none. I think essentially we'll go by the clinical criteria, the wide fixed split and presence of any right ventricular diastolic event, ECG, X-ray and echocardiogram, paradoxical septal motion, and any AST more than 8 millimeter with the right heart dilatation. I think less than 3 years of age group, less than 8 millimeter, there is a tendency to be closed naturally by around 60 to 70%. So there is no emergency when you want to close an 8 millimeter AST during first 3 years of life. There are some instances, even during infancy, AST can produce a heart failure in 5 to 10% of population because of the posterior defect or the non-compliance of the right ventricle or left ventricle both. Right ventricle may be stiff. So these conditions, probably you may consider AST device closure during early childhood also. There are some papers worldwide published that. So it's mandatory to check pulmonary veins, all pulmonary veins before, because in adults especially, left upper pulmonary vein will not be seen by transthoracic echo. So earlier we used to actually open the device based on the transesophageal echocardiogram before the procedure and then load it and then take axis and all. Then we realized that sometimes the femoral vein axis may not be there. In couple of cases we had to do transhepatic approach. So we stopped. Once we get the femoral vein axis, then we used to open that. Then we realized that sometimes cases like that. Okay, ready? Raghu is ready?
No, carry on.
No, please go ahead, Dr. Raghu.
Carry on, because these are the things which I also encountered. Please go ahead.
So then you see pulmonary hypertension, then again you are wasting the device. Then finally we realized that unless until you enter the upper pulmonary vein in adults, then you should, unless you diagnose before itself. So it's a common to miss that. Please
it's
go ahead.
It's very important. Access issues, suddenly you recognize on the table, they are very, you get flummoxed. Thank you, Dr. Srinivas, and my respects to my teachers, Dr. Seshagiri Rao and Dr. Bharat Dalvi, my friend and teacher, Dr. Nageshwara. So it's, I learned a lot from all these people. So let me start with the device closure of atrial septal defect. So Dr. Bhargavi has done an excellent job and very beautiful cases from the Dr. Nageshwara's group on ASDs and different clinical scenarios, which we see in our practice if we continue to do them. And we all know that we are treating mostly the ASDs in the fossa vallis location only. So that is the type of the ASD, that's what we commonly call as the secondum ASD, that's what we are going to do. The most important thing is the appropriate case selection. So your planning for the ASD starts from the case selection. We have to understand what are the anatomical risk factors. The echocardiography talk has covered a lot of them, and I would be sharing what are the various steps and for the ASD closure and post-procedure management. So this is also very important. What is our post-procedure management which we need to adapt to our patients. So I will take a case-based approach for my presentation. We had a 22-year-old lady who comes from Somalia to India for infertility treatment. She doesn't have any cardiovascular symptoms. And incidentally, during her preoperative workup, she was found to have an atrial septal defect. And she has been sent for device closure. So when we looked at her clinical examination, her oxygen saturations were normal. The ECG was showing a PR which is normal with an incomplete right bundle branch block. The echocardiography showed a dilated normal left ventricle with a dilated right atrium and right ventricle. The right ventricular function was normal. The ASD measurements we take in 0 degrees and 45 degrees and 90 degrees, and then we had about 2 measurements, and then we had a pulmonary hypertension on echocardiography which was around which was a mild pulmonary hypertension. Actually, this lady we did not do a transesophageal echo. My comment upon the 45 and 90 was based upon whenever we perform the transesophageal echo. Now, having said that, will this patient require a ASD device closure? A 15 millimeter ASD in a 22-year-old lady without pulmonary hypertension. So we need to really think. When we have a smaller ASD is okay. When the child or a person is asymptomatic, should we do an ASD closure or not? So that is the first question which we need to ask. So what are the requirements? So for example, we do encounter patients who are breathless and coming for ASD evaluation. So that patient, irrespective of pulmonary hypertension or not, so we need to close them. If the shunt is more than 1.5:1, the dilated, when the heart chambers are dilated, then any size of the ASD with a documented transient ischemic attack, stroke or pulmonary embolism. And we really need to document pulmonary hypertension to be suitable or to be taken up or to be have an indication for a ASD device closure. So symptomatic patient, dilated cardiac chambers, even a small ASD with a embolic symptoms and QP by QS more than 1.5:1 are the indications, standard indications for ASD closure. So why I wanted to share is, it is very important to choose the right patient. Now, we need to do right heart hemodynamics, as Dr. Nageshwara's case was showing. The right heart hemodynamics pre-procedure are essential. But in a busy practice, what we do is we try to cut shortcuts and then try to avoid that. But having said that, we need to do right heart hemodynamics at the extremes of age, which is very important. And the size of the defect is something which is a controversial thing. We have got the Britishers who feel that ASD which is 10 millimeter has to be closed, but the Americans take a much more aggressive approach where they tend to close any ASD more than 5 millimeter, but this is what we need to understand. Then, for example, when do we do a small ASD closure? For example, when we work in a quaternary centers like Yashoda Hospital, any patient who has got an ASD who is going for a liver transplant surgery or a brain surgery to prevent a paradoxical embolism. Now comes to an elderly person, let's say 65-year-old person. Just now I had a patient who had 55 with right heart failure, and whether we should do a ASD closure or not. It is nowadays the data is accumulating, and as operators we get more and more quality experience, we are able to close them. The indication in this case is quality of life preservation, but at the risk of developing atrial fibrillation. So with this, what are the contraindications? They have already been covered in the previous talk. So now I would like to share little repetition, but what I look for and how I assess the ASD in my day-to-day practice. This was the article Dr. Bharat Dalvi was just referring to, was an article by Dr. Krishna Kumar's group, where we do an echocardiography in the 0 degree upper level, septum looks what we call complete. When you go to the mid level, septal defect is seen. When you go below, the septum is once again seems to be intact. So this is a very important article which I strongly recommend, because the retroflexion for looking at the IVC rim is also a part of this article. Now we do at 3 angulations, 0, 45 and 90. And 90 we look at the SVC rim and we look at the IVC rim. So these are the fundamental rims. We cannot leave this responsibility to another of our colleagues, but the implanter should always have the echocardiographic control. And in the 45 degree or 50 degree, we see the posterior rim and the aortic rim, and this is where the maximum span of the ASD is there, and this is a very important view for us to see whether this case is suitable or not, and at the same time whether the device is stable or not when we are doing the procedure. So these are the 3 views, and then as I told you, that article by Dr. Krishna Kumar's group is a wealth of information. So I strongly recommend everyone to go through that article before every device closure, especially in the formative years. Then echocardiographic measurements, which we have already discussed. Now let's go for this case. This patient, if you can look at the echocardiography, the right atrium and right ventricle is dilated. You can see we are looking at the subcostal projections, and then we are taking up the case further for the procedure. Now let's go, what are the things? Before we go into the procedure, we need to understand what is the anesthesia. Are you going to do under TE guidance or transthoracic echo guidance? What is the anesthesia? Am I going to do a general anesthesia, or are we going to do a local anesthesia? Access, like Dr. Nageshwara was just proposing. Then balloon sizing is something which is very divergent across various institutions, and how do we deploy the device. various hardware, because I am a adult coronary cardiologist, or IC, what they call as interventional cardiologist. So we are not versed with these hardware and all those things. So we need to have the entire hardware control, without which you will not be able to do. Right heart catheterization is mandatory for all my ASD procedures, and ACT monitoring is also very, very important for us. Balloon sizing, we had just now had a discussion. There are two ways. I used to do an angiographic thing, but just now, but recently, last few years, I had been doing a stop flow technique, where you stop the flow and then look at this one. The other advantage of doing a balloon sizing is we can look at the surrounding tissue also. Now, how do you size the device, or what is the choice of the device size? Usually on transesophageal echo, we measure the ASD size, and we'll take a device which is about a couple of millimeter larger than the size of the device. And then system preparation I will discuss later. But for people who are very young, we need to understand that the device size is based upon the waist diameter. So the device size is the waist diameter. That is the one what we are seeing here. Now this is a self-expandable device and a self-centering device also. That is what is very important for you to understand. You got the right atrial disc is smaller than the left atrial disc by about 4 millimeter, and the length of the waist is about 3 to 4 millimeters. So these are the essential components. For example, you are taking a 20 millimeter device, means this is the diameter of the central waist, and the LA disc is larger than that by about 12 millimeters. So that's what you need to understand, and the RA disc is larger than the waist by about 8 millimeter. Now, having said that, when you take the device, the sheath comes separately, so you need to have a grasp on which device, which sheath, so and what is the usable length. So these are important things. Now we go for the delivery system. Nowadays you have got the 2E post and or the Y connector, and then we have the delivery cable. This is what is a typical delivery system and a torque system. I will just show you, this is something which is very important because if you are not careful here, this is what air embolism happens, and when you introduce through the Y connector and deliver the device and load the device, and this is the loader, what you can see, the blue hub, and then test the intactness, and then you have to uncoil. Once you completely fully this one uncoil by revolve by about half rotation, and then always load it under underwater seal, and then connect it so that you advance this one. So this is very important step, because I myself had I think once a big brain stroke because of that. Then the second tip what I wanted to share with you is, whenever you are advancing with the dilator and the sheath, you have to advance the dilator up to this one. If you can see the instructions for use from Amplatzer or the Abbott, what they say is you should not go into the left atrium with the dilator, because once the sheath is there in the IVC, you remove it, remove all the air, and then only advance the system. So this is also one more important tip. Otherwise what will happen is you start putting the removing the dilator in the left atrium, the air can get sucked, and nowadays with the Y connector systems we need to do deployment removal of the dilator in the right atrium. Now this is a case what we did under transthoracic echo, and then you can see here we advanced the sheath across the ASD into the left atrium. Then after doing that, we went into the left upper pulmonary vein. You can see on the echocardiography also on this side, and then we deploy the device. We are just advancing the device into the left upper low pulmonary vein. You can see here the device, and now we start deploying the device from the left upper low pulmonary vein. Pull back the device, and then you can see on the transthoracic echo that the device is in the left atrial disc is released. Then after that we pull back the echo. I think the echo will play a moment later, but what is happening is you can see in the LAO cranial projection 35-35, you can see the nice waist, and then echocardiography also collaborating. So LAO cranial, you deploy the LA disc, then pull back the sheath, and then deploy the RA disc, and you can see the clear-cut waist across the septum. So that is what we do. Then what I do, what I learned from Dr. Hugh in Vietnam is always come to the REO caudal and look for an NFAS device view where you can see a disc-in-disc appearance. If it is there, then your disc is good. Then before you release, do a Minnesota wiggle, but Minnesota wiggle you should not do very vigorously. Early part I used to do vigorously, device used to prolapse. So it's an important tip, just you do a gentle Minnesota wiggle, and then before you deliver or release the device, you have to look at echocardiography in multiple projections in, as you can see in the echocardiography, where we looked at multiple projections in the 4-chamber, color, and then we went into the, you can see the splaying of the device on either side of the aortic aorta. So that is what you get. If you get like that, then it's a very stable ASD. Now, after the procedure, it is very important for us that we give infective endocarditis prophylaxis for at least 12 months after the device. So this is very important, and pre-procedure also we need to give antibiotic prophylaxis for ASD device closure. So this is one more point I wanted to talk. And then pre-procedure itself we need to give aspirin for these people, and for 6 months single antiplatelet is the thing which is required. And if the patient already has some other cerebral embolism due to some other cause, then you have to give a dual antiplatelet therapy. When do you see the patient back in the clinic? Echo before discharge, and then at the end of 6 weeks, 1 year, 3 years and 5 years. After 5 years we can release the patient, because we need to look at, like Dr. Nageshwara's patient, within 2 days they develop pulmonary hypertension, but sometimes you can develop PAH later. So we need to understand what is the reason for pulmonary hypertension development, and device erosion are the things which we need to always look at it. And then we should always think the need for future transeptal punctures, just like what we do in a lifetime management of TAVI, we need to look for this. I will go for the next case, where we wanted to show a 51-year-old lady, hypertensive, obesity, and hospitalized 4 months, 4 times in heart failure. And then if we look at her oxygen saturation is only 87%, and then this lady had an RBP with a prolonged QRS. So echo showed an ASD of 31 millimeter, severe pulmonary hypertension. So such type of a patient with systemic desaturation, we did and we need to do pulmonary vasoreactivity assessment, balloon occlusion, and then possibly device occlusion, and we need to look for the progressive pulmonary hypertension. So this is the cath where we had the wedge of 35. So when we did the baseline cath with a wedge of 35, we thought that I could understand that the shunt is left to right, even though that she could be having a HFpEF. So this is a very tough scenario. You can see the systemic saturation is only 87. But when we did oxygen and then with 100% oxygen, the QP has increased from 1.2 to 4.1, PVR reduced from 5.5 to 1.65, so which gave us the confidence to do this procedure. So why I wanted to share with you this case is, in patients with severe pulmonary vascular resistance, and you should always consider a HFpEF, and sometimes the ASD presence could be contributory to all these things. Now we release the device for this patient, and then this is what we did. Now let me go quickly to the various other techniques. Post procedure, this lady has improved well. Now I quickly show you, this is the conventional technique where we release the disc on the LA side, and then the waist here, and then release the right atrial disc and a Minnesota wiggle. Now we can do the same from the left upper lobe pulmonary vein, and then we are deploying the device from the LUPV, go down. For example, many times when you go at the 45 degree, if the RA disc, the disc is prolapsing towards the RA side, then we need to do an aggressive counterclock manipulation to go to a different plane and then deploy the disc. Then we can do it from the right upper lobe pulmonary vein. So we can deploy from the left upper lobe, right upper lobe, and then we can do a cobra head deformity also, as you can see in this patient. So where we gradually release the ASD, you can see the cobra head deformity of the device, and once again, once we do this procedure, then gradually you can see that the right atrial disc will be released on the RA side, and then you can reposition the device. So this is what we can see. Now let's look at some new techniques for the ASD. This is the fast technique where there are absent trims, which is very popular when the large ASD instead of doing a very time consuming of a balloon assisted technology or a catheter assisted technique, you can do a fast, you put the sheath directed towards the left upper lobe pulmonary vein, deliver the device and then pull back the sheath very rapidly, as you can see in this patient. And then you can, once you retrieved it, then you can reposition with a Minnesota wiggle and you can see how it is happening. Or you can see like this patient of a fast, where you deliver both the device discs on the left side and then reposition it once the device is held on the left side. So this is a fast technique for ASD closure which is becoming popular. Now coming to the last slide, atrial septal defect closure is a simple procedure, but the case planning is very important. We need to study the right ventricle to assess the hemodynamic. It is also important to study the left. TEE closure leads to a symptomatic improvement and regression. A patient benefit from the closure is not dependent upon the age. The success for ASD is very high, 96%, and low rate of complication. Pre-interventional check is very, very important, and sizing the device and avoiding a large sized device is something which is key to long-term outcomes. Thank you very much.
Thank you very much, Dr. Raghu. Maybe in the interest of time, we can take questions later. Or okay, one. Yeah. So, any questions from the floor?
Yeah,
I mean, a couple of things is, one thing is, it is a very common cliche that there are many ways to skin the cat. What I would suggest is that you should use the technique wherein you are most comfortable.
Yes.
Don't go by what A, B or C does. I think you must feel that level of comfort with the technique that you are using. And as Raghu has showed, multiple ways of deployment of the device. Another thing that I wanted to talk to you about is many times we think that the pressure that we get by tricuspid regurgitation jet is the PA pressure, but it is RV pressure. I have seen many patients with pulmonary stenosis being labeled as pulmonary hypertension, and association of pulmonary stenosis with ASD is not at all uncommon. The third thing about pulmonary arterial hypertension, I think many times when you go in the cath lab, you throw those numbers, QP, QS, PVR, SVR, but I think the approach should be holistic. And why I'm saying this, because if you close the ASD in somebody with an irreversible pulmonary vascular resistance, you will convert him into a PPH-like syndrome and make his life even more miserable. So it's not that you're not helping him, but actually you are harming him. And if you don't close in somebody with reversible pulmonary arterial hypertension, you will end up stealing away important years of his life, both in terms of quality as well as longevity. So look at everything. In the era when I grew, these numbers were given importance, but they were looked in the background of clinical picture. Whether the patient has symptoms of left to right shunt or he is presenting with fatigability, hemoptysis and syncope. Whether he has a large heart in the absence of AV valve and semilunar valve regurgitation. Whether there are flow murmurs across the tricuspid valve and across the pulmonary valve. And then look at the various other echocardiographic, ECG, X-ray. ECG may not help you, but X-ray definitely. Cardiomegaly, plethora going into the 1/3 of the lateral field of the lungs. Look at the echo where you see that the flow is only left to right. Look at the pulmonary venous flow and also saturations at baseline and post-exercise. I think all these things need to be looked at, and then look at the numbers in the cath lab. Looking at the numbers in the cath lab in isolation, I'm sure you will burn your fingers. So these were some of the things. And one thing that I wanted to tell you is never flout the basic principles of cardiac catheterization. I've seen it many times, people pushing the sheath without having a wire. Not a great idea. Putting the catheter or putting the device without aspiration. Not a great idea. So these are the basic fundamentals of cardiac catheterization which should never be flouted, no matter whether you are doing 100 cases, 200 or 1,000 cases. So these were some of the points that I wanted to make.
Sir, I wanted to ask you a couple of points about, because we do encounter an elderly ASDs. 65, 70. What is your recommendation? At what age we should continue to take the ASD? That's the first question. The second question is, what is the size of the ASD, smallest size of the ASD when we should intervene, and at what age? That is the second question. The third thing is, whenever there is a systemic desaturation, what is the cutoff point, and how do you approach these patients? So these are the three things which I wanted to take because practical relevance in our day.
So the first question was regarding the age. I think that when you deal with elderly patients, it is impossible to prophylactically or say a priori whether this patient has a restrictive physiology or not. So if you have multiple risk factors, hypertension, diabetes, CKD, atrial fibrillation, I will not bring this patient to the cath lab unless I have given him adequate diuretics, vasodilators for at least 2 to 3 weeks before bringing him, and then trying to balloon occlude or even device occlude to see the effect on the left ventricular end diastolic pressure or a pulmonary artery wedge pressure. The second thing, when in doubt, I will always perforate the device in this subset of patients rather than burning all the bridges and closing ASD altogether. If the patient has, see, I would not go by how big the defect is, because many times these defects in different planes have different dimensions, and the size of the defect also depends upon the size of the patient. So I think what I would look at is the physiology. How significant is QP by QS by virtue of right atrial, right ventricular dimensions, and by virtue of QP by QS calculated in the cath lab if there is any doubt. But if the defect is too small, I would probably not do anything and let the natural history take its course. And lastly, in a desaturated patient, I think it is important to know what is the, many times the desaturation may not be related to pulmonary arterial hypertension. It may be related to systemic venous anomalies. Sometimes it may be related to lung issues. So I think it is important to put the entire clinical picture before you decide whether you are going to close this or not. And again, in case of pulmonary arterial hypertension, if in doubt, I would fenestrate. And more importantly, I would first treat the patient, reassess the patient, close with the fenestration and treat again. So that would be my policy.
Size of the ASD?
Size of the ASD, it wouldn't matter again because I'm not so much bothered about the anatomical size. I would go by what the physiology looks like.
Yeah.
If QP by QS, right atrial dilatation, cardiomegaly, plethoric lung fields, I would go for it. And age is not a criteria. Now there is a huge data from Japan where even octogenarians have been benefited by closing ASDs in terms of quality of life.
How do you do a fenestration, sir?
Fenestrations, there are two ways of doing it. One is you get factory-made fenestration. There are certain companies which have it. And in others, you have to make it in the cath lab. I tend to use my surgical colleagues to make the fenestration.
Before deploying?
Before deployment, we make a fenestration and then deploy the...
and then load the device and take it.
Absolutely, and then deploy the device.
Thank you, sir. Thank you.
I think it's extremely important to remove the dilator very slowly when the sheath is in the left atrium. So it rapidly sucks the air. That is very important, which you have to observe. The next thing is, after releasing the left atrial disc, what we do is we release a little bit of waste also, so that the alignment would be much better. Suppose if you release the disc only and try to align it to the septum, there will be some wavering motion and disc may prolapse into the right atrium if the defect is bigger. Suppose if you release a little bit of waste also and then align it, the alignment would be better.
Dr. Arnavalli, microphone please. No. If you go by the natural history, clearly in curriculum mentioned, 5 to 10% of large fossa ovalis ASTs during infancy will produce heart failure, essentially due to posterior defect, which I mentioned that non-regression of right ventricular hypertrophy or left heart disorder. These children, even you can either subject them for the surgical closure if you feel the risk is low, or nowadays even we are doing less than 10 kilogram, less than 3 years in selected population. Like they may need diuretics or not gaining weight, heart failure is still there. X-ray if you take a big heart. So there are indications. It is not that guidelines, AHI guidelines or whatever it is, strictly you need to follow that. There are indications. Even earlier Maas and Adams, the AHI group also shown that infancy they closed some of those things whenever there is indication. Yes. Yes, correct. So now may I request Dr. Bharadwali, senior pediatric cardiologist of the country and is founder, editor for the Annals of Pediatric Cardiology. I think he doesn't need any introduction. At this point of time, he is working at the HN Reliance Heart Foundation with the surgical colleague Dr. Shiv Prakasha.
Thanks for that kind introduction. And I'll try and stick to time, maybe 3 to 4 minutes over time. So my talk is on ASD device closure in complex anatomy and spatial scenarios. So there is no universal definition as to what constitutes a complex anatomy. But most of you will agree with me if I consider following subsets as being complex. Large ASDs in adult or in children, ASDs with deficient rims, and deficiency could be in terms of its length or in terms of its strength. Many times combination of large defects with deficient rims, ASDs with malaligned rims, multiple ASDs with or without aneurysm of the interatrial septum, and absence of femoral access either because of obstruction to the femoral or the iliac veins or because of interrupted IVC. The second part of my talk, which unfortunately I'll not be able to cover in this particular, but we can discuss during question and answer session, are the special scenarios. The special scenarios include in the very young, which was referred to just a couple of minutes back. And what are the implications of closing in the very young? These are the patients with small left atrial size, and so the left atrial disc tends to prolapse across the defect into the right atrium. There is just no space in the left atrium to accommodate the left atrial disc. So these are technical issues. And there are some other issues like heart blocks. Believe me that if you try to close large ASDs in small children, apart from issues of mitral valve, issues of erosion, I think one of the commonest issues is conduction abnormalities, and sometimes it may translate itself into heart blocks. In the very old, there are chances of restrictive LV physiology getting manifested, atrial arrhythmias, and worst amongst them is atrial fibrillation. So how to deal with atrial fibrillation in elderly if the atrial fibrillation is there before you take the patient for closure, and if the atrial fibrillation were to develop after you have closed the ASD. And another issue in elderly is the coronary artery disease. Whether to deal with coronary artery disease, when to do coronary angiography in asymptomatic ASDs in elderly, these are all the issues which are debated worldwide till date. And of course, just now we discussed about pulmonary arterial hypertension. So the questions that we need to answer in patients with pulmonary arterial hypertension is to close or not to close. If we decide to close, whether we close completely or with a fenestration, and the philosophy of treat and close or close and treat or treat, close and treat. So these are some of the issues which we will discuss during Q&A, and I'll not be able to cover in my talk in the interest of time. Now let's begin with complex ASDs. If you really look at the complex ASDs in your own practice, you will realize that there are two important issues which make it technically very demanding. One is the lack of alignment, which was just referred to. When the left atrial disc, you bring it back, it kind of malaligns with the plane of the interatrial septum. No matter how many times you try, every time it falls perpendicular to the septum. And this is the example is large ASDs in adults. The second is the lack of accommodation. In small children, when the left atrial disc opens, there is no space, as a result of which the left atrial disc gets secondarily malaligned and results into prolapse across the defect. So this is an example you can see here, how do you get the point? Okay, thank you. So you can see here, this is the plane of the septum. Every time you open, it kind of opens perpendicular. And the second thing is in small children, where you can see that there is just no space in this left atrium. So the disc comes across into the right atrium. So lack of alignment and inability to accommodate. So what are the solutions for these problems? You can either change the mode of delivery, you can change the delivery sheath, or you can use an additional support. And this is an example where instead of coming out of left superior pulmonary vein, you try and deploy it from just outside the right superior pulmonary vein. In maybe small to moderate cases, you may be able to get the alignment right, and then you can deliver the device. Or you can modify the sheath. One of these sheaths can be used, but availability of these sheaths is not very common. And that is why many people have started using support, maybe support of the guide wire, catheter, dilator, or balloon. And one of the techniques which Dr. Raghu described was the FAST technique, where you can deliver the device very rapidly, and this has been popularized by a group from Dubai. Now, I'll show you some of the cases of large ASDs in adult. So this is a 28-year-old, huge defect. You can see that it's around 39 millimeters in 4th chamber. So you can see here in short axis, the defect is close to 40 millimeters. So you will agree with me that although the rims are not too bad, the defect is quite big. So this is a patient who is a perfect candidate for balloon-assisted technique. So this was a circular balloon. This was in an era which was, I think, maybe 15 years back. And you can see that the left atrial disc is delivered. That is followed by the delivery of the waist and the right atrial disc. What does the balloon do? Balloon allows you to deploy the right atrial disc without left atrial disc coming into the right atrium. Any support technique exactly does that. Because the right atrial disc is much closer to the delivery system, will always be aligned to the plane of the interatrial septum. And once the right atrial disc aligns itself to the plane, the left atrial disc has no other way of doing anything but to sit on the right atrial disc. And that is what happens. And then you can deflate the balloon, and you can see that now the device is sitting beautifully, and this is how the device looks in the end. Now let's look at the large ASDs in children. As I said, the main problem is accommodation. So in 2013, we described a group of techniques called as the left atrial disc engagement disengagement technique, one of which was referred to by Raghu, or maybe many of them. So in this, you engage the left atrial disc, release the waist, followed by the release of the right atrial disc, and there is a spontaneous disengagement of the left atrial disc with device capturing all the rims. So this is an example of a small child who has a reasonably large ASD, but if you see, the rims are pretty good. And this is the commonest technique of left atrial disc engagement and disengagement, and you can close the defect very predictably. And there is nothing sacrosanct about the left superior pulmonary vein. You can do it from the right superior pulmonary vein. Now, whether when the disc doesn't disengage spontaneously, is it a good idea to pull back the disc or push on the disc is something which is a matter of debate. We like to little bit push on the cable in this fashion, because what we believe, if I pull back this, the RA disc will lose its alignment and both the discs will fall across the defect. Whereas when I do this, the RA disc is still aligned with the interatrial septum. The only problem of pushing like this is conduction disturbance. You have to be very, very gentle, and you don't have to push the cable like this. You have to let the cable be redundant so that it curves over itself and helps in disengaging the left atrial disc. Again, there is nothing sacrosanct about left or right superior pulmonary vein. These are accidental engagements. While trying to engage in the left superior pulmonary vein, it got disengaged and got engaged into the left atrial appendage. And see, we have used that engagement to deliver the device. Similarly here, we tried to engage in the right superior pulmonary vein, got disengaged, but got engaged somewhere in the left atrial roof. and you can use this particular engagement to deliver the device. So it's not necessary where it gets engaged. The principle remains the same, that if you can deliver the right atrial disc without left atrial disc prolapsing through the defect, you will have achieved your purpose. Where you engage it is not a matter of importance in this particular subset. It's not necessary that all patients, small children, these techniques will be predictably positive. Maybe 90% of the times you will be able to obtain the success of technically delivering these devices. But sometimes even in small children with such large holes which are 20, 21 millimeters, as seen in this particular patient who is a 3-year-old, we went ahead and used a 22 millimeter device, again using a balloon assist, but here we see a cylindrical balloon, and you can see that the left atrial disc is delivered. The balloon doesn't allow the herniation. Then we deliver the waist and the right atrial disc, and then we start deflating the balloon slowly, push the cable so that the device is well formed. In doing that, in this case, both the discs came into the left atrium, but the alignment was perfect. So what we did, just recaptured the right atrial disc, brought back the left atrial disc, and delivered the device in the appropriate position, and once we were happy, then we have released the device. Now let's move on to the deficient rims. I'm going to only discuss deficiency of 2 rims, the inferior and the superior. So this is an example of a 76-year-old gentleman who came in cardiac failure, renal failure, ventilated, hemodialyzed, and you can see the spontaneous contrast. Huge defect. I think this defect is something like 37 or 38 millimeter, and the rims are quite deficient there, and even floppy. You can see the IVC rim, and even on 3D, you can see that just a sliver of tissue all around with a huge hole. Again, we went ahead and closed it with a balloon assist. Here, this was a 44 millimeter septal occluder, which was fenestrated to prevent the manifestation of restrictive physiology, and you can see that how the fenestration has helped us in decompressing the left atrium, and this patient could be deventilated, got off dialysis, and was discharged. This is an example, and this is what I am trying to tell you. It is not at one point. This is at 0 degrees. There is hardly any aortic rim here. Then you go on to 15 degrees, then on to 39 degrees, then on to 53 degrees. You don't see any aortic rim. This is truly deficiency of anterior and superior rim. It's not only at one point, it's across the spectrum. So when you have a deficiency like this, 2 things can happen. This is a candidate where you can have device embolization, or you can have a cardiac erosion. These are the patients where families should be taken into confidence and counseled really for a long time to let them understand what you are trying to do. So this is what we did, balloon sizing, and then we use the same balloon to deliver the device. And again, in various angles, you can see that the device is sitting beautifully without compressing on the transverse sinus here. And this patient did not have embolization, nor did she end up with any erosion. So this was a successful closure despite there being a significant deficiency of the rims. Now let's talk about malaligned rims. So this is what I mean by malalignment. You can see here septum secundum, you can see here septum primum. Gross malalignment, but sometimes better seen in bicaval. You can see this. This is the septum primum, which is getting attached to the roof of the left atrium here. This is the septum secundum. If you want to close this defect, the device should start from here. If you put the device here, it will get embolized. If you put the device only across this fenestration, the device will get embolized on the left side. So the only way of closing a malaligned ASD is to use a very large device, much larger than what the defect looks like. And that is the reason why malaligned rims make these patients prone to erosion, and because of the malalignment, many people tend to put the device here, gets embolized. So again, embolization and erosion are common complications of malalignment. So this is one of our patients, 19-year-old. You can see here, septum primum is getting attached here, and that's the septum secundum. You can see again in short axis, this is the septum primum, and that's the septum secundum. Unfortunately, in this patient, we couldn't show the malalignment so well in bicaval view. Again, balloon sizing was done, and here we did not use balloon assist, came from outside the left superior pulmonary vein so that we can capture the septum primum attachment on the left atrial side, and then we delivered the device, just a gentle wiggle, although I'm not a great believer of wiggle, and once we are happy that both the rims were captured, the septum primum on the left atrial aspect, you can see here. You can see now the septum primum here is well captured, and the septum secundum here, you can see them separately, and so also in short axis, you can see that the septum primum is here, and septum secundum is here, and this device. And now you can see how big the device is. Look at the straggle. This is not how normally the devices are known to straggle. So that's in bicaval. Now let's talk of multiple ASDs, and this will be the last subset that I will be dealing with. Multiple ASDs is a big spectrum. You can have a multiple ASDs wherein there is a small thin tissue separating the two defects, or there could be a big chunk of tissue which separates the two defects. Or you can have a fossa ovalis defect, and when you push your transesophageal lower down, you can see there are multiple fenestrations in septum primum. Or you can have a huge aneurysm with, God alone knows, maybe 5, 6, 7 fenestrations, as you can see in multiple views, and look at the size of this aneurysm. And then you can have an aneurysm of the septum primum with a small defect here, another defect here, then between the primum and the secundum here, and then you can have, with a counterclockwise rotation of the transesophageal probe, you can have some more defects here. For every patient like this, the philosophy of treatment will vary. It has to be tailor-made. You don't have one simple principle of treatment. Now let's start with two discrete defects. So these are all the various strategies which were used. If the distance is more than 7, use 2 devices, less than 7, 1 device. If some people manufactured their own devices in China, they made the overhang of the left atrial disc to 12 millimeters. So they said we can close if the devices are separated by 12 millimeters. Some people said that you can tear off the intervening tissue, convert it into one, and then treat. And some people just said that use a large size device. However, all these strategies were empirical, never put to a scientific test. In 2022, we presented our data of balloon interrogation of the intervening tissue to decide whether we are going to use a single device or a 2-device strategy. And if we use a single device strategy, what would be the size of the device that we are going to use? And now what did we do? We did a simple thing. We passed through one particular hole and then inflated the balloon like we do for a stop flow, but we did not wait there. We kept on inflating the balloon to see whether this tissue was redundant, and if we were able to push it to the other side, stopping the flow through both then we said this is balloon interrogation positive. And if it was not positive through this hole, we would pass our wire through the other hole and try and push the device on the other side. So at the end of this, the result was balloon interrogation positive or negative. If it was positive, that we could close the flow through both the holes, single device. And the size of the device would be based on balloon interrogation diameter, not on stop flow. Balloon interrogation diameter is always bigger than a stop flow diameter. And that is what we did, and that was the end result. And this is one of the examples which you saw. 2 defects separated by a tissue here in short axis as well as in 4 chamber. This is a stop flow technique. You can see that there is a definite flow there. You can see here that there is a good waste here. We went ahead, inflated the balloon further till such time that the flow was stopped through both the holes. Look at this. This is the balloon interrogation diameter, much larger than the stop flow diameter, and then used a single device to close both the holes pretty effectively. Now this is a patient who has 2 holes, and now what we have done, balloon interrogation of the inferior hole, but you can see that we cannot push this on this side. So what we did, we went through the other hole. And again, when we did balloon interrogation of this hole, there is a definite flow through the inferior hole. So this is a candidate. Now this is through both the holes, we have passed the balloons and closed both the holes. So this is a candidate for 2-device strategy. You cannot use a single device in this, no matter how big the device size is. And this is what we did, a small device in the inferior, a little bigger device in the superior, and this is how two devices look after they are released. Now, apart from two discrete holes, if you have any other combination that you saw, what we do? We first try and cross the hole with a pigtail catheter. If we are successful in crossing with a pigtail catheter, then we balloon interrogate through that defect and decide whether we are going to use a single ASO or single ASO with cribriform or whatever. But if you are not able to cross with a pigtail, despite making an effort to cross through these multiple fenestrations, then our philosophy or then our policy is to use a cribriform device, either one or multiple. And now I'm going to show you this. So this is again multi-fenestrated with a huge aneurysm. You see that? But the major fenestration is located inferiorly. So this is quite easy to cross. So again, what we did, we crossed with a pigtail. And you can see the aneurysm has already stopped the massive excursions that it was undergoing. And then we did the balloon interrogation. And you can see the aneurysm is getting smashed and it's completely gone. And now we can, through the same hole, we have put a single amplarter septal occluder, and you can see that it has closed the entire aneurysm, and it has closed all the holes in the aneurysm and that major hole which was situated inferiorly, giving us a great result. In a case like this, again, we tried to cross with a pigtail, which we were able to, but we were not able to, when we did the balloon occlusion, we were not able to close all these fenestrations. So what we did, we said that we will close the main hole with a amplarter septal occluder, and we closed the multiple fenestrations in septum primum using a cribriform septal occluder. So this is a cribriform septal occluder, and this is a amplarter septal occluder closing all the possible holes. In a case like this, where you see, where you see that there are multiple fenestrations here. So you can see that, unfortunately I couldn't play these, but these fenestrations we couldn't cross with a pigtail, so we directly went ahead with a cribriform device and closed both all the aneurysm, all the holes, and squashed the aneurysm. I'm so sorry. And this was a patient in whom we used multiple cribriform. I don't know what's the problem. But anyway, we used multiple cribriform devices to close the defects in the interatrial septum here. So this is how it looked. So in conclusion, ladies and gentlemen, complex ASDs are a wide spectrum, and we need meticulous planning and execution. Many of these patients are technically challenging. Procedural failure and complications are a real issue, and that's why the patients and families need to be counseled properly before you take them to the cath lab. Thanks for your patient hearing, ladies and gentlemen, and sorry for the glitches.
Thank you, Dr. Dalvi, for an excellent presentation demonstrating all complex situations we come across during the ASD closure. When there are deficient inferior and posterior rims, when all your transfemoral approach fails, it is described in literature that you can try transjugular approach also. But we had the opportunity of doing transjugular case in only one case, where the patient has IVC interruption with esophagus continuation. There we went through the transjugular approach, but there we pre-shaped the sheath because we had to go 90 degrees. 90 degrees, we crossed the atrial septum and we positioned our wire into the left lower lobe pulmonary vein. And after entering with the sheath, we released the disc in the left lower lobe pulmonary vein and slowly withdraw it and let it center and align it to the interatrial septum, and finally we could release the right atrial disc also. When all your attempts fail with transfemoral approach, in spite of sizing up the device, and when the especially posterior and inferior rims are deficient, inferior caval rim is deficient, probably we can try and approach through the transjugular.
Absolutely. We have, see, the problem is, if you look at the lie of the interatrial septum with the transjugular, I think it is far more difficult to close from the jugular than from the femoral, because in the femoral, the natural lie is towards the left atrium. So here it's almost perpendicular, so only a small or moderate. I have not closed many, but I have closed half a dozen defects using the transjugular approach. And all those defects were moderate sized defects. But my concern is that if you have a large hole, probably the disc will come almost perpendicular and we will have no scope of using all these alternative techniques through a transjugular approach. So I have a little bit of reservation. The other thing is we can use a transhepatic approach. But we have not used transhepatic approach so far in any of the ASDs. And sometimes I ask myself that rather than doing this, especially in large ASDs, why not send them for surgery? Surgery is still an option, it's a very safe option, and it's a very time-tested option. So I think that even as an interventionist, you have to keep it in mind that surgery still exists. You know, it's not extinct. So I think you must know when to stop in interventions, that I will go this far and no further. Because the more you will try to explore, I'm sure you will burn your fingers. So I think it is better to be safe than sorry, and that's why many times we have backed out. I'm not saying we did not have complications, definitely we had. But I think as you age, probably, you know, your appetite to explore these newer things is a little difficult. The level of adrenaline comes down, and that's why some of my patients, I send them to surgery de novo, or sometimes I accept failure. I prefer to fail rather than face a complication, say that I couldn't do it.
I think that's a great wisdom with experience. Transjugular approach has got role, but most of the times either you said that either inferior pulmonary vein or left ventricle, you have to go the sheath. And the positioning in the presence of deficit trims is going to be quite challenging. So therefore, transhepatic approach is superior. Lot of interventions are being done in transhepatic approach. We published also some couple of case series in the past, many years back. So in transhepatic approach, the septum is aligned. It's much easier than the transfemoral approach because your disc is going to be aligned, even deficit trims also. So I think it's a great talk, but my question to you, when you have multiple defects, how to choose whether it is a cribriform, because many people they ask cribriform versus a regular septal occluder or combination of the devices, or you are going to catch the one of the smaller versus bigger versus smaller, these things. Maybe one comment you can give, then we can.
Sure. So as I said, Nageshwar, our policy is that I will balloon interrogate through that fenestration. If I'm able to squash the entire aneurysm and all the defects, I will go with amplifier septal occluder. If I'm just not able to cross, the fenestrations appear quite small, then I would not even think of doing anything but use cribriform, either a single device or multiple cribriform device. So we have used all combinations, single cribriform, multiple cribriform, ASO with cribriform, and ASO alone. I'm sorry, last few slides did not come up well. I don't know what was the reason, but all four combinations can be used with a basic principle of crossing the defect with a pigtail catheter.
Multiple ASTs and total septal length. So when you are choosing multiple ASTs, regarding the total IAS septal length, how do you consider it?
Absolutely, great question. So if you look at the data that we presented in the Annals of Pediatric Cardiology, usually our formula is like this, that we will use somewhere more than 150% and less than 200% of the fenestrated septal length. Fenestrated septal length is defined as the length between the two extreme fenestrations in all three views, 0 degrees, 40 degrees and 90 degrees, means 4-chamber bicaval and short axis. Now we measure total septal length again in all these three views, and we will choose a device which is a multi-fenestrated device or a cribriform device which will have the size which is more than 150% of the fenestrated septal length but less than the total septal length. But if we feel that there is a lot of aneurysmal tissue and we have to really exceed, go to 200%, and if that 200% is more than the total septal length, we will not shy away from using 200%. Because what we have seen in post-procedural CT scans, that these devices have an ability to adapt themselves to the plane of the interatrial septum. Remember one thing, interatrial septum is not a structure like this. It has a third dimension. And if you look at the CT scans of these patients, you will see how beautifully these devices can adapt themselves to the plane of the interatrial septum. What we measure on echo is the shortest distance, which is not the true interatrial septal length. So we would go ahead and still do it, even if it is more than total septal length.
Thank you, sir.
Thank you very much, sir.
Interventions, complications bound to happen, and there is no unit is exception to that. But we should be little bit avoid what was to your basics. We have to say normal imaging we have to see, and then we have to see whether it is suitable or not, and we have to expect the complication, then we are able to treat that. So this is like one thing I always tell, कि whenever we are thinking कि we are doing excellently great and we are doing very good, at that point only one complication will happen with the simplest procedure. So that's what that gives you the, whenever we'll do more, success gives us arrogance, but the complication always keep us grounded, so that whenever is there, we have to understand कि we have to stick to our basics and we have to do follow the all steps properly. So there are general complications, puncture related, T related, intubation, no proper hydration is one of the very important factor when the chance of embolization is very high, and poor case selection, ignoring the echo findings, very important. ECG assessment, Bhargavi also told, sir also told, X-ray finding done in presence of anemia sometimes that will cause, and if you not preserve blood and if you cause some damage, you are in the big trouble, and that cause, it happened to us once. So what are the device related complications? Heart block, perforation, pulmonary vein stenosis, IVC stenosis, erosion or embolism. And again, these are the very common which applies to so many of the cath lab who are taking in odd hours, no surgeon backup, or no help available, no proper hydration causing risk of embolization, sheath device mismatch, we don't have the proper sheath, improper hardware in not our cath lab, without intubation. But because this vary, but in our lab, 90% time in most of the cases, small, we are doing intubation and doing the procedure. So these are the one paper that shows the early complications all. Out of that, the embolization is 3.5%, embolization is arrhythmia is 2.5%, minor complication including the vascular injury is 6.1%. So younger age, larger device, more inclined to do intervention without need or urgency is also because recently one of the circulated paper where they shows out of the all interventions all over the world, 15% are unindicated. So we have to see when to intervene, when not to intervene, that we have to be there. This is like what Bhargavi showed, this is one ASD come to us for device closure, but when we saw the ECGs are prolonged 200 PR interval, that means very high risk for device closure, we should not attempt. This is one case, 6-year-old large ASD, posterior inferior defect taken for ASD device closure, T guidance. Okay, so this is there. So what happened after device we did? See, this is very huge device, almost 24 mm, and then we found out there is a heart block development. So once the heart block is developed, then we have to decide what to do. That we cannot give one new disease for a simple disease. So we have to back out. So we backed out in all the cases where even we had type 2 or any heart block also, and we sent for surgeon, we'll try to give steroids to revert. But we'll never go ahead to continue doing the procedure. So this is one of the things we have to check. This is another case, 13-year-old T evaluation, large defect, and you can see, it looks like deviceable, but see, the disc is hinging over the back. And this patient, after 24 hours, developed the large pericardial collection, and we have to take in the OT and remove the device. And you can see this device is exactly hinging into the LA wall. So such devices, even it looks simple, but when the next day complication happens, then we saw retrospective, we found out that because this is hinging over that and this is causing the perforation. So this we have to think. Now the first step, this is one very common when the anesthetists come to us and they give, and we found there is a desaturation. This is first case, lung collapse after intubation, patient got desaturated, bradycardia. We found out the tube was inadvertently onto the right side to causing a left lung collapse. We did the pulling up of the tube, did the suction, and we found out the patient okay. Then we went ahead with the device closer. Again, this is one case, 2.5-year chest deformity, weight is 9 kg. You can see the first, it looks okay, but very difficulty the sheath went. So we did the device, but when we realized that luckily we saved ourselves, you can see the vein is very small and there is a very spasm is there. So somehow if we try to manipulate more or we are not able to deploy properly at first go, we can damage the vessel. So sometimes this is one ASD we took, there is a duplication and there is a very severe spasm of the IVC. So we not able, we did after 1 month after doing the proper hydration, we again checked and after that we did. So these are the normal evaluation or we have to do with the venous anatomy when we are doing the smaller cases. In the same way you can see, this is the one case we took, both sides there is no proper lumen and it's all filling through the paravenous plexus. So for this we did the IJV and then we successfully, but once we made a protocol after that, any small kid you are taking less than 15 kg, give at least the venous injection from the sheath, so at least any abnormality will come to know and you can decide your approach as well as your procedure better to avoid complication. So now this is one perforation, oversize, excessive manipulation, pulmonary vein. See, this is one of the 28-year-old excessive manipulation by us. You can see what sir was telling, sometimes without wire we are trying to push. We accept sometimes we did in hurry, that is the mistake, we should not be in hurry. So I am accepting sometimes we did excessive manipulation, we able to do the device, but after the 4 hours this adult developed the hypotension, we found out there is a rupture in the RA and then we have to send for the surgery. So excessive manipulation without wire, just with the device and the sheath also is causing one of the complications. That is one of the reason for the complication. So here we found out the same complication, although we able to manage and she survived, otherwise it will be big trouble. So this is the torus, what already Bhargavi told. Torus is the elevated structure which is the more responsible for the erosion because the disc is playing over that. So this I won't go. Sometimes we found out we are unable to unscrew the device. Sometimes the sheath flaring is there. Sometimes cable causing the perforation if we are not able to pull the cable. Tearing of the floppy. One patient we found out that floppy patient totally tear out. What the device was 20 mm not turned out to be the 34 mm in a 20 year. So we understood that while doing that, so we accepted that we tear the septum and we send for the surgery at that point. So this is one you can see, this is one we are doing the unbraided sheath. The telescoping is very common, so we are unable to deploy. Once we are pulling that disc got telescope. So disc telescoping of the sheath is very common in the performance check flow sheath when you are doing the unbraided sheath and when you are pulling the device, we are unable to put on the first go. So other air embolism, this is one example, 18-year-old, you can see what happened. After device closure, suddenly the air which is unlocked in the sheath, luckily after device deployment it happened, so it's on the RA side, so you can see it's totally occluding the MPA. So the child suddenly become hypertension. So what we did, we have to take care. We did the oxygen, and then we try to break with the catheter. So this complication because of the large air embolism and this our initial cases where we used to intubate. So that's why we made a policy for all cases we started because as soon as deployed, they took a deep breath, inspirated, and that sucked the air what is locked in the sheath also. And after breaking that, it becomes okay. So this you can see, these are the common complications which everyone may face. It's a properly a non-hydrated well, not intubated, and that checking in the last 8 hours, these are causing the complication. So this is the one case. You can see this is very important. We thought everything is okay. See, with the 7-year-old, 22 kg TE, we did this, we deployed but we saw again the PA pressures are very high. Why? We took the fluoro. You can see the left lung is totally collapsed, right lung is totally collapsed. So what we do, we thought why it happened. So we did the suction, we did the intubation, everything happened, but it's still not happening. Then we realized this is a 22 kg and we put an adult TE tube. So once we pull the TE tube, you can see this is the TE probe. So once we pull the TE probe, automatically everything settles. So here comes again the star. This TE probe adult is only beyond the 25 to 30 kg. This is a 21 kg child. We put a large TE, it's compressing the bronchus. So as soon as we pull the TE probe, that automatically the bronchial compression disappears. So sometimes these things also may happen. We have to be very careful. That's why the recommendation. Then we did the just little contra, so that we are not causing perforation. That is not causing. But we realized just we pull the TE probe as well as everything compression relief. So this weight 23 kg adult to this is tightly fitting and causing the compression. That's why these are the recommendation. Less than 25, don't put any adult TE probe. That is causing more chances of complications and the manipulation. So that is the one lesson from that. So again, 45-year-old successful device closure. After device closure, suddenly there is a heavy bleeding from the mouth. Anyone? You can see. We not keep, but there is a denture which is a loose teeth which comes out, and we come out of the socket and causing the heavy bleeding from the mouth, and that we gave the heparin, so there is a large bleeding. So that's what these things we have to check. We thought there is a loose tooth, but it was not obvious loose tooth, but with the manipulation of the catheter and with the manipulation of the TE probe, not catheter, with the TE probe, the teeth got dislodged and got into the abdomen. So you can see these are the complications we have to expect, and we have to be very cautious about that, otherwise it will cause the major problem. So this is the teeth into the stomach. And see, this is what we did. When we are doing this, we have to understood the device profile on the frontal is like this. You will not see the waist. Once you started seeing the waist in a frontal, that means what you deployed is not across the defect. That means you are across some of the defect and it's prolapsed to that. Some of that we found with this patient, 4-year-old, 13 kg, with the 13 device with adequate rims, but they're not checked. They're done somewhere outside and come with the pH. They realize there's a severe compression of the pulmonary vein and causing the pulmonary vein hypoplasia. So sometimes when we are doing the device, we have to release, before releasing, we have to make sure that there is not causing a pulmonary vein obstruction also, otherwise that is also causing the problem over the long term. So we are closing the simple thing, but we are creating major problem. So we have to be very, so lace displacement, this is post-ASD closure, continuous coming for 2 years for the chest pain. Anyone, this is when I started writing book, I realized the retrospective diagnosis after 2 years after seeing the X-ray which we missed. It's a typical absent pericardium, see we did. But the child was completely having chest pain. Because of the absent pericardium, the excessive movement and having the chest pain. So we thought initially it's a coronary problem, we did angiogram, we did CT, we didn't find out any problem. So what we not looked after that, there's a right border abscences, then the Snoopy sign. That is already present from the beginning, but we not looked after. So we have to see the basic ECG, basic X-ray, basic evaluation of the echo, all are very important in considering the ASD to avoid complication. There's a complication, one, we floppy rim, but it got embolized, then we have to send for the surgery. We were unable to capture from the RVOT because that is an RVOT. Second, I got it from Neeraj. See, this is one RA, 30 implants the device retrieved with a 12 mm sheath and the snare. So sometimes embolization happen, but that is the most common cause is our inadequate assessment, and inadequate assessment that is causing the embolization. Another thing, what sir already told, when it's a malalignment, this is the paper that shows that when the both septum are malaligned, septum and private, then you have got the more chances of erosion. So this malaligned septum, you have to be very careful while doing that, because although you may able to do, but over the long term it will cause the erosion. So this is, you can see sometimes possible perforation erosion site. I showed for first echo I showed where it caused the perforation because it's touching the posterior wall of the LA. Here sometimes it caused even the perforation of the near the SVC, because that area sometimes it caused the tear and causing the perforation. This is the first, that same, you can say it's touching the LA and causing the perforation. This is the first case. And here the septum, you can see the alignment of the septum as well as the device is totally different. So this is more chances of causing the erosion as well as the complication risk. So this again, although I not encountered, that is the known complication over the long term of the erosion. So this is the heart block, large ASD size, young size, diameter to septal diameter we are taking more, and then these are more chances of heart block. This is 3-year-old ASD device with 80 LifeTech occluder. You can see after again it developed the heart block. So again, once you are doing, you have to understand the mitral rim, you have to understand the all rims assessment, and then you have to go. Excessive Minnesota wiggling also will cause the tear of the septum, and there will the edema of the septum. Some of the surgeon told when we cause the heart block and come out, they told there was an edema at the near coast triangle, near the tricuspid wall, that is causing the heart block. So sometimes you have to be very careful in excessive manipulation and the wiggling also. So 6 years old underwent device closure using 22 sheath, some resistance, and you can see. But although we able to do, but when we thought why there is a little bit resistance, so then we did this. You can see this is a total tear of the IVC. So we accepted because it went, but there was one jerk was there. But although sheath was going, there was no fall in BP. We did the device, but we thought why there was a jerk, although we missed any IVC abnormality we saw, and it's caused the IVC tear. We manage with the aggressive fluid and inotrope, everything. But over the long term, I give another disease to the patient. So I am feeling guilty. Why? When there is a still little resistance, we push, we should not push. So that is the simple what sir told, you have to follow to your basics. Don't push when there is even slight resistance. So this is causing, you can see that now she's coming for the 2 years follow-up. We took the vascular surgeon over there, they told there is a flap, you can see in the IVC. There is a limb, there is no problem, but this flap at present is no flow restriction, no flow to the IVC, but this I give the long term. So even with that improper assessment, little bit of your negligence will cause a life and death thing to occur, so we have to be careful for that. So this is now last too many cooks say, sometimes the soup, 9-year-old diagnosed of ASD, 23 kg. The simple ASD we thought it will be able to close. But as usual, once you thought, I told you, once you thought ki you are doing very good, at that time even simple thing will close. See, this is the device. Even you think this device position is okay? No, if you see this device, normally septum will be from the T5 to T7 as I showed. It's more horizontal, but I thought there is no waist seen, it's already hold on very well, so I came out and I deployed the device. Then, see, this is the usual orientation of the septum we have to understand. And then we saw here, you can see, the device missed the lower rim. But because somehow it's hanging on the upper rim, then it is causing the mitral valve restriction. So what to do, it's like a cliffhanger, what to do. So what we have to do, we tell surgeon to be on ready, by that time we thought we'll try. So we did the retrieval attempt and we finally able to do the gooseneck snare. Again, the problem same. We are unable to acquire in that stress all image acquisition. But again, we able to pull into the sheath, but we are unable to take fully into the sheath. What you do? Again, it's the same telescoping of the sheath happened and then we are unable to. What happened once we are in doing this commotion? The device get out of the sheath and total iliac vein got obstructed. So what to do? So then here, injection from the left femoral vein we injected, we took the help of the vascular surgeon and we thought we'll again take a second puncture from that side and try to snare. And then again we sheath aligned to the device and we screwed again with the same. Luckily we got the sheath on the left side where it got embolized and then we able to screw the well. But what I told in that, suppose you have one step you miss, like the proper assessment, you will get into the trouble. So that's what you should not be in hurry. You should take help of your colleagues. You should be around everyone. Somebody should do echo. You also be assessment and then you have to do, you should not be. So this final injection, after that we went ahead and we did the device closure properly. So this is the final echo. So issues here, we taken without surgical backup in the night, but surgeon will take, by the time we'll try to do. Overconfident, sometime or improper assessment will definitely lead you into the trouble. Unbraided sheath, when such things you are taking, always try to use the braided sheath. That is always given advantage over the unbraided sheath. Lost access here, but we at least we able to access again, we'll screwed again. Other complication, what we saw during that, maybe the ectopics is sometimes SVT, which is causing unstabilizing the device. You have to maintain that. CAG we have to do always, do the coronary assessment. One patient we not able to take, but once we are doing it causing the ischemia, and then we found out there is a RCS coming from the LC and that is the groove which is causing the compression. So that is also common. Respect rims, eustachian valve sometimes cause problem. SVC stenosis, once it's the anterosuperior, sometimes will cause problem. Pericardial effusion, whenever is there, or it gets little bit more as compared to your baseline, you should always be worried you are causing some trouble. Or puncture site, when everything went all right, suppose you are not able to make the hemostasis better, again you will lose the patient causing the retroperitoneal hematoma. So these are the expert panel recommendation from the AGA, what we have to do, avoid unnecessary to and fro movement. So message, we have to plan meticulously to avoid complication, stick to our basics, don't be in hurry. And sometimes we accept, we all sometimes make mistake in hurry, okay, it's a simple, we'll do, but never think any simple is not simple, because you can make it complicated if you are not vigilant enough to make it happen. So preparation and pre-op assessment, always know your limits, what you can do and what you have to help with take the help of your colleagues. So you have to believe in yourself, as well as I always understand that you have to build in a team, because always when you are in team, you are able to get a good. So good team is always to be success, because we are all bound to make mistakes. But when it's a team, it's a combined responsibility and you can able to produce very good results. Thanks a lot and sorry for exceeding time.
Thank you, Sudeep. That's a great presentation, including a variety of a spectrum of complications which we have seen. One quick comment I'll give you. Whenever you are doing an atrial septal defect, make sure that the hydration is very good, and child or patient should be taken first in the cath lab. We always measure the right atrial mean pressure to see the hydration status of the child. If you are doing a large defect, under transesophageal echocardiogram, we prefer to do intubation anesthesia so that your air embolism will be reduced. To prevent air embolism, a good hydration, intubation anesthesia, and put the sheath snugly in the pulmonary vein so that your air embolism during the procedure will be minimized, I won't say, and make sure that a check valve should be very good. Several times people tend to use the old sheaths of Cook's Mullens, even though check valve is there, it doesn't work. Whereas the Amplager sheath is from Russia, whereas device is from America. This is the one of the medical area where Russia and America is collaboratively still working on that. So when you are retrieving the device, braided sheath is better to avoid the telescoping rather than a non-braided sheath. These are my quick comments. Maybe I'll pass to Bharadwali sir.
Thank you, sir. I'll just make general comments. So my first comment is that in interventions, never let your guard down. Do every case as if it is your first case. Otherwise, what happens after doing 100, 200, 300 cases, you think that it's a slam dunk. The day you think that it's a slam dunk, nature is there to put you on the ground. So you have to be very, very careful. I always look at interventions like driving. When you start driving, you look left, you look right. Then once you get hang of it, then you want to go till such time you crash. So I don't want you to crash. You have to be very, very careful in every intervention. There is nothing like a slam dunk in interventions.
For example, what's the technique? One is how to exchange this braided sheet. When we have already the device is there and it's not coming out, how do we get out the braided sheet?
So there are two ways of getting the sheath out. One is that there is a sheath which was made by AGA or now Abbott, which is called the bailout sheath. Now, bailout sheath has a dilator which can accommodate the loading cable of the device, and you can go over the loading cable. What we did actually is that we made bailout sheath in our lab before bailout sheath was manufactured by Abbott. Way back, 20 years back maybe, we came across this. We were not able to slenderize the device which was in RA. So we brought back the unbraided sheath. Then we cut the 12 French sheath obliquely. Once you cut the 12 French sheath obliquely, it has a very big diameter. It can take the loading cable. And then you extend the loading cable by screwing the male end to the female end. So you have a long loading cable. You take another cable. And where you actually screw the device, you screw the loading cable backside with this. There is a male-female end. So you extend the loading cable, cut the dilator obliquely, and you can then exchange the 12 French sheath and recapture the device.
But this Abbott has got the
Yes, they have a bailout sheath. I don't know whether they still have it, but they used to have it. I'm very sure about it. But we did this even before Abbott had the sheath, just by common sense.
Sir, I have one closure if there is IVC rim is deficient. IVC rim is deficient.
Yeah. See, I'll tell you very frankly that when in doubt, when I have any doubt in my mind, nowadays I don't do it. I tell them that you go for. And remember one thing, that whenever the device is fully deployed, look at the lowermost part. If you see in the lowermost part, both the discs are close together and there is a flow around the discs. Rest assured that this device will embolize no matter how good it looks fluoroscopically, how good it looks transesophageally. So if first I will not do it, but if I do it, then I will look at this portion towards the IVC for the two discs, how close they are, and whether I can see a flow around the disc, not through the disc, not foaming, around the disc. That is the time. As a matter of fact, just last week, we abandoned one patient like this, a large defect, but there was a flow around. We said, no, we want to recapture and send him for surgery. So when in doubt, please don't. Send them for surgery.
It took long time for her to recover. So once they are stressed, better when we are doing the TE manipulation, better to intubate and do, that will decrease the stress. That will also one of the point, because recently she deteriorated with very low pressure, somehow with the IABP and all she improved. But suppose not improved, then you may not able to forgive yourself with just you did the T, ASD and she developed the stress cardiomyopathy. We have to make the patient as comfortable as possible.
No, is the diagnostic T or T on the table during the procedure?
No, sir. We did the procedure. After that, 4 or 5 hours, she developed low BP. Then we found out that there is a LV dysfunction which was not there, because we checked the PA pressure, LV, EDP, everything was okay. Then when we did over that MRI and when we thought it's like a stress cardiomyopathy, she had got history also before other. So then we thought, okay, we did the TB, not asked that properly before whether she had before during the pregnancy. So again she developed the low BP, and then luckily she improved, but otherwise if you not improve, then with that stress and that serotonin surge, we have to make sure the patient should be comfortable when we are doing so.
What I would like to know from the expert is transthoracic versus transesophageal intra-procedure guidance. When do you suggest a transthoracic, or you want to do with all the cases and transesophageal?
Moderate atrial septal defect with adequate rims in a child where good windows are there, transthoracic alone is sufficient. Whereas adult with no windows, a large defect with deficient rims, we prefer to do transesophageal echocardiogram.
So in my practice, although I completely agree with what Nageshwar does, in my practice it is 100% transesophageal and 100% general anesthesia. 100% absolutely. Everybody gets general anesthesia, everybody gets transesophageal.
I think probably defects approaching 30 or more transesophageal, I think it's a must. Or we have to, when you are deploying a larger defects, transesophageal, definitely it should be there. Smaller defects, I think you can get away with in transthoracic also.
I think we will close this session and break for the tea, coffee. Next session. Thank you. Thank you very much, all panelists and speakers.
I thank chairpersons and moderators for their valuable insights. Now I request Dr. B. Srinivas sir to present some mementos to chairpersons. I request Dalvi sir. I request Sai Sati sir to. I request Sudeep sir to. I request Bhargavi ma'am to receive. Anita ma'am, Amitabh sir and Srinivas sir.
Very good afternoon to one and all. So without spending much time, we'll get into the next session, which is on transcatheter closure of ventricular septal defects. So the first talk here is on the relevant anatomy and echo assessment by Dr. Usha. So I'm inviting her for the first talk. Dr. Usha is an associate professor in pediatric cardiology at Jayadeva, and she's one of the well-known senior pediatric and as well as interventional cardiologists in the country. Over to Dr. Usha.
Good afternoon, everyone. I thank Dr. Srinivas. Sir, thank you for this opportunity. After roller coaster presentation of Dr. Sudeep, mine is a simple and calming presentation. Today, let's discuss clinical and echo assessment of VSD for device closure in this session. I feel that VSD device closure is a precision art. So when you do assessment, echo assessment for a VSD device closure, you should have the same concentration and focus as Tom Cruise is having here in this Mission Impossible. The assessment should be under the following headings. It should be initially regarding the morphoanatomy of VSD, clinical grading of VSD, echo anatomy of VSD, suitability for device closure, and intra and post-procedure evaluation. And once you decide management of VSD broadly, if it is a large VSD, obviously surgery is the management of choice. Moderate VSDs are suitable, can be suitable for device closure, and usually we wait up till 4 years of age, that is to give chance for a natural closure of VSD in case the baby is asymptomatic. If it is symptomatic, you can consider earlier. And small VSDs as such, in broad category, there is no indication for closure and it needs follow-up. So all of you know this classification of VSD, I am just reinforcing. You have perimembranous and muscular VSDs, inlet, outlet and muscular VSD. So this is the outlet VSD which lies just beneath the pulmonary valve. Here is the inlet VSD which lies behind the septal leaflet of the tricuspid valve. You have posterior muscular, mid-muscular and anterior muscular VSDs. So basically membranous defects are the ones which are most commonly suited for device closure, and also muscular VSDs which KNR sir will focus upon. So when you start evaluation of a VSD, obviously the first thing is to evaluate clinically. So what is the aim of the clinical assessment of VSD? Aim of the clinical assessment is to determine the significance of the shunting. So how much is the QP/QS, what we talk about? What is the ratio of the pulmonary flow to the systemic flow, and whether it is significant clinically? So how do you estimate that? If you find a child has failure to thrive, if you find child has hyperdynamic precordium and cardiomegaly, then it's a definite indication that the pulmonary flow is significant. If there is a presence of a thrill, always what I have noticed is if there is a thrill, then it means that the VSD is significant. It is a significant shunt. Presence of loud P2 also says that there is possible hyperkinetic pulmonary hypertension, and a loud murmur, thrill indicates grade 4 murmur. And if you hear a mid-diastolic flow murmur at the apex, then that's obvious there is a lot of flow going through the mitral valve because of the increased QP. So if you have a MDM with a pansystolic murmur, it's a large VS, it's a moderate or a significant shunt. And very large VSDs obviously will have early systolic murmurs rather than pansystolic murmurs. And muscular VSDs also have a early systolic murmur. If you have a soft or a short murmur with a normal P2, then it is a small VSD and device closure is not indicated. Chest X-ray can show cardiomegaly with or without some plethora in a moderate VSD. ECG may not be contributory in a moderate VSD. A large VSD, we all know, will show biventricular hypertrophy with equiphasic RS complexes in midprecordial leads. Always note, before you embark on VSD device closure, look at the duration of QRS, look at the axis, and make sure that no changes happen after the procedure. This is with regard to the clinical assessment. Going on to the echo assessment, You should assess under these following headings. As I said, first assess for the shunt and make sure that the patient needs VSD closure. So how do you assess? Indirectly by looking at the LALV size and the VSD gradient. Look at the location of the VSD, as we already discussed anatomically. Echo-wise, you should decide whether it's perimembranous, inlet, outlet, mid, anterior or posterior muscular or apical. So in a short axis view, if you have a VSD between 10 o'clock to 12 o'clock position, it's a perimembranous VSD. Between 12 to 2 o'clock, it's an outflow VSD. Between 9 to 10 o'clock, there's an inlet extension to the VSD. And you look at the muscular VSDs. If you see the VSD in the 4-chamber view, then it's an inlet VSD. If you see the VSD when the aorta opens up in the 5-chamber view, then it's a perimembranous. And with extreme anterior tilt, it's an outlet VSD. And look for the rims and the surrounding tissues to assess suitability for device closure. Look at the aortic valve, look at presence of AR, look at the tricuspid valve, presence of tricuspid regurgitation. Look for associated lesions like additional VSDs, mitral valve abnormalities, assess for coarctation, presence of any RVOT obstruction as a natural history of VSD, presence of PDA or a subaortic membrane. So assessment of PA pressure is also important. How do you assess PA pressure in a patient with VSD? VSD gradient or a TR jet gradient or a PR gradient. So here you can see a 4-chamber view. There is obvious LALV dilatation. And one simple way eyeballing is to take a long axis view, compare the aortic size to the LA size. If the aortic size is more than 1.5 times the LA size, then definitely there is significant shunt. Here you can see the VSD gradient is around 46 millimeters of mercury. So what do you think is the PA pressure in this child? Let's say this is a 5-year-old child. What will be the PA pressure if the VSD gradient is 46? So let's say the systemic pressure for this child is 100 millimeters of mercury. So what do you think is the PA pressure? So you subtract the VSD gradient. So VSD gradient is the pressure difference between left ventricle and the right ventricle. So if you have a systemic pressure of 100, then the left ventricle pressure is 100. Okay. So and the VSD gradient is 46 means then the RV pressure is almost around 56. So it's a moderate VSD. The PA pressure is anywhere between 50 to 70% of the systemic pressure. So VSD gradient, so always don't say there is no TR, I cannot measure the PA pressure, or there is no PR, PA pressure cannot be measured. VSD gradient gives you a clue to the PA pressure. So this is a moderate size VSD. Next, assess the view in which the VSD is best seen. This also helps you to decide which angulation you have to take for an angiogram. Suppose you see the VSD in the apical 5-chamber view, that is the perimembranous VSD. This VSD is best seen in LAO 60, steep LAO with cranial angulation because it's a perimembranous VSD. If you find that there's a VSD has an inlet location, when you do 4-chamber view, you are seeing near the tricuspid valve, such VSDs are better seen with shallow LAO with a LAO of 40 and a cranial of 30 or even lesser cranial. And if you have an anterior muscular VSDs, then plaque, which you see in a plaques outflow view, that is you take a plaques view and you give an anterior tilt and you see the VSD, then such VSDs are better seen in RAO view and not LAO views as we usually use for perimembranous VSDs. So once you decide that it's a perimembranous VSD and you have to assess next for suitability of rims. So how do you assess? Most of the devices which we use have a 2 millimeter retention skirt. So when you put the device, you don't want the device to touch the aortic valve. So ensure that there is at least 2 millimeter distance to the aortic leaflet when you put the device. So measure and always remember, don't imagine VSD or ASD in 2-dimensional planes. It is a 3-dimensional structure and they are not perfect circles. So just because you measure in one plane, that's not the final size of the defect. Always measure at least in 2 perpendicular planes. So measure in 5-chamber, measure in short axis and get the final size of the VSD, whichever is the largest. Once you decide on the size of the VSD, most of the times we upsize only by 2 millimeters and not more than that. Next, assess for the presence of an aneurysm. Why is an aneurysm important? Aneurysm can be very beneficial, can be very helpful. So if there is a sturdy aneurysm and if you can do a deployment inside the aneurysm, most important advantage is you can spare the conduction system, okay? And you can choose a device which is little smaller than the actual defect on the LV side. And also assess the aneurysm for the number of openings present. Sometimes aneurysm can have multiple fenestration, and when you cross, if you go through one of the smaller fenestrations, your sheath or the guide catheter may not track through that fenestration. Or if you close one of the fenestration, you may have a residual VSD which is opening in the aneurysm in a different location or a different site. Decide, like I said, between intra-aneurysmal versus a septal deployment. Look for a inlet extension which can also lead to the presence of a LVRA shunt. So here you can see this VSD has a very good aneurysm. The aneurysmal tissue is thick, is sturdy. And if you put the device inside the aneurysm will support the device. The aneurysm tissue will not come out when you do a intra-aneurysmal deployment. And here, when you do the intra-aneurysmal deployment, your aortic valve will not be touched by the device. So you are safe. You are safe from conduction system point of view. You are safe from the aortic valve point of view. Look at this aneurysm. Here is a VSD which is actually significantly large on LV side, but there is a very beautiful aneurysm which has formed. But if you see carefully, there are multiple openings to this aneurysm. And this child also had a moderate ASD. So what happened when we put the initial device? We noticed that aneurysm, but each hole was small. We couldn't put a single device to cover all the aneurysms. So when we closed one device, there was another opening which had a significant shunt. So we had to put 2 ADO2s to cover 2 different openings in the aneurysm, and we had to put a ASD device also for this child. So assess the aneurysm in terms of number of openings and see in different views for the aneurysm opening. Like I said, distance from the aortic valve, here you can see a very good distance from the aortic valve. Such VSDs are safer to close with regard to occurrence of AR or aortic cusp prolapse. And if you have an inlet extension, that is, you see when you, in the inlet view also, you should be careful while selecting the device, because if you have an inlet extension, you can see the tricuspid valve chordae, which is closer to the VSD. And if you choose a double disc device, you can entrap the tricuspid valve chordae. You may close the VSD, but you may end up with a significant TR. So if you have an inlet extension to the VSD, better to choose single disc devices. And while measuring the distance from aortic valve, always PLAX view always gives the feeling that the VSD is very close to the aortic valve. So it's best to measure in a 5-chamber view to look for the distance from the aortic valve. This was another VSD. Again, there is a good septal aneurysm. It is a restrictive VSD, but when you actually see in 5-chamber view, I am not sure whether it is clear, the RCC is very close to the VSD. So there is a septal aneurysm, it is a restrictive VSD, but the RCC is so close, if you attempt a device closure, if you can see here in the short axis view, it is extending to the inlet septum and it is there in the commissure between the left and non-coronary cusp also. This VSD definitely will have an interference with the aortic cusp when you put a device for this. And always, a presence of an AR, a significant AR, is a definite no for device closure of VSD. Because all such ARs will happen. You can see the eccentric AR here. Eccentric AR is because there is a VSD here. The RCC has moved away towards the VSD. It is trying to close the VSD, and that has caused the defect in the coaptation, which is leading to the eccentric AR. So such RCC prolapse are not suitable for device closure. And some of these VSDs, once RCC prolapse, sorry, I don't know, it's not playing. Once RCC prolapse develops, some of them also develop subaortic membrane. Can you see in this, here, the subaortic membrane is visible. There is a significant RCC prolapse. You're just going to worsen all these problems by attempting a device closure in such patients. So assess for subaortic membrane and assess for significant RCC prolapse. RCC prolapse can be assessed both in 5-chamber as well as in short axis view, where you can see the prolapse cusp which thickens and it tends to remain near the aortic margin as compared to other cusps. So what do you see here? So this is a VST, perimembranous VST, there is a septal aneurysm and there is an inlet extension, but there is severe TR. So what do you think this TR is due to? It's a gerboard, okay? It's an indirect gerboard. And this gerboard should disappear. If it is a gerboard, as per our assessment, this should disappear completely when you put the device, okay? If it is persisting, then probably there is some other primary TR or you have not closed the defect completely. Again, such VSTs using 2 discs sometimes can result in significant TR because of the entrapment of the tricuspid valve chordae. And don't measure, if you measure the TR jet, you will get systemic pressure, so that is not the PA pressure. Look at the color flow, there is lot of turbulent flow. It is a restrictive VST with subsystemic PA pressures. So though you get high TR jet gradients, it is because of LVRA shunt and it is not because of pulmonary hypertension. And VSD, long-standing VSD in older children, you can find this hypertrophy of the right ventricular outflow tract. Can you notice here there is some muscle bundle thickening? So this RVOT obstruction, if it is mild, we tend to go ahead and close the VSD because it does usually halt the progression. It will not regress, but it can halt the progression. But if it is significant, then it's better sent for surgery than doing a device closure. Subpulmonic VSDs are very close to the aortic valve. Doing a device closure can affect the aortic cusp and can lead to AR, and as such they are not indications for device closures. Again, muscular VSD, Nageshwar Rao sir will talk in detail. When you assess a muscular VSD, you should assess in relation to the moderator band. Splitting of the VSD, you can have multiple tracks on RV side, though you see a single defect on the LV side. And those very close to the apex may not have a supporting rim. Accurate localization is important to choose the axis based on the location. Anterior and mid-muscular can be closed through femoral veins, but when you take posterior muscular and apical VSD, jugular axis is must, otherwise sheath will not track and you will not be able to close the VSD. So this was a patient who had come with actually, can anyone guess, this was an acquired VSD in a 12-year-old. This is a classic location of a post-traumatic VSD. This boy had an accident in a two-wheeler and developed failure symptoms after 15 days. This boy had a VSD which had occurred following blunt chest trauma. So this is the typical location, and this VSD, though moderate to large, could be closed by a device because of adequate rims. And apical VSDs, when extending this here, it appears as if it's devisable, but when seen in short axis, there are almost no rims. So always assess in 2 planes before deciding on device closure. Intra-procedure echo can help in device placement. So here it is seen, you can see the device being brought closer to the septum. Once you decide on accurate position of the device, if you are not sure on angio, echo can help you in device placement. Assess AR before release, assess for TR and residual shunt. This was one patient who had RCC prolapse. We put a tenate regular duct occluder, but what happened was it was distorting the aortic cusp. I have not recorded the AR. There was more than mild plus AR. So we removed this device and we actually used an eccentric VSD device. There was little bit of mild AR which was not there, but it was, we accepted this mild AR and went ahead with closure. So before releasing the device, do a thorough assessment with echo. So here it may appear a restrictive VSD, but when you see in 5-chamber view, there is no gap between the, so such VSDs should never be taken up for device closure, and don't try to close small VSDs just because you can do it. Consider device closure in babies only above 7 kgs. Moderate VSDs can be considered for device closure. Thorough clinical assessment and echo evaluation is necessary for planning. Echo helps you in deciding access route. It is necessary for deciding on the type of the device you will choose, the size of the device, the method of crossing. You can decide if there is a large aneurysm, you can't cross from RV side. But if there is no aneurysm, you can attempt crossing from RV side. All this can be planned with an echocardiogram. And make sure you avoid collateral damage when you do device closures. Planning is half the battle won. Thank you.
Nice presentation, ma'am. The echocardiographic evaluation nicely depicted. In one of the, I think in the initial slides, you had shown the aneurysms from different aspects. Like I have one comment, like you have shown one beautiful echocardiogram where the aneurysm is mainly in the inlet septum. Like all the aneurysms which are mainly in the perimeters area and this, they are a little bit stronger, which can actually hold the device if the device is deployed intra-aneurysmally. But inlet aneurysms appear to be a little bit weaker, where the device, even if they hold, they might have some amount of malalignment, and the chance of slipping, the device being slipped, is slightly higher. And also, if it's a garboard defect, sometimes, as you said, when if the device is correctly in place, the whole stream disappears. If not, then we might have to reevaluate whether there are any additional streams or not. Very nicely depicted.
Thank you.
Thank you, Dr. Usha, for that insightful talk on anatomy. So the next talk we invite Dr. Nageshwar Rao for a step-by-step approach and tips and tricks for muscular VSD device closure. He's in home ground and of course doesn't need any introduction. So over to you, sir.
Thank you very much, Dr. Navneet, and thank you, chairpersons. At the outset, I thank the organizers and Nims for this great program. So I'm going to speak on muscular VSD closure step by step and also some of the illustrative cases. You should understand that muscular VSD closure, generally speaking, is in infants and children. Those who are in adults, by and large, they are all small, may not require treatment. That's why you don't see much of the muscular VSD in adults being closed. It is going to be post-MI VSD predominantly. So these are the disclosures. We recently got a US patent apart from Dr. Bharadwali sir. I also got the US patent for this particular device. So what are the difficulties? The case selection itself is difficult to define the location of the ventricular septal defect. Vague terminology like membranomuscular, some people call it as outlet, intraconal, all these things. You should define the proper the location of the VSD. Many devices are available. Which is the device which is matching to the defect? What is the approach? Antegrade, retrograde, AV looping, foramina ovale. How to cross it? Again, standard question, am I going to do under transthoracic echo or transesophageal echocardiogram? Dr. Usha already elaborated all these things, but I want to tell you that it's safer to use the device above 5 kilograms. Whenever there is a severe pulmonary hypertension, probably you should understand the pulmonary vascular resistance before dealing with this problem. So essentially, if you look at the embryology here, the primary septum, trabecular septum, and perimembranous and outflow septum. Wherever it merges, fuses the septum, then you will have the defects. So that's why commonly you will see the mid-muscular or apical muscular, posterior muscular, and sometimes here outlet. Anterior large defects are unusual. Usually those are all Swiss multiple fenestrations, you will see that. Therefore, Soto et al. Classified accordingly, and you see from the right ventricular side, you ask, better thing is you ask your surgical colleague, they will tell that right ventricular side, it is very difficult to identify the VSD because of the complex structure of the trabeculations, papillary muscle, moderator band, and also septal band. These are the things which causes serious issues while deploying the device from the right ventricular side, or understanding the multiple defects, and also sometimes you may produce the tricuspid regurgitation because the papillary muscle sometimes attached to the interventricular septum. So essential points, the mid-muscular, apical, anterior, posterior, whatever it is, you should have definition as already described by a previous speaker in reference to the AV valves and the intracardiac structures. Because if you are going to put a device in the posterior muscular location, mitral valve compromise, mitral valve regurgitation or tricuspid regurgitation may be possible. If you are deploying a moderator, juxta-moderator band device, your RV disc is not going to be deployed at all. So therefore, a thorough echo assessment is important to identify the size, shape, the number, the septal thickness, whenever it is possible. It's a very rare to do the transesophageal echocardiogram unless the poor echo window or adults which you are dealing. But what I prefer is subsified short axis view will give you wonderful idea to take the sizing of the defect as well as the approach. So perimembranous, you all know that the long axis view is the standard. Many of the Asian countries, they do AP, shallow, LAO, cranial and lateral views where biplane is available, but we all work under monoplane. I don't know in Nims, but a long axis view, if there is a muscular, again mid-muscular long axis, anteromuscular, either you go to the dead lateral or steep LAO or RAO view. When there is a posterior muscular, you can do the hepatoclavicular view or so on and so forth. You can see this is a postoperative ventricular septal defect long axis view, whereas here you can see that a situs inversus location, we are doing the RAO for the anteriorly placed outflow VSTs, and this is a case of a PFM coil being deployed here. So these are all various mid-muscular here, and then subsequently you can see the somewhat four-chamber view. So if you look at the blood flows, the right ventricle flow and left ventricle, how the flows are there. Superior and inferior vena cava drain to the right atrium to the right ventricle, and it takes almost 180 degrees to go into outflow tract. Similarly, in the left ventricle side through the mitral valve, it goes to 360 degrees. So therefore, when you have a VST, it's important to see the hemodynamic path so that you can have minimal hemodynamic compromise during the procedure time. Therefore, we actually described that draw a hypothetical line from the posterior to the mid-septum and also to the anterior to the apex. If you have VSTs there, these are the outflow anterior VSTs. Either you can close retrogradely or transfemoral approach. Whereas if you have VSTs close to the apex here, either you can go jugular or you can go through foramina ovale. Again, this is a posterior apical and also a lot of trabecular septum is involved. Jugular approach is preferred in this particular scenario. This is going to be very, very difficult to do either jugular or femoral. So most of these cases generally will go for surgery when there is inlet VST. So you generally tend to avoid the device closures. Always there will be gray zone for all these procedures. So most of the times, general anesthesia in case of a jugular approach or in infants, thoracic echocardiogram and fluoroscopic guidance. Nowadays, we are avoiding the angiogram in a large multiple VSTs because it's meaningless to see the lot of contrast is going from left ventricle to right ventricle. So echo-based and pressure-based deployment is much easier than the angiographic profile. Appropriate sheath selection is important. Earlier, less number of infants were undergoing this procedure because of the large sheaths. Now, smaller sheaths are compatible to the conar multifunctional occluders. So, surgical backup sometimes is needed. So, therefore, we do complex cases whenever surgeon is available. So, these are some of the issues like cannulation with the right coronary catheter or only wire method which we described long time back in perimembranous, similarly in case of muscular. or crossing from the foramina ovale or crossing from the right ventricle from the jugular approach is going to be a discussion point. You should decide based on the type of the ventricular septal defect. So commonly what I described, that arteriovenous looping in case of mid-muscular or post-muscular, LV to RV crossing generally, transjugular approach, retrograde approach in case of anterior, PFO method, probably that this method we are the only people are doing in the world, and sometimes we do hybrid approaches. Variety of devices, muscular, amplatger, radio 1, 2, AVP, cocoon device, and occlutec, coil, and finally this one. So of all, the three devices which are popular are amplatger muscular, ADO2, and then now there are close to 45 papers published on the conar multifunctional occluder. I don't have much experience in the remaining category of the devices. A mid-muscular, again you can do amplatger, ventricular septal occluder, forming the AV lobe, or apical sometimes, as I told you, that moderator band complicate the issue. So AVP2 may be useful sometimes. Some people from UK, they attempted. And posterior or even anterior, small to moderate, ADO2 may be useful in retrograde fashion or transjugular approach. So what is common to all this is multifunctional occluder is feasible to close most of these defects. So this is one of the case. Earlier days we used to do ADO1 even in muscular defect, but I don't prefer generally a single disc device in case of muscular because of the contraction of the interventricular septum, and the stability will be somewhat less. You tend to oversize the device. So the advantage of antegrade, you can use the larger sheaths, you can deploy from the LV, and you will have the hemodynamic control except sheath going across the tricuspid wall. So transjugular approach, you can see this is a classical standard large mid-muscular VST being closed with by the transjugular approach here. I can't imagine any other method in this. If you try to do from retrograde fashion, you have to put a large sheath here in a small child, going to be vascular injury, and also manipulation is going to be difficult to position the sheath from the LV to the right ventricle and then probably to outflow tract. So these are the cases where you do the jugular approach, and you can see a standard jugular approach forming the AV loop. This is the large mid-muscular VST crossed from the left ventricle to the right ventricle, wire positioned in the pulmonary artery, forming the arteriovenous looping. So here what is the problem? It's a large mid-muscular VST. The operator, we were thinking to go through the femoral vein. Now you can see the sheath. If you are positioning, it has to go to the femoral vein, right atrium, right ventricle, crossing this. This kind of loop is going to cause the hemodynamic compromise. So this is not possible. So we backed out, and then subsequently you can see a jugular approach was done, and jugular puncture was taken, and device was deployed here. There is a small additional VST here which we did not do anything. Retrograde method, simple, single catheter, one person can do it, but the major problem is arterial axis. A large, longer sheath may be needed sometimes. Catheter induced AR if it is antemuscular or close to the perimembranous area. So sometimes it's difficult to negotiate through the posterior defects. These are one of the earliest cases using the ADO2 here in a small infant with a heart failure and respiratory tract infection, mid-muscular VST, crossing the VST wire-only method, and positioning the 6 French guide catheter. I really don't remember 6 or 5 French guide catheter, and you can see that ADO2 being deployed here. This is one of our first series in 2011 or so. So successfully closed that. These other advantages are this retrograde method. When you have multiple VSTs, this is the case of double outlet right ventricle, post-PA banding, multiple VSTs, film artist daughter, and we had to close with multiple VSTs here. You can see subsequently child underwent PA debanding, and then the major VST closure, that means routing of the left ventricle to the aorta was done. So these are, whenever you have multiple VSTs which are not closed naturally, probably you can think about this kind of methods. So we actually published this method many years back, a transforaminal approach, where you go from that in infants, but many people said it's a very difficult procedure, but somehow we learned that it's essentially the principle is go through the foraminal mitral valve, cross it and deploy it. So this is the index case. What happened is the patient came during the respiratory infection epidemic, and then surgeon refused to do surgery because baby was having a sepsis. Then we were debating ourselves to close that. We closed it using a 2 ADO2 in this particular patient. Child did very well. So with that, there is another case of a 4.6 kilogram from Orissa, a large ventricular septal defect. You can see the sheath, which is more than 360 degrees curve here, double curve. So when you are going through the mitral valve, sometimes you will have mitral regurgitation. You can see that severe mitral regurgitation will fall the blood pressure. So this patient underwent a 12 millimeter amplatzer muscular VST device, and the child did very well, and we followed for many years and we stopped follow-up. Sometimes it is useful, a 7-year-old child, you can see this case example of a severe pulmonary hypertension, vascular resistance is 5 wood units, whereas QP by QS 1.8:1, and we took the patient for the procedure, multiple VSTs, RAO view and lateral view. You can see that this patient underwent a foraminal method, 2 multifunctional occluder as a first phase human studies which we did in 2017 or so, 2 devices. Then later on we actually recatheterized after 4 years. Now you see the pulmonary artery pressure significantly reduced to 42 millimeters of mercury, the systolic from the near systemic. So when you have multiple VSTs, target to close the bigger ones and leave the small ones as a pop-up. So see the natural history rather than debating. That's sometimes rarely it happens. It's not very often. Hybrid perventricular devices possible in case of small children where surgeon or cardiologist are debating themselves to do the procedure. So this is an illustrative case of a large apical ventricular septal defect. You can see that, and the initial sheath is placed across from the right ventricle across the ventricular septal defect at the apex, and then you can see the final device, the deployment here being done. So this procedure is useful in case of small babies where surgeon cannot reach that point, a cardiologist cannot reach that point. It is possible to do this procedure. The other issues, embolization when you don't have proper sizing, conduction issues bit rare in case of muscular, but post-muscular may cause bundle branch block, sometimes very dangerous. Left bundle branch block can cause the ventricular dysfunction over the period of time. And most common thing I noticed is the residual shunts. Multiple VSTs are common whenever a large VST is there. Even you put a device, because of the large defect, residual shunts are very common in this. And also the RV disc will not be formed many of the times. So here a typical case, you can see mid-muscular VST. Initially we thought that how we judged in this case. Initially we thought that we'll go from the foraminal veil approach. We could not go. There is no foraminal veil. We did not want to do the transeptal puncture. Then we thought we'll go retrogradely. You can see retrogradely we could not go it. Transfemoral approach which we could not go after the looping. And finally we had to go from the jugular approach and deploy the device. So that's how sometimes you may misjudge yourself, and you don't, your decision and dilemma also may be sometimes important unless you take it. Our experience of muscular VST in infants using only amplatzer muscular VST device, 25 cases before Conner MF era, and there were one mortality was there because of the sepsis patient refused for surgery, otherwise the success was very good. This is the multi-center data which we are going to publish, Dr. Usha and Dr. Navanita, their data. of conar multifunctional occluder in 3 centers, and mid-muscular is the common group, and commonest devices are the bigger size devices which you can see, and the residual shunts are very common, up to 20% of residual shunt immediately and the first discharge, whereas by 6 weeks to 3 months everything will be subsided. So this is a 5 months old baby, failure to thrive, a transjugular approach, you can see conar multifunctional occluder, how it is being deployed. So to summarize, transcatheter muscular VST closure is a safe option, effective alternative to surgery for muscular VSTs in many occasions where surgeon cannot reach the apex or post-muscular location. The device choice is purely dependent on the size, location and patient profile, most of the times infants and young children. The advantage of a multifunctional occluder is it goes through smaller sheaths. That is the major advantage, and trackability is good and the profile is medium to low profile. The approach, whether you want to do AV loop, retrograde, jugular, should simplify your procedure rather than sticking to only one method I want to do. It doesn't work out really in most of the cases. I feel that these cases should undergo early intervention, otherwise growth retardation, recurrent commonest cause of death in VST, according to me, it is a respiratory tract infection. It is not due to either heart failure or pulmonary hypertension. Therefore, I recommend these babies should undergo for the procedures whenever it is suitable from the operator point of sight. Thank you very much for your kind.
Thank you very much, sir, for the elaborative presentation. So I have only one query. With your vast experience, like you have dealt with so many different types of VSDs and so many overcome like different approaches, retrograde, antegrade from the RV side, also from the PFO side, everything. Now, what's your experience of the heart blocks? Because this morning also we were having a word, like whenever you are having a heart block, maybe we can divide in 2 parts, like on the table or maybe after say 2 or 3 days. Then what's your approach in different kind of VSDs?
Muscular VST heart block we did not encounter. Posterior muscular VST is dangerous. Whenever ECG is showing left axis deviation, you should be very careful. Whereas a perimembranous VST, the heart block, when you are crossing with the catheter or putting a delivery sheath, if there is a heart block, you should abandon the procedure, you should not do it actually. Because you are already demonstrating that the conduction system is in close proximity to the ventricular septal defect. We actually studied on conduction system. If the reference to the VST device closure, we published our data. I did not put that because it's a mainly perimembranous, and we found 5 types of conduction abnormalities. Actually, if you look at the paper 1970s by Anderson group, they have actually published the surgical conduction system variability in case of VSTs. Similarly, what we found that type D and E, where the left bundle and the his bundle, lower part of the his bundle travels to posterior part of the membranomuscular junction where it buries. So if you have that kind of cases, if you can identify, you can avoid the heart block. Otherwise, the heart block chances, whatever the device it is, it may be multifunctional, it may be whatever it is, patient factor also is important. It is nothing to do with the operator factor or the device factor.
Great presentation, Nageshwar. I have a couple of questions for you. The first question is that many of these muscular VSDs have an intramural tract. So you have a LV opening on one side, RV opening, and there is a big length to that tract. My concern in these patients is that when you pull back the device doesn't form itself well, and you are on the cable and you think that when you are going to release, it will form itself well. I have seen a patient done by one of my colleagues where it didn't form itself well because it was intramural, not on the RV side, and over next 15 minutes got milked away in the left ventricle. So what are your thoughts about muscular VSDs with an intramural tract? That is my question number 1. And my question number 2 is, many of these muscular VSDs, especially close to the moderator band, LV has one opening, but when it comes on the RV side, it gets divided. And then the right ventricular disc just doesn't form itself well, and leaving behind sometimes a residual shunt. So I wanted to know what are your thoughts and what is your experience in these kinds of...
Both are very much burning questions. When you deploy the device from the RV side, we think that the device may form, it may not form. But amplage muscular VST is a high profile. Many of the times amplage muscular VST tend to form the shape, whereas a multifunctional occluder doesn't form its shape. Therefore, we regularly, when we are doing the right ventricular side, we try to push the device as much as possible, but still it is not possible. The other approach for that is, if the child allows you the size of the baby, you go retrogradely and pull the RV disc as much as possible. Deploy the LV disc even if you stretch it, because the LV disc will go and attach it to the left ventricle because of the left ventricular pressure is higher. This is the main problem is the RV disc, what you rightly pointed out. So either you use amplage muscular VST and push it, the corner MF, or deploy from the retrograde. To some extent only you can solve the problem, but it is not possible always, especially when you are deploying multiple devices. The other one, residual shunts, it's very, very common to have the residual shunt to 20% we are going to publish that actually. We think that it's only one muscular VST, but when you close that, there will be just beside that there will be additional muscular VST, or through the device. The mechanism of the device is either amplager or corner MF. You deploy entire thing, the fabric should be there and it should occlude. When you pull the right ventricle, which is not formed right ventricular disc, it is not completely you are occluding, you are only partially putting a wall across the defect. So you have residual devices. But most of those residual shunts will disappear. You have to counsel the family that the shunt, intra-device shunt is going to subside that, even TR, whatever it is in case of posterior muscular. These are the real problems.
Can I make one comment? Please. I just wanted to make one comment on muscular VSDs, and this was my experience, and I have burnt my fingers. I don't want all of you to do it. This was in a post-infarction case. We closed the defect, and the defect closure was really very good. And we wanted to unscrew the device. Actually, it took some time to unscrew. It got unscrewed, but the cable refused to come back into the sheath. The reason was that probably I had wrapped the tricuspid valve chordae, and when I tried to do it, I did rupture. Fortunately, patient made it, despite it being a post-infarct. So from that time, what I have learned is that never bring back the sheath too much outside. Keep it very close to the device and then unscrew, lest you might wrap the tricuspid valve chordae. You have to be very careful there.
I am sure you might have deployed very well, but what our approach is the jugular one. If the patient is here, we move the entire system aligned to that and then deploy. If you don't do that, the cable will rotate in reverse direction. So you have to align the cable. When you have apical VST jugular, you come almost close to the patient head and deploy that. Two people has to hold. Otherwise, some of the problems may occur. TR is not a very unusual, followed by post-MI, as you rightly said. Tricuspid valve injury is very common. I have seen many of those post-MI ways.
Thank you.
Thank you for that comment.
Thank you.
Thank you, both of you. So actually this point is a very important one regarding like that release aligning well. It's probably because the fulcrum changes where exactly like the release is going to, our force is going to be transmitted to the cable attachment to the device. Another situation where this is very important is when you use a Trevisio cable for ASD delivery. So when you're using the Trevisio cable, like you have to really get the sheath very close. Well, in all IST devices, you have to get the sheath very close to where the cable is attached to the device. More so in Trevisio, because otherwise when you unscrew, the fulcrum becomes elsewhere and the release may have trouble. So in Trevisio, it's a little bit difficult to get the sheath back because there is a little bit of flexibility there, but still you have to like pull on the cable, push the sheath, and then release it only when it is closer. And as Nageswara Rao sir was mentioning, when you approach muscular VSDs from the jugular, it is better to align it so that you don't end up in trouble with the release. Thank you so much for this insightful discussion and the presentation.
I had just one question, sir. Sir, have you had any unfortunate incident where there was any hemoglobinuria, especially with the large devices? Because in some
no, it is common with post-MI amplantar muscular VST device. The amplantar muscular VST device has got a Dacron fabric. Dacron fabric has got porosity more. When you test that, you will have hemolysis. Whereas the LifeTech muscular VST is nothing but a PTFE 3-layered one. So larger devices, we prefer LifeTech muscular VST because 3-layered PTFE porosity is very, very less. So we had two cases I remember still, that post-MI VST device, amplantar VST device is causing porosity. Then when we were testing in China, all this corner MF has got a PTFE layer, no Dacron. Whenever Dacron is there, more inflammation, more porosity, hemolysis rate is very high.
Thank you. So we call upon Dr. Soumya to present preliminary VSD device closure, step-by-step approach and tips and tricks.
I thank Nims for giving us this opportunity. We are from Sri Padmavati Children's Heart Institute, Tirupati, and I'm here to present perimembranous VSD device closure tips and tricks. Most of the talk will be a repetition of what Dr. Usha and Dr. Nageswara Rao had already said. So, yeah, once the slides start, a small disclaimer to start with. I'm presenting what all I know of this topic, so any questions, please direct it to the seniors, Dr. Bharat Dalvi and Dr. Nageswara Rao. So, starting it, right? So, for a successful intervention, you need to have a complete and thorough assessment. Please do the echo yourself. Please, the primary operator has to do the echo himself, see it in all views, all planes. Plan the case, hardware checklist. Discuss with the technician and scrub nurse. Nobody is inferior in the cath lab. The only person who is above us in the lab when you're doing is the patient himself. So please talk with everybody, be communicative, know your hardware, what all do you have, and knowledge of different vascular access routes and catheter materials. We have a different armamentarium of VST devices now. So you should know what all is there in the rack of your lab before you even puncture the child, right? And predicting and avoiding the complications. Once the complications happen, we all get tachycardic. But predicting them, like when a wire goes, you would have had a, like a prolonged PR or a small heart block. So then you know that this child is prone to it. So predict it before you actually land up into the complications. This is the 4 regions of septum which has actually been dealt with, and we are talking about this perimembranous area which is near the tricuspid valve and the aortic valve, and that is what we are trying to close with the device. Indications for transcatheter closure: heart failure which is not controlled by medical therapy, LV volume overload or LV dilatation, cardiomegaly on chest X-ray, ECG when it shows volume overload, and if the QPQS is more than 1.5:1. Transcatheter closure of ventricular septal defect, it was done, the first one was in 1988. I'm sure many of the audience in the room would have not even born by then. It was done by none other than James E. Locke. He was the first person who has closed the ventricular septal defects with a transcatheter. Of course, most of them were in adult patients. What are the contraindications? Any child who is less than 5 kilo, associated with valvular regurgitations or a high pulmonary vascular resistance, VST near the semilunar valves, active endocarditis because you obviously don't want to put a foreign body in, VST with RCC prolapse, and when the parents prefer surgical closure. Nothing wrong in sending a child for surgery. Just as the way pediatric cardiology has advanced, pediatric cardiac surgery also had advanced. They are able to do this now with mini sternotomy, even thoracotomy also. So when the parents say, let us get surgery done, just accept it and just get it done. This is a picture where the VST has a aortic valve prolapse So this is a complete contraindication for a transcatheter closure. Pre-procedure echo assessment, as Usha madam had already said, location, size in multiple views, relationship with adjacent structures. In adults, you would obviously want to do a TE. So this is an echocardiographic classification of the perimembranous defects. They are classified into type A, B, C and D. A is the one with an absent aortic rim, which means the superior margin of the defect is in flush with the aortic annulus. There is no separation. Type B is what we usually call the Laddu VST, where the aortic valve is separated from the VST as such and by the ventriculoinfundibular fold. Type C is a restrictive VST, which is restricted because the membranous septum has formed an aneurysm. It might have a single exit or multiple exits. Type D is again a VST which is restricted, but this time it is not the septal aneurysm which is restricted but by the septal tricuspid leaflet, which comes and restricts the VST. So you don't have any aneurysm there. So the only thing which will hold your device there would be the STL. So this is an example of a VST near the aortic valve. So you can see that the aortic valve is actually in flush with the VST. You can think that there might be a little ridge there, let's go and try to do it, but no. VST, when it is near the aortic valve, you at least have to have a margin of 2 mm between the VST and the aortic valve. Otherwise, don't venture into a device closure of these defects. They have tried these asymmetric, these are called the asymmetric VST occluders. If you can see, this is the symmetric perimembranous VST occluder. This is the asymmetric one. If you have the perimembranous, you'll have +2 and +2 on both sides. But in asymmetric or the LifeTech eccentric, you don't have anything on the aortic end. So you don't have anything which is touching the aorta. Instead of the 4, you'll have a 6 mm on the RV side. These are marketed, they are still there. But these are devices which have high radial strength, high axial force. So there were incidences of complete heart block more in this. This out of 19 patients, this is the data from Jaideva where we had used eccentric VST devices. 1 patient had a complete heart block, 1 had an RBBB. That complete heart block patient, we had to get him operated. The right bundle branch block patient is still being followed up. Again, type A VSTs, no aortic margin or less aortic margin less than 2 mm, don't go for a device closure. VST away from aortic valve, yes, you have a good margin. You can see that the VST is separated from the aortic valve by a good margin. There is this ventriculoinfundibular fold. So you can close this with the number of devices which we have. The choice of devices can be ADO1, MFO, muscular VST or ADO2. This thing is, if you're measuring anything less than 6 mm, this is for a beginner like me. If it is anything less than 6 mm, you can try an ADO2 6.4. Anything more than 6 mm, you should venture, think of doing it with an MFO. This is the type C VST where it is restricted by septal aneurysm. You can see that the membranous septum itself is, the membranous septum itself is forming the aneurysm and which is restricting the VST. So these VSTs, that membranous septum is very flimsy. You don't want the bigger devices because you don't know when that membranous septum, how much the membranous septum would support. So your choice of devices again would be an ADO2 and an MFO. So this is the ADO2 which is being deployed there. So when to choose what? Again, it's the same thing. Less than 6 mm, go with ADO2. More than 6 mm, go with an MFO. Both of them are very low profile devices. They are very soft devices. They just stay where you put. And one blind thing is an ADO2 6.4 is equal to an MFO 8.6. Both will have a 12 mm retention skirt. Both will go through a 6 French guide. Then VST, which is restricted by septal aneurysm. You don't have any tissue to hold there. It is just the STL which is forming the restriction there. In such patients, you cannot go with a double disc device because of the you're afraid that the disc would protrude and cause more TR. So your choice of the device would be a single disc device, which is an ADO1. So this is the ADO1 in such a subset. We'll just see. So the next is angiographic profiling. Perimembranous VST, classically we do it in LAO 60 and 20, but because they are children, you will not be able to go to LAO 60, so we end up doing it in 40-20. Muscular VSTs, sir, already had spoken, outlet and subpulmonic VSTs are better profiled in lateral or RAO view. This is the pigtail injection in the LV which shows the profiling of the VST. We used to do it before. Now we know how big that VST is. You would have already planned the size of your device in the echo itself. Angio is not going to help you to size the defect. Angio is only which tells you where the defect is, how to cross it. That's all there is to it. So now we have changed to a end hole catheter with a hand injection. I know many of them don't agree. LV should not be injected with an end hole catheter with a hand injection, but it is just a little volume in small babies just to see where the VST is and the direction of jet is. Once we have done this, you have already known what your device is. Crossing the VST. Perimembranous VST can be crossed in two ways. One is a wire-only method, the other being the catheter method. And crossing from the RV side definitely needs practice. Wire-only method is the easiest. You take an 035J Termovire, ask your technician to give a new Termovire. Don't compromise on these Termovires for crossing a VST in these children. The only one thing which you would be using in this child new would be a Termovire and the device itself, that's all. Take a new Termovire, put the JR guide just above the aortic root sinuses and the wire just beautifully passes through if it's a perimembranous VST. This is another way where the catheter is, this is from entry from the RV side, where you have a catheter in the RV and the catheter is being to be pointed towards the LV and then the wire is passed. This is another way to cross the VST antegradally, and this is being described by Dr. Shivakumar in his recent paper of venous only closure of the perimembranous VST defects. So where he takes a 4 French RCA catheter, goes into the pulmonary artery and then comes down slowly where a pressure tracing is connected to it. Once the RV pressure trace goes into the LV, you know that you are facing that VST. Once that he's facing that VST, because it is just a 4 French RCA and just goes in, then it goes into the LV. Crossing from the RV side is difficult, it needs practice, but someday we'll all reach there. Outlet VSTs, this is for the catheter crossing of the VST. When would you choose wire? When would you choose a catheter? This decision also happens in echo. This is just a representation. When you have an acute angle between the jet of the VST and the LVOT when it is acute, roughly when you're doing an echocardiogram and your jet is going up, then you need a support of a catheter which looks up so that the VST can be crossed. Your wire cannot just come like this and it might not float easily. So what are the armamentarium of catheters we have? IMA is a good thing, and we have a whole bunch of cut pigtails which we have cut. You can see the pigtail is cut almost 1.5 turns. This is 2 turns almost. But please be careful. This should be your last resort, right? Because the way we cut it, they are not equal. The edges are not plain. The moment you touch it, you are scraping the borders of the VST. You never know where the bundle gets involved and when the heart block comes. So this should be your last resort. Then is the snaring in the AV loop. When you want to close bigger defects through the RV side, you cross through retrogradely and snare it through the AV loop. What I found is that snaring it from the pulmonary artery was easier rather than snaring it from the SVC IVC. By easier I mean that when I'm entering the RV from the venous end, I take a loop in the catheter and enter rather than with a wire. So that at least takes away the tricuspid valve caudal loop. So if it is just snared from the PA, at least this path would be straight. So once the sheath goes, this is the LV angio of the sheath which is placed in the LV. And this is how an ADO1 is deployed. We all know it is facing the LV apex. You deploy one disc, slowly pull it out and then deploy the other. This is the angio to see how it is, but I accept that there is the waist is really tight in this. Maybe we could have downsized the device a bit. But thankfully the child did not have any issues. So this is an ADO2 deployment. Okay, the ADO2 deployment, when once the guide catheter is in the RV, we try to deploy the RV disc of the ADO2 first. Okay, I'm sorry, I know they are all hunger pangs, I'll just finish fast. So when we are deploying this ADO2, make sure that the RV disc is completely deployed in the RV, deploy the waist, slowly pull it back and then deploy the LV disc. And if the RV disc by some reason doesn't form in the RV, it means that you have caught in the trabeculae or something, pull the device back into the guide, reposition that guide and then deploy again. Once you have deployed the ADO2, you can, it is because of the cable is also very slender, you can push it down to the required position of the device and you can do an angio to see whether there is an AR or no. Not like, it's not changing.
Only hanging.
ఇట్లానే ప్రెజెంట్ చేసేస్తానండి ఫుల్ స్క్రీన్ రాకపోయినా ఇది కాదు సరే నేను చూసుకుంటాను ముందుకి I have skipped few slides because the PowerPoint also doesn't want me to present. This is a small baby, less than 7 kilo baby with a perimembranous VSD who presented again with heart failure. So this we have closed with MFR from the venous side, and as you can see in the echo, there are no issues at all. So the complications being device embolization can happen if you have a residual shunt and especially a low profile device like an ADO2, VSD size mismatch or STL aneurysm, and if you don't deploy it in a proper angle. We had one case like this where we had deployed an ADO1, but unfortunately ADO1 had gotten stuck into the tricuspid valve chord and the child had moderate TR, which we had to send for surgery. Dysrhythmias, bundle branch block and AV dissociation are known to occur. Valvular regurgitations are common and hemolysis is rare. This is a case report from Jaideva where the child, who was a 7-year-old child, underwent an ADO1 10-8 and on progressively his QRS got in widened over follow-up. So he had an LBBB. We were not sure whether surgically retrieving the device 1 year post the device closure would revert it back. But we went ahead, got it operated, and the child is now has a narrow QRS with a normal sinus rhythm. So this was a good thing. And smaller children, please avoid complications, prevent hypothermia, hypoglycemia, ventilate them, they will not have any issues, avoid blood loss, minimize contrast injections and minimize flushing. So in summary, please understand the morphology of the perimembranous VSD, evaluate it, understand whether you will be able to do it or not, plan the procedure properly, know what all devices you have, what do you want to plan, and surgical backup, ask your surgical colleagues, there's nothing wrong in it. Perimembranous VSD, be very cautious of heart block, even LBBB. In younger children, all this is challenging. So this is from Padmavati Children's Heart Center. Thank you.
Any of the younger cardiologists want to ask any questions to all three of them?
Sir, I'm not sure I'm young, but then the point is, one of the challenges, of course, what threshold do you back off from the VSD strategy? I mean, suppose you get a block, a right bundle branch, we do see that even when you're delivering the cable or when we're delivering the delivery sheath. Would you just back off at that time, or you would like to reposition it, or you feel it's no-go at all?
Right bundle branch block, we tend to accept it, sir. Just like mild TR, right bundle branch block, we tend to accept it. If the QRS is not wider than 120 milliseconds, we try to adjust this way, that way we accept it. But any left bundle branch block, no.
one more challenge sometimes we find is to get the delivery sheath into shape. I mean, you have to get it to point to the LV apex. So how do you do it? Do you feed the catheter, or how do you do that? Because sometimes it's a challenge because the delivery catheter is aligned to the aorta. We need to get it down into the LV apex. So
there are few steerable sheets, sir, which are called few star sheets, but they basically have a bigger profile. Even if they say it is 7 French, they'll have a 9 French outer diameter. So with a few star sheet, you can actually steer it so that it points into the LV apex.
thank you.
So when we have the stiff wire, we can actually direct the stiff wire like into the apex of the LV itself using an RCA catheter or something. And once you have that too with you have to make a shape round at the tip of the stiff wire and direct the stiff wire to the apex of the LV. So then when you come from the IVC and cross it, then the sheath will go straight into the apex of the LV. And that we also have found that it is easier to deploy, as well as alignment is better than from the aorta. And you can deploy with lesser precision, I would say, than how you would come through the aortic valve in a perimembranous.
Yes, sir.
There used to be a wire called noodle wire or rope wire. What you can do when you cross from right ventricle from the loop, you take the Judkins right coronary catheter, push the wire into the LV. The wire will go into the LV, then you advance that. That is the routine method. Nowadays the wires are not available because of the device itself is not there. So that's where retrograde method came. Now whereas when you accidentally already position sheath into the arch of aorta or descending aorta, you bring back with the device a partially open device, because there's a risk of coming out. That's why you partially open, allow it to fall from the aortic wall with the pressure guided. If you pull it, aortic wall damage may be there. Once you are in LV, then push the entire assembly towards LV apex. This maneuver has to be done, otherwise you may end up, sir has got it.
Really speaking, I was trained in the era when asymmetric ambulatory occluder was there, and what Nageshwar says is perfect. We used to take the sheath predictably into the ascending aorta with a noodle wire, and that noodle wire, the arteriovenous loop was with a right coronary catheter. In LAO 60 and cranial 30, bring the sheath into the ascending aorta, give a counterclockwise loop, and just push the noodle wire. The whole noodle wire with the right coronary will go into the LV apex. Just track the sheath. It will be predictably into the LV apex. So that is a well-known thing. I have a couple of questions for you. My first question is regarding the distance of the VSD from the aortic valve. It's not uncommon to see that the aortic valve is far away from the VSD when I see it in apical 5 chamber. And when I see it in parasternal long axis, it looks much closer. She said that she would not give too much of importance if it is seen closer to the aortic valve in parasternal. But my question to both of you is that many times after you put the device in, then you wonder that this device appears very close to the aortic valve. So I'm not very sure as to how you judge this before really opening the device and putting the device in, whether parasternal long axis view is to be taken into consideration at all, and what distance you would think would be a significant distance to accept for device closure. That's my question number one. And question number two, I have read Shiva's paper on classification, but I tried to look through my eyes. I don't know how you differentiate a membranous aneurysm from a STL aneurysm. It's very difficult for me, at least. I don't know whether you guys can actually say that, okay, this is a membranous septum and this is not a septal. So I'm really tricked by this kind of classification. So what are your thoughts?
So when we are assessing the aortic margin for the VSD, not just apical 5 chamber and the parasternal long axis, we tend to see it in the subcostal view also. Subcostal view, when we are opening both the great arteries, if you have a little ledge of tissue under the aorta, then we are safe. That is the thing. And the second one, between the membranous MSA and the STL aneurysm, both of them, like they can coexist together. Like sometimes it can be an STL with an MSA, but if it has a very loose tissue, we tend to write it as an membranous septal aneurysm, and if it is just an STL, then it is like a type D. You don't have a membranous septal aneurysm, we tend to go for an ADO1.
Yeah, I think what I've used is a modified subcostal apical for defining the aortic rim, and I think that gives the best view, and I've not had any problem with that. So not modified apical subcostal.
Sir, I think PLAX view foreshortens the LV. That's why I suppose most of the VSTs appear very close to the aortic valve. And unless you are taking a very large device, anything below 12-10 or 10-8 with the 2 mm rim would not touch. And one thing is when you deploy the device and if you see excessive movement of the disc, with each heartbeat the aortic cusp is pushing the device, I think there would be a risk of perforation in the future. You may not have AR immediately, but you should be very cautious in releasing such devices.
I have a little bit of concern about the perimembranous VSD. I mean, I don't do it anymore because of the complications in my hands. I have stopped doing it. But you know, when I used to do it, I used to see the device take quite a bit of a turn. When it is on cable, it seems to be in one position, and when you release it, it really changes its position as well as its disposition with respect to both tricuspid and aortic valves. And when you have released it, it's too late to do anything. And that is the reason why I was not very confident, because I couldn't predict the results of the device closure. Just as a matter of comment, I wanted to emphasize one fact which really hit the nail and why I stopped doing it is the occurrence of left bundle branch block. It's a very serious complication, in my opinion, far more serious than a complete heart block. Because if LBBB occurs late in the course, beyond 6 months, it's unlikely to be reversible. And almost every patient who has developed it has developed left ventricular dysfunction, which can go into a cardiomyopathy, which can have very serious consequences. I had done one case in 2006. 2019 echo is perfect. 2024 echo shows a LV with LV dysfunction. So sometimes it may be so late onset that probably nothing can be done. So
When
that's
our patient had after 2 years, sir. After 2 years, LBBB developed.
Yeah.
Like what Soumya mentioned, surgical retrieval, but it reversed completely.
Yeah.
Do you advise against device closure of a perimembranous VSD then?
No. See, I am not judgmental. I don't pass judgment. I would say, in my hands, I really...
Rephrase the question. Would you do a perimembranous VSD device now?
I feel like doing it, but I don't do it because I didn't find it. I looked at my own data. And I'll tell you one thing, I had 2 aortic regurgitations, 1 moderate. I had 1 tricuspid regurgitation with a single disc who had to go for surgery. And I had 1 left bundle branch block. We must have done around 100, and we started doing perimembranous VSD when nobody was doing. But we created the mistakes which we didn't realize at that time. We burnt our fingers, but by that time it was too late. These guys, their understanding of perimembranous VSD anatomy and all is much better. By that time I had stopped doing it. So I wouldn't say that don't do it, but I think you must have a very systematic follow-up, very honest follow-up, and then take a call whether you want to do it. My concern is in trying to close or in trying to treat a defect which is not so complex, you may create a problem which is far more complex in terms of aortic regurgitation, left bundle branch block, complete heart block. These are some of the issues. Which I agree with you. If you have a good, absolutely. And I think those are some of the cases which you should do, and probably they are the ones.
More like a type 1 PDA.
Yep.
Or
Completely.
type of RS probably. That I think.
Yeah, those may be the cases. But I think Nageshwar has much larger experience, so I think probably he will be able to.
No, what happened is, if you look at the perimembranous VST device evaluation over the period of time, Rashkin device was the first one which was introduced. The Rashkin device never had any heart block. You review the literature from Jim Lock, Arora, Professor Arora and all they did. The main disadvantage with that was embolization, fluoroscopy, less visibility and residual shunt. The reason for that was they used a material where it will not cause shear stress on the conduction system, clamping force. Then Amperature device came in 2002, precisely till 2006, many devices implanted across the world. The problem was the waist distance is 2.5 millimeter and it is a high profile. So the conduction system started getting compression by the two discs, because you always would like to put 1 or 2 millimeter higher. So it caused shear stress on the bundle and the clamping force, and also the tensile power of the device itself caused. Then the fabric inside was highly inflammatory. That's why the heart blocks developed not only immediately, 6 months to 1 year later on, because of the chronic low grade inflammation happened. Therefore, it never got any approval. The ADO2, which is originally designed for the PDA occluder, which failed because of the LPS stenosis, which has got 3 discs, which is elongatable to 15 millimeters to 24 millimeter. So that means when you put a device, it will not actually compress, it will be little bit of less shear stress, it will move along with that. That's why heart blocks are very less common with the ADO2. Only few case reports are reported, including Dr. Muthukumar, one case, and some Chinese guys. We introduced the retrograde method. While you are doing, if you avoid that AV looping, put a wire-only method, the amount will, based on all this information, autopsy studies, then MFO we brought it with the ceramic coating, all those things. So far only one heart block by Majni Alvi reported in cardiology in the young. That's a case of Down syndrome with the baseline left bundle branch block is there, a left axis deviation. So it's a patient factor, sometimes operator factor, where you try to put a bigger device. If you look at the paper by the who is that first, Gunther Foster and Lee Benson group, all the devices they published are oversized one. The device waist is very much compressed and elongated. So we feel that that is the reason, and nowadays heart block reporting with the devices are very, very less. I don't see that.
No, I take your point on heart blocks. My point is on left bundle branch block. And left bundle branch block is seen with a single as well as with a double disc device. My concern is about the left bundle branch block. Of course, heart block also, but more with left bundle.
Actually, we see a lot of junctional rhythms following device closure. Have you been experiencing that? They go into accelerated junctional rhythm, and which reverts with steroids. We give steroids for 2 weeks and they are fine. But why is it so common? I mean, some his bundle or something gets irritated, I think, when we put the device. Does this predict heart block in the future?
Dissociation, we see it even with ASD closures.
This we see a lot, sir, actually, with VSD closure.
And when we used to do VSD, but really speaking, isorhythmic AV dissociation with narrow cure has never bothered me. We have always gone ahead, once the patient is off anesthesia, little lighter, it's probably related to some high vagal tone or some such thing.
No, this develops 24 hours after device closure.
No, during the procedure, what Bharat sir said, anesthesia, Dexamide causes AV dissociation.
No, later, sir, not AV dissociation. Later, next day, 24 hours or 48 hours later, when we are about to discharge, junctional rhythm is seen.
Maybe you can report it, we'll study much better.
Actually, in our department, we have similar case, like a child developed junctional rhythm immediately after deploying ADO1 device in perimembranous location, but it was transient and it has settled on its own.
So I think it all points to the fact that the perimembranous VSD is very close to the conduction system, and we have a lot of unanswered questions, as Bharat sir was saying, regarding the long-term consequences of device closure of perimembranous VSDs. So I would say that we are currently looking at the natural history of more than 1,000 or maybe 1,200 perimembranous VSDs which presented after the first year. So there is a difference between the large perimembranous VSDs who present in the early infancy with heart failure versus which are mostly not amenable to to device closure and which mostly goes to surgery versus the later presenting ones. We'll have more information on actually what percentage of them are actually undergoing closure, at least in our center. And I think the thing that we all have to underline is that we have to look at whether the procedure is indicated or not, because we still don't know what we are giving to these patients for a disease which otherwise is not that complicated. So I think with this we can close the session. Thank you all.
Now we have come to the end of this VSD session. Now I request our Professor and HOD Ramakumari Madam to present mementos to the chairpersons and speakers. Now I invite Amitabh sir. I invite Navanita ma'am.
Dr. Nageswara sir, we missed you in the previous session. Usha ma'am also. Madam, please. Nageswara sir,
I invite Soumya Kasturi ma'am.
And when shall we meet back, sir? 45 minutes. So around 3 p.m. Yeah. Huh? 2:45. And 10 3 out.
Next PDS.
So now we are moving on to the next interesting session of PDA discussion. So now I would like to invite our chairpersons, Dr. Bharat Dalvi sir, Dr. Anuradha Sridhar ma'am, Dr. Usha MK ma'am, Dr. Nitin Rao sir, Dr. Amol Gupta sir, and Professor N. Ramakumari ma'am, and Professor B. Adilakshmi ma'am.
Anatomy, clinical assessment and imaging of PDA from point of view of device closure will be presented by Anuradha. Over to you, Anuradha.
Good afternoon, everyone. I thank Dr. Srinivas for this invite and this talk on clinical and imaging assessment of isolated ductus. Now, for any PDA device closure to be smooth and uncomplicated, we need to evaluate the patient thoroughly before the procedure, both by clinical assessment as well as by echocardiography. And it is equally important to remember these details when you take the patient for procedure. For example, this is a 1.5-year-old child, 6.5 kilos, severe failure to thrive, and large PDA by echocardiography with left heart volume overload. But the operators did not pay much attention to the echo details and the clinical details, and they were relying on the angiographic measurements for device closure. If you see the iotogram, it shows a small PA end, like the PA end was like 1 to 2 millimeter. It was a very small PA end. So the operators had initially deployed a coil which got embolized, and then multiple device sizes were tried in a graded manner, and finally it had to be closed with a 14 by 12 duct occluder 1. So if we remember the clinical details and the echocardiographic assessment and the measurements, then we would not assume this as a small PDA and will be able to recognize ductal spasm. It's very important to know the echocardiographic details before the procedure. Now, about hemodynamically significant PDA, it is very simple in older patients, children, adults, and even term-born infants. If there is a PDA and there is signs of left heart enlargement by echocardiography, it is a hemodynamically significant PDA and needs closure. Whereas in preterm neonates, it's different. There is no consensus statement on what is a hemodynamically significant PDA in preterm neonates and which PDA needs to be closed. We need various clinical and echocardiographic parameters to actually show that the PDA is responsible for the physiological instability. Now, it's also important to understand the pathophysiology to do a comprehensive echo assessment of PDA. Now, PDA is a vascular structure between the two circulations, systemic and the pulmonary circulation. So it can shunt volume between the two circulation. It tends to cause pulmonary over-circulation and systemic under-circulation. So the spectrum of clinical features of PDA will not only depend on the size of the PDA, but on many other factors, like the vascular resistance between the two circulation, the difference in the vascular resistance. And it will also depend on the severity of the over-circulation on the lung and the under-perfusion on the systemic side. And apart from that, it will also depend, the clinical features will also depend on how well the left ventricular myocardium adapts to the increased shunt volume through the PDA. And also it depends on how well the end organs adapt to the low blood flow in the systemic circulation. Now, when we look at the spectrum of clinical features of PDA, it belongs to three main pathophysiological mechanisms, which is pulmonary over-circulation, which will depend on the maturity of the pulmonary capillary bed. If in older patients, the pulmonary capillary bed is very compliant, it allows a lot of blood to flow into the lungs, and over a period of time, they develop pulmonary vascular obliterative disease. Whereas in preterm neonates and small infants, very non-compliant pulmonary vessels, which will transmit the pressure to the capillary sites and leads to pulmonary edema. So pulmonary over-circulation can cause these respiratory symptoms, and systemic hypoperfusion is indicated by signs like bounding pulses, wide pulse pressure, low diastolic pressure, and organ system dysfunction like oliguria and feed intolerance. And if the myocardium is immature in a small infant, then you will have features of heart failure, hypotension, acidosis, and even dependency on the vasopressors. Now, this is a published grading of the clinical features in preterm neonates with hemodynamically significant PDA. When we assess these infants, extremely low gestational age neonates in the NICU, this chart will help us to classify as a hemodynamically significant or insignificant, and even hemodynamically significant is moderate or large. Sorry. Now this, in preterm neonates and extremely low gestational age neonates, any PDA which is more than 3 millimeter and with signs of left heart volume overload, and the infant having severe symptoms with the airway pressure more than 12 and requiring high mechanical ventilation, is a very significant, hemodynamically significant PDA. It is all because of the non-compliant pulmonary vessels, severe aortic runoff, and the immature myocardium. Now, whereas in older patients, it is different. And in an older patient, a small PDA less than 1.5 millimeter, a silent, no murmur, will not cause any symptoms. Whereas if there's a small PDA, 1.5 to 3 you may have, the patient may have only a continuous murmur and not much symptoms. And a mild or moderate PDA will be 3 to 5 millimeter, some mild symptoms and continuous murmur. Now this is the most important group, patients with large PDA, significant symptoms. So this is the group we have to assess in detail clinical basic cardiac investigations and echocardiography. And your clinical investigations, echo, ECG, chest X-ray, and clinical assessment, if all these are showing consistently left to right shunt lesion, you can send these patients for device closure or surgery without any right heart catheterization. Whereas if all these features are suggestive of right to left shunt, then they are from medical management. If in this assessment, if you find some features are suggestive of left to right shunt, some features are suggestive of right to left shunt, they are borderline operable patients. And these are the patients who have to be, who needs right heart catheterization, pulmonary vasoreactivity, and also balloon occlusion test. Now, Eisenmenger patients PDA will have differential cyanosis where the clubbing is seen. Cyanosis and clubbing is much more in the lower limbs. And these patients are at high risk for organ dysfunction. Now, echo, X-ray, not much clue. Like some patients, the preterm babies, X-ray can show pulmonary edema if it is hemodynamically significant. This is an adult patient with Eisenmenger. Pruning is seen and calcification in the pulmonary artery, and cardiomegaly in a child with a significant PDA. Again, ECG, if there are Q waves, features of LVH, deep Q waves in the left precordial leads, they are mostly operable patients, whereas inoperable ones will have features of right ventricular hypertrophy. Now coming to the comprehensive echo assessment, the pathophysiological mechanisms are important for the comprehensive echo assessment. In the echo, we assess the ductal characteristics, pulmonary hyperperfusion, systemic hypoperfusion features, and the myocardial dysfunction features. Now, the first step is always to rule out other congenital heart diseases and make sure that the biventricular function is good and the PA pressure is normal. And it is very important not to accept suboptimal images. If acoustic window is poor, then we should use some tips and tricks to get good images, and if it is not possible, there should be a low threshold to get additional imaging like a CT or a MRI, and that is for the interventional closure. So about the ductal characteristics, it's the size of the ductus, the morphology of the ductus, the shunt direction, and the flow pattern across the ductus. Now this is about the size of the ductus. The ductus can be assessed in 3 echo views, and the number 1 is the ductal view, which we obtain in the high parasternal with the pointer facing upwards, and the probe is parallel to the sternum, and this is called the 3-finger view, where the descending aorta is in the long axis, and you get a very good view of the PA diameter and the ampulla as well as the length. Is a very good view for measurement. Now the ductus size is measured at the narrowest point, the diameter of the narrowest point. This is the point where the ductus tries to constrict and close off, and it is usually at the pulmonary end. The second view is the aortic short axis view. You get the short axis of the aorta, and then when we move the probe anteriorly, cranially, you see the round descending aorta in short axis, and that's when you visualize this PDA. And this is also a good view for measurement of the ductal dimensions. And the third view is the suprasternal view, ductal cut view, where you get the arch view and then turn the probe clockwise to get the ductal view. Now again, this difference in size between the grading of the PDA based on the size, there's a difference between the preterm babies and the adults. Now about the morphology of the PDA, these are some of the studies. These two are important among some of the studies that are published about the morphology of PDA assessment in echocardiography. Now they found that in patients who are less than 1 year of age, there was a good correlation between 2D echo and angiography in terms of assessing diameter, ampulla, length and morphology. Whereas in more than 1 year of age, only the diameter and to some extent ampulla were correlating. So in these patients, you will need additional imaging like angiography or CT or MRI to actually know the morphology. Now this is the Kreshenko classification of morphology where he described 5 different types, and this conical is the usual type and the AP window type where it is very short length, and the aortic and the PA end are almost equal in size, and the type C is the tubular PDA where it's a long tubular and with equal dimension of the ampulla and the PA end, and type D is the vertical PDA with multiple constructions, and type E is the elongated PDA, and all these might need additional imaging in older patients. Now these are some of the echo images showing the various morphology. This is a usual conical PDA, and this is the AP window type of PDA, and the central one, the 6th type of PDA is the fetal type of PDA, and which is also tubular, but the orientation is more vertical and it can be a little tortuous, more tortuous than the tubular PDA. And this is the vertical PDA. Usually it can be in complex congenital heart diseases. Then about the PDA shunt direction, the direction of the shunt can also be assessed in the same 3 echo views where we identify the PDA. Now this shunt is the red flow through the PDA, the Doppler signal is towards the probe, the color flow is also towards the probe, and the Doppler signal is seen in the above the baseline. This is a completely left to right shunt PDA. Whereas if you see a blue flow across the PDA throughout the cardiac cycle, it is the flow away from the pointer, and the Doppler flow is also below the baseline. And when there is pulmonary arterial hypertension setting in, then there is a change in the shunt direction. In early systole, the shunt direction changes initially, and you will see this kind of pattern on both sides of the baseline. And the PDA can be classified according to the shunt velocity and flow pattern, and this is a very important step where we will know whether we are dealing with a big PDA or a moderate sized or a small PDA. This is an unrestrictive or pulsatile flow pattern. If you see, the systolic flow velocity itself is not very high, and the end diastolic velocity is less than 50% of the peak systolic velocity. This is a large PDA with a unrestrictive or pulsatile flow pattern, whereas here it is a restrictive flow pattern where the peak velocity is also high and end diastolic velocity is more than 50% of the peak velocity. And there are some surrogate markers of echo which can indicate pulmonary hyperperfusion. One is the LPA diastolic velocity. When we have a continuous wave Doppler in the LPA, then we can see the forward flow in diastole, and if that forward flow is more than 0.42 meter per second, more than 0.42 meter per second, then it is significant increased pulmonary circulation. And the LA iota ratio as well as the LV size, which is indicated by the LV IDD Z score, these are also suggestive of large pulmonary blood flow. The other features are subjective features like pulmonary vein size may be increased and velocity is increased, and MR, mitral valve regurgitation, and there is a reversal of EA ratio. And there is an increase in LV cardiac output in comparison to the SVC flow, and this is also a marker of high pulmonary blood flow. And the isovolumetric relaxation time is also reduced because of the large shunt volume in the LV. Now about systemic hypoperfusion, this we can see in small babies where there is a diastolic flow reversal in the descending aorta will indicate this is the aortic arch flow, where we see in a normal flow we see the forward flow in both systole and diastole, whereas there is a reversal of flow in, you can see the holodiastolic reversal flow in the diastole. And this is abdominal aortic flow, again there is holodiastolic flow reversal. So holodiastolic flow reversal indicates there is a significant aortic runoff and organ system dysfunction can set in. Now about the myocardial adaptation in hemodynamically significant PDA, initially when there is a large shunt volume, the LV preload increases, then the LV dilates, and because of the large shunt volume, initially there is a LV hypercontractile state which is indicated by high cardiac output. Then the diastolic dysfunction sets in with reduced relaxation time, and then finally there is LV, systolic dysfunction. So myocardial adaptation, again we assess by contractility, fractional shortening, tissue Doppler, and speckle tracking and strain rate. Now fluoroscopic assessment will be addressed by the other speakers. Now CT is required in older patients, and CT has high spatial resolution, so we can get fine 3D, 4D images, and MRI, now we are 4D flow MRI may have good spatial as well as temporal resolution and may be preferred in future for assessment of PDA. So I'll skip this. This is a simple PDA device closure procedure in a small child where these are the clinical assessment. You need to get an X-ray, ECG, and a thorough echocardiographic assessment, and it is not enough we measure only the size of the PDA. So we have to assess all the features that we mentioned about systemic hypoperfusion and pulmonary hyperperfusion. So this child had a successful device closure, and so in adults, when we diagnose PDA or we come across PDA, most of the time the question is whether we really need to close PDA in adults. So this is a paper published in 2007 which mentions that adults with moderate or large PDA, before they develop permanent LV dysfunction, we need to close these defects, and they cannot be medically managed, because after the LV function dysfunction sets in, even if we close the PDA, the function doesn't recover. And then there is always risk of endocarditis and pulmonary vascular obliterative disease. So we need a thorough echocardiographic and clinical assessment for all these PDAs before the device closure procedure. Thank you.
Quick one or two questions from the audience. Anybody has any questions? I have two questions for you. Question number one, that how confident are you in measuring the ductal size in children above the age of 1 year, or sometimes even below the age of 1 year? I have the following concerns. One is that when you have elongated ductus, you don't know where actually the pulmonary artery is beginning, and many times you tend to pick up a color jet a little distally when it actually fans out. So there is a chance that you may overestimate the ductus if the color flow fans out, and if you pick it up proximal part of the ampulla, again you will overestimate.
Yes.
So my question to you is, how confident are you in sizing the ductus?
I think it is difficult, except in that conical PDA, which is a very common type. Other PDAs elongated, and if you see a different morphology, I think we need sometimes additional imaging before we close the defect.
My second question to you is regarding cardiac catheterization. I read this in books and I hear it in many meetings. How relevant is cardiac catheterization in PDA? The reason to ask you this question is, which is a chamber which is distal to PDA where you will pick up a sample which is absolutely perfectly mixed sample? Because if you pick up a stream of PDA, you will overestimate the shunt and underestimate the resistance. And if you pick up predominantly systemic venous sample, you will underestimate the shunt and overestimate the resistance. So
I think to decide PDA closure, I would rely more on the balloon occlusion. But again, there are difficulties in balloon occlusion. I think we need to have a comprehensive assessment. And when we take the sample, we try to go distally into the PA and on both sides and see how the difference. And definitely it carries fallacies. And we have to look at the whole picture of clinical features, the symptoms, as well as the echo cath.
again, this is one more example where you need to look at the numbers in the clinical background. Please go ahead.
Sometimes when we see that the patient is inoperable by all these assessment, and then according to the AHA guidelines, we start on pulmonary vasodilators, bring them back after 4 to 6 months, the numbers change in the cath, but the patient has actually not changed.
I agree
So
with
I
you.
think that is when we get into trouble.
Sure.
Sorry.
7 to 8 very large hypertensive PDAs. And what we do, at least to document on paper that we have done a cath study, we take average of both the lungs saturations. And the ultimate test is, we used to do balloon occlusion. It is very cumbersome. It keeps slipping, or either it will occlude aorta or the PA. So we do actually occlude with the device.
Yeah,
And
that
it
is-
has to fall below 50%. If it doesn't, like as Dr. Anuradha said, we give 3 months vasodilators.
And bring them back.
And we have sent them for surgery for a partial PDA ligation. We have not, though the device fits well and the PA pressure falls, we don't close with the device. We have done surgical partial PDA ligation, and 2 of them we have done residual PDA closure after 2 years.
Because not all surgeons are willing to
Yeah,
bang.
initially
So
they
you
were
must-
hesitant,
So you
but
must
now
have
they
a
are
good
also used to
surgeon.
it. Yes, sir.
Excellent, excellent.
Yeah, I agree with you 100%. What did you say about what she said about doing a partial ligation? But we had some adults who we thought were reversible, and we closed them, then they came back in very bad shape later. So that's a good strategy to do, of partial ligation, and maybe close the device later. The other thing what we said is perfect. It's always the device occlusion that helps, not the balloon occlusion.
Yeah,
you know,
I
what
think
you-
only, I agree that device occlusion, but sometimes if it's not possible, I think that reliant balloon, the round balloon that is available, to some extent we are able to.
Yeah. I think, thank you very much, Anuradha. I think we'll move on to the next talk. A little change in the sequence of speakers, because I think Navneeta has to go. So she will be speaking on hypertensive duct and interventional approach. Navneeta, over to you.
Thank you, sir. Very good afternoon to one and all, and sincere thanks to Srinivas sir and Mani Krishna for having me here. And thank you for initiating the discussion regarding operability and balloon occlusion and device occlusion, and are we able to predict like who will do well and or not. So I'll delve a little bit more into it in the next 15 minutes. I'll try to keep well in time. Let me try. So when it comes to large ducts, as we just discussed, there are 2 things that come into our mind. One is whether this duct should be closed, and if yes, then how can it be closed? So the first of these questions essentially pertains to operability, which means is the patient going to essentially benefit if we close this PDA, or are we going to harm this patient down the line if we close this PDA? The harm comes because I would explain that in the sense that any left to right shunt, like a large VSD or a large PDA or a large AP window, especially the post-tricuspid shunts, if we close when they have already had developed significant pulmonary vascular obstructive disease, what has been seen time and again is that their outcomes are not only worse than how it would be if it was not operated, but it is worse than even that of idiopathic pulmonary hypertension. So our first aim should be to do no harm. And once we have reasonably assessed and are reasonably sure that, okay, this is going to benefit the patient, then we can get into the technical details of, okay, how do we do it? So I'll start with a story again, similar to one that Bharadalvi sir was mentioning. So this is back in 2006 when a 7-year-old girl presented. So clinically she did have MDM. There was no saturation difference between upper limb and lower limb. So essentially a right to left shunting PDA will have differential cyanosis. She did have an MDM which was documented at that time. She had a large PDA with left to right shunt on the echo and some flow reversal in the descending aorta. So as discussed, this patient underwent a trial balloon occlusion at that time, and as you can see with the trial balloon occlusion, the PA diastolic pressures fell significantly, not the systolic though. And I think many of us would be aware that PA diastolic pressures are sometimes looked upon as a much reflective about the pulmonary vascular bed further downstream. And earlier PA diastolic pressures were given much importance in these settings. So looking at this, it was closed at that time, And fast forward to 2018, she did present with severe pulmonary hypertension and is currently on dual therapy. So is it possible to prevent this? 100% of course not, we cannot prevent, but we do have a lot more data than what we had 20 years ago. So as I mentioned, the first step in operability assessment is clinical. So there is no replacement for a thorough clinical assessment, as Dr. Anuradha was mentioning, when it comes to deciding whether a patient is operable or not, in the sense whether closing a hole will help the patient or not. This applies not only to PDA but also to ASD, VSD, any shunt for that matter. So each factor in the clinical assessment is important. I will not delve into details. Clinical history, examination, you can actually make out like which direction they are going. Is it towards operability or is it towards inoperability? Even your X-ray as well as ECG can be, X-ray can sometimes be very helpful, ECG can be supportive. So a thorough clinical assessment forms the base of the rest of the assessment. So after your clinical assessment, then comes echocardiography. So in echo, again, you corroborate your findings from the clinical assessment. As Dr. Anuradha was mentioning, if you have a significant left to right shunt, if you have chamber enlargement, then it is probable that the patient still has significant shunt and is operable. So whom do we cap to decide whether they are operable or not? And with that too with the caveats in PDA that Dr. Bharadwalli sir was mentioning, in the sense that it is difficult to get a proper sample which is indicative of a shunt in a PDA. And as Dr. Usha was mentioning, what we also do is we take two samples, one from the left lung, one from the right lung, and take an average of both to calculate for documentation purposes. So who benefits from CATH generally is somebody who has borderline features from a clinical assessment plus echocardiography, in the sense that we cannot classify them as, okay, this is clear-cut operable or this is clear-cut inoperable. They benefit from a CATH. In CATH, what is most important is baseline data. Of course, in PDA, there are some caveats which we discussed. And step 3 is the question of, do we do a vasoreactivity testing or a balloon occlusion testing? So in the baseline data, this is applicable not only to PDA, also for ASDs and VSDs. If the baseline data clear-cut shows towards operability and your clinical evaluation is supportive, then we can close the defect. If it clear-cut shows inoperability and your clinical features are supportive, well, it's better to leave the patient at least for now, and there is the opportunity for treat, re-evaluate, repair and treat, which of course does not have a lot of evidence as of now, but that may be one way to go in future. And again, those who do not fall into these two clear-cut categories may benefit from a trial occlusion with a balloon or a device itself, as we discussed. So I would like to mention again that there is no value in isolation for vasoreactivity testing or occlusion testing in any shunt lesion. We have to see the patient as a whole. So balloon versus device we just discussed. So it is difficult to stabilize a balloon, and it is more easier actually in the PDA than in a VSD, of course. And device is easier for that purpose. And we of course will have to answer, like if you take out 1 or 2 devices for occlusion and we end up not closing the defect, then who will pay for the device? So of course, so then what do we look for when we trial occlude? So the initial recommendations, as I mentioned, was 2008 CAT-CVI, where the recommendations were made on a small group of patients, where the PA diastolic pressures were considered to be very important and predictive of whether the pulmonary hypertension or the pulmonary vascular obstructive disease was reversible or not. And then we do currently have this large data. This is one of the largest data, especially pertaining to PDA. This has come out of Korea in 2014, where they report on 137 patients with large hypertensive ducts with follow-up data up to 5 years. So in this paper, as we would expect, what they found is that at baseline, the patients who had clear-cut features or favorable features of operability, which is like large left ventricles, baseline systolic PA to aortic ratios which were lesser, baseline pulmonary vascular resistance which was less, and baseline resistance ratios which were on the lesser side. So those were the ones who were free from residual pulmonary hypertension at a median follow-up of 5 years. If you look at post-occlusion data, again, systolic and diastolic PA pressure to aortic pressure ratios as well as resistance ratios were predictive to some extent. In their analysis, it was significant in the univariate analysis. When they did a discriminant analysis, the only predictor of residual PAH 5 years median follow-up was PA to aortic systolic pressure ratio less than 0.5, as Dr. Usha was mentioning, and this is what we currently focus on, but not isolated, but in the background of all the other information. There's one more paper which has come out in 2023 from China, again huge series, 134 patients, but unimpressive if you look into the details with respect to what were the indications of closure and what criteria and how they decided who will get a closure. Nevertheless, it is 134 patients, and what they found that those who had a post-occlusion mean pulmonary artery pressure more than 35 had significant incidence of residual pulmonary hypertension on follow-up. So let's look into how do we do the trial balloon occlusion. So once you have the stiff wire across the PDA, you can actually snare it out from the other side, from the aortic side for stability. That helps. You can pass a balloon either from the aortic side or from the PA side, depending on the patient size as well as the balloon size that you need. And what you focus on is what happens to the PA pressure versus the aortic pressure. Like in this patient, you can see that there was a significant drop in the PA pressures on balloon occlusion, and this was closed with, this was a large PDA and was closed with a large device. So I'll show a couple of cases where trial occlusion with device was done. So this is a 15-year-old syndromic child, but at presentation at 15 years did still have features of increased flow. You can see the X-ray. ECG was not very supportive, though there were clinical features which were suggestive that the patient could be operable. And you can see there is a large PDA which is more than 10 millimeters in size, and this was occluded with a 24x22 device, and you can see that there was significant fall in the PA pressures on trial occlusion with the device. So because there was significant fall in both the systolic as well as the diastolic pressures, this device was left there, and thankfully at 1 year follow-up, this patient did not have any residual pH. Now trial occlusion, again one more case I'll show. This one was an 11-year-old girl at presentation, clearly borderline in the sense that there is some cardiomegaly, but some endons, not much vessels in the periphery on the X-ray. ECG is not greatly supportive, no differential cyanosis though, like upper limbs, lower limb saturations are the same. There is a split test too, but there's no MDM, so it is clearly borderline. And again, this was a large PDA, and initially it was tried to be occluded with a 1210 device. You can see significant residual shunt. With an 1816 device, the device sat well and there was no residual shunt. Satisfactory device position and closure, but if we look at what happened to the PA pressure, so this was the baseline, almost like 120 systolic PA pressure and mean of 84, although the aortic pressure was also high in this case. But after occlusion, you can see that there was no significant fall in the PA pressure at all. It was pretty much in the similar range, and hence this device was removed and she was advised medical follow-up. So if this is one of the challenges that we deal with in hypertensive ducts, deciding who is operable and who is not. Now let's look into some other challenges from an interventional perspective, the technical aspects. So in addition to pulmonary vascular obstructive disease, these large PDAs, sometimes it can be very difficult to define them on angiograms. Sizing is an issue. And we know that the dynamics is slightly different when you have pulmonary vascular obstructive disease downstream and there is pulmonary hypertension, so device stability is a question. Older patients may have duct calcification, which can interfere with our device choice and deployment. And many of them can have abnormal shapes and orientations, and it is important to have good thorough assessment before we take the patient into the lab, so we take a reasonably good decision as to intervention versus surgery in these patients. So as I mentioned, sometimes we can be limited by size. You can see that it's not uncommon when we try device closures in huge ducts. for the device to just slip in as you can into the PA, as you can see in the first image. And sometimes, we may not have the ideal shape of the device. You can see that this second case is being attempted to be occluded with a post-infarction muscular VSD device, and there is significant residual shunt. Not only that, you can see that there is a risk of obstruction to the LP as well. So the usual strategy of sizing does not work in large hypertensive PDAs, which is adding 2 to the PA end. And some of us do follow a slightly different strategy in usual older adolescents and adults, where we take one size bigger than what we think is the right size. Both of these don't work, and when it comes to sizing, if you look at literature, there is one large series from Mexico in 2010 where they mentioned 50% oversizing, and both the papers that I showed, 2014 from Korea as well as the 23 from China, they have used like double the PA end size for the device at the PA end. I actually think that the truth lies somewhere in between, and trial and error is quite common in this setting. I'll show one more example of trial and error where there's a large PDA, and 22 into 20 just slipped into the PA when we tried to deploy it, but when we just upsized one, 24 into 22 sat pretty well, and this one did not have any challenge, or it was deemed to be operable, so we actually left the device there. So we know that inappropriate size and deployment can lead to issues with device stability. So this one actually embolized immediately after release, and then retrospectively we felt that one size higher would have been better. And when we try to do complex cases especially, it's good to be friends with your surgeon, because sometimes we may not be able to retrieve the PDA devices, because that screw is like buried deep and it's hard to catch it from that end. Other devices that have been used commonly include muscular VSD occluder as well as a Amplatzer septal occluder in this setting. As I mentioned, sometimes we may need additional imaging to decide what is a good option for the patient, whether it is intervention versus surgery. Like in this patient who was 14 years old, clinically very operable. We actually did not cath this patient for operability, and we thought that this was more like a window type with minimal length. And this we sent for surgery, where it was done under cardiopulmonary bypass, and they had used a patch to actually close it. And sometimes how much ever we assess, things don't work out, like in this patient, and we may have to resort to exotic stuff to bail out. This was a trisomy 21 patient, preterm, was diagnosed at 3 months of age but was lost to follow-up, and presented at 3 years. Again, borderline in the sense that, there was a suspicious MDM, P2 was loud, X-ray, there's some cardiomegaly, some features of increased pulmonary blood flow, ECG, not so helpful in decision making here. I think I'll finish in 2 minutes. So this is another example of a test occlusion with the balloon. You can see that we've got a near okay occlusion with a balloon here. This was a 12 into 2 Cook balloon. And there was some fall in PA pressures, even with balloon occlusion, we couldn't decide on what to do, because the PA pressures did fall, but not to the level that we would like. But clinically, we felt that, it may help the patient, and in the setting of down, because there were some features of increased flow. So it was decided to actually close this PDA with a fenestration in the device, and we also decided to stent that fenestration. This is only one case that we have done in Amrita so far like this. So this was an 18 into 16 duct occluder. Actually, a V18 wire was placed through the sheath and into the descending aorta, which was snared out. And the device was actually passed over this wire. After the device deployment, from the aortic side, through a 4 French sheath, 14 into 22 integrity stent was actually passed through that fenestration, stented open, and at 3 years follow-up, the child is actually off medications, and the fenestration is still shunting left to right. The fact that the patient had trisomy also sort of prompted the team to actually take this approach at that point. So, of course, I also wanted to mention about this. I came across this while I was looking up literature for this talk, and we know some things, we still don't know some things. So I came across 3 reports of aortic dissection after PDA device closure in adults, where the dissection was, the origin of the dissection was exactly at the aortic end, or the duct, the aortic side of the occluder, which was used to close the defect. So, I think it's a word of caution. It's good that we are aware of such things. So when we see abnormal shapes and peculiar shapes, and when we are thinking what device to use, it may be good to think about this as well, how we can prevent such things in future. It may be because it is calcified and brittle in the adult, may not imply as much to children, but it's good to know that such things have happened. So to summarize, essentially which ducts to close, it's a multi-step decision-making process, and there's no replacement to a thorough clinical assessment. It forms the base of anything else that follows. Test occlusion with a balloon, challenging, device quite helpful. There is reasonable data, but still we need more information. What happens like 10 or 20 years down the lane to these patients? And how to close oversized duct occluders may work for the majority. Some of them may need other devices. Of course, there is always the option of surgery, and this partial ligation seems to be a good option. And it's always good to remember that we should try our best to do no harm. Thank you so much. I have to thank KK sir and one of my friends for a couple of the slides. And thank you for your patient listening. And thanks once again the organizing team for my invitation.
Okay, thank you, Navneeta. Any questions or comments?
One is, when you image by CT in an adult patient with PDA, how do you size based on CT measurement the size of the device?
In the CT measurement?
Based on the CT, how do you size the
device? Based on the CT. So CT, I would say, is like step one. So sizing, as Dr. Anuradha was mentioning, like it is again, how it looks on whatever imaging we have, echo, CT, finally angio. And in older children, adolescents, adults, how I go about it is not only looking at the PA end and the aortic end, the length of the PDA is also very important. So sometimes how these oversized duct occluders actually work in this setting is that they conform in such a way that they can actually compensate for some of the length that is needed as well. So generally in the children, what we do is we measure the PA end and we add 2 to it, to the PA end of the device. That's how we do it in children. In slightly older children and adolescents, we actually, how we go about it is we think about it like house in the children, and we decide on a size and we take the next size. So that sort of accounts for the slightly bigger length. So this is just like a rough guideline, but of course the measurements, actual measurements will matter, because in some cases, like I showed in that dissection image, we can see that it was a really long PDA and it was a vascular plug. The aortic disc of the vascular plug, which actually they intended to be in the aorta, were actually pulled into, like much into the duct. And the vascular plug, the disc is not like our aortic disc of our PDA device, it is more sharp. Our PDA device, actually we can mushroom it, we do it a lot of times, we mushroom it, and we actually do intraductal deployment when we have a slightly longer PDA. So if the PDA length is not too bad, then we can decide sort of based on the PA end itself. If it is a long PDA, then we will actually have to take in account the length of the PDA as well. So these are the factors that we consider, and I don't think there is one formula. I will leave it to the
question about the length of the PDA. I am very large vascular plugs. So those are the ones which we use for very long ducts. Now, go ahead.
No, my second question is, when you have hypertensive duct in adult patient with hugely dilated PAs, where PA roominess is not an issue.
Where PA?
Roominess is not an issue, accommodativeness is not an issue. Would you prefer a device with 2 retention discs? Or still you will go with the oversized ADO1 type?
So personally,
no matter the shape of the duct.
Yeah, so personally my preference for the older patients with the huge ducts is an oversized duct occluder device. Primarily for the reason that the 2 disc devices, mainly the ones that we have are the muscular VSD occluded device or the ASD device. ASD device, there is no length to it at all. And the muscular VSD device, the regular one, has a 6 or 7 millimeter waist. So the 6 or 7 millimeter waist of a muscular VSD device, as I showed in one of the pictures, it generally is not, in some patients where it is short, it will be enough, and there are many reports, and I think in our unit itself we have used muscular VSD when we think that it is not that long. But for the very long ones, the best option that we find is an oversized duct occluder, because as it conforms, the conformation sort of adds to the length. And that's what we find is useful. But of course, it's a personal choice. Vascular plugs could be another option.
But risk of ambulation would still be there with an ADO1 type, when there is a pulmonary hypertension is there.
See, the problem is, I'll tell you, pulmonary hypertension is not synonymous with vascular resistance. What happened in the West is that they would just go by cath lab numbers. So anytime when they found anything borderline, they would put a VSD device, and they wouldn't, because then if the PA pressure becomes suprasystemic, the device would pop into the aorta. That was the reason. But if we take into consideration all these features and decide the operability and then keep the device on cable for 15 minutes or 20 minutes, showing that there is a definite drop in pressure, and then release, I see no reason to use VSD device. I'll tell you, we have presented our data of hypertensive PDA maybe 12, 13 years back in Annals of Pediatric Cardiology. And it was probably one of the first papers on pulmonary hypertension, such a large database. So we have never used, not even one patient with muscular, all with ADO1, all with ADO1. And wherever we thought that they were inoperable, we would leave them on pulmonary vasodilators. So I think that, in my opinion, muscular VSD has no, VSD occluder has no role as far as this is concerned. Because then if you are using a muscular VSD occluder, probably you are treating patients who have already Eisenmengerized at that point in time, if the PA pressures were to go suprasystemic. Only one comment I want to make in the interest of time, and that is pulmonary artery diastolic pressure. Now, when we dealt with pulmonary hypertensive patients, and when we made a loop and put one more catheter in the PA and then there was a huge pulmonary regurgitation. So never go by diastolic pressure when you do balloon occlusion, always by systolic pressure. Because the amount of pulmonary regurgitation by doing an angiography in the aorta, you have to see to believe how much regurgitation occurs, definitely drops the pulmonary artery pressure. Absolutely, because there are two. One is the wire loop, then there is a huge balloon there, and then there is one more catheter. So all these things. So systolic pressure is a better indicator of reversibility. Okay, so in the interest of time, I think, thank you very much, Navnita.
Thank you.
So we'll go on to the next talk, and that will be given by Kavita on PDA device closure, step by step, tips and tricks. Over to you, Kavita.
Thank you. Thank you, Dr. Srinivas and the Nizams Institute team for giving me this opportunity. Thank you all seniors also. So my talk is going to be pretty basic. I think Dr. Srinivas requested me to cater to the young audience here. So I won't be going into the hypertensive PDA or the low birth weight PDA. So the PDA was the first congenital heart disease to be treated by percutaneous intervention. So in 1966, Portsmouth did the first transcatheter closure using 18 French sheaths. So since the last 50 years, we've come a long way. Now we are at 3 French sheaths in extremely low birth weight babies. So, and then indications have already been discussed. I think we all agree that most of the PDAs need to be closed except the silent PDA, and there's some controversy about the small PDA which has a murmur. So coming to the techniques, techniques can be in 3 ways. One is a conventional arteriovenous approach, so where we have arterial and venous lines, and we are going more and more towards a single or simple venous approach. And the third one could be a retrograde approach, and in some cases with difficulty, we can do an arteriovenous loop. So I just have examples of each. So in the conventional arteriovenous approach, so we put 2 sheaths, the arterial and a venous sheath. And the arterial sheath is used for getting a pigtail angiogram to define the PDA. And then we also get continuous monitoring of blood pressure, and if in case we need, we can get an arterial blood gas from there. And this is, we are going more and more, for simple PDA occlusions, we are going the venous route, but this can be used for the large ducts, and those with abnormal morphology like the types B, D, and E. So the step-by-step technique, so we see a pigtail catheter in the ampulla, in the descending aorta next to the ampulla, and then we define the PDA, so this is a lateral view. And then, actually I'll come to the other views also, but this child we only have a lateral view. And then, so the next slide shows we come through the femoral vein with a Termo 0.035 Termo wire and cross the PDA. And the best one is to use a straight-tipped wire. So that shows crossing the PDA and going into the descending aorta. Then followed by this, we go through a catheter like a 5 French JR or 5 or 6, and then go down to the descending aorta. The wire is exchanged for a Amplatz stiff wire through which we put the delivery sheath, either Amplatz sheath or Mullins sheath, and then the next one shows the device is loaded, and I'll come to the sizing of the device subsequently. So through the venous route we are passing the device, and then you come down to the descending aorta, you unsheath the device, so the aortic end or the retention disc is outside. Here it forms a little cobra-like appearance, but when you withdraw it, then it conforms. And then we check the landmarks both by angiography and by echocardiography. So a good angiogram is very essential for this, and then also the air column, the tracheal air column, usually the anterior end marks the narrowest part of the ductus, and make sure that when we're using the ADO1, so now the aortic retention disc is in the ampulla, and then a small tug you can give for the ADO1. For the softer devices, we should not expect to see a resistance or tug. And then, and before deployment, we should make sure that the narrowest part of the PDA is stented, means the device comes through the narrowest part of the PDA. And that's what is happening there. And then after checking the position both by echo and by the angiogram, we can do another angiogram. Since we have the pigtail in the aorta, we can do a aortogram and check for the position of the device. 1 second, yeah. Are they running? Yeah. Okay. So this was supposed to have this one? Okay. So this is the PA end of the ductus at the anterior border of the air column, and so the PA end of the device has to stent this portion, otherwise there could be embolization. And then we perform an aortogram to make sure that there's no aortic obstruction with this retention disc, and then subsequently, after ensuring a perfect position both by echo and angiogram, we can release the device. So this is the regular arteriovenous approach. Yes. Then the second one, and the one we perform more commonly now, is a simple venous approach. So where we are not getting any arterial access, it is completely a venous approach. So there are advantages to this. The main one, as you would imagine, would be not having an arterial access. So it avoids all the vascular complications, especially in a small child. We could end up having femoral artery spasm, thrombosis, ischemia to the leg. So it avoids all those, including sometimes you have false aneurysms, fistula, so all the vascular complications it avoids. Because we are not getting an arterial sheath, there's decreased fluoroscopy time, decreased procedure time, and also the requirement for heparin is less because we are only going through the vein, and then less contrast use, and we can avoid using the injector, so we can do hand injections, and also because of this, we also can use less manpower. Of course, it comes with a little disadvantage that we do the angiogram after crossing the PDA in the ampulla or the proximal descending aorta. So this sometimes can cause some spasm. So that measurement can be undersizing the device because the ductus may go into spasm because we are across it. So in this technique, we should rely on the echo sizing. So a good echocardiographic definition and the size of the, so sizing tends to be based on the echocardiogram, not so much on the angiogram. And we use the angiogram for the landmarks. So a perfect echocardiographic measurements are important. And then since we don't have a pigtail in the aorta, we sometimes, we may miss aortic position. The aortic disc may sometimes protrude and cause some iatrogenic coarctation. So we won't have that by angiography, but that's why, a good echocardiogram post deployment is very important, and then we will not have an arterial blood pressure tracing. Those are the disadvantages. And so this one shows that, so we come through the vein, femoral vein, and across the PDA like the other conventional method, and then through the, so the angiogram can be done either through the multipurpose catheter that you initially come in the thermowire, or some people put the sheath. So the size of the sheath we pick depending on the PDA size that we measure by echo. So we can put the delivery sheath and do a angiogram. So here we have the delivery sheath, and here this is not defining the PDA, so it's a little more proximal. So it's in the proximal part of the PA side of the ductus, it's not defining well. So we can move a little bit further down, and even this is not defining. So it's best to keep the tip of the catheter somewhere in the, after the ampulla, in the ampulla or the adjacent descending aorta. So this one shows that you've moved a little bit more into the descending aorta, and so you now can define the origin, the ampulla of the, see again the size is not very accurately measured, so we are basically looking at the landmarks, and there's a little bit more frozen image where it shows the ampulla and the ductus, but again we are not measuring the size, we have measured it by echo. And then the rest of the procedure is same. You load the device, come down, you unsheath the device, pull the aortic disc towards your ampulla, look at your landmarks, and then deploy the device. And of course, you will not have a aortogram here. So you're basically depending on your echocardiogram for the position. So you can do an antegrade injection through the delivery sheath, but you will not have an aortogram here. And then the device is released. So for simple straightforward cases, we are always doing this to avoid all the vascular complications of getting an arterial access. So it is safe in experienced hands. I mean, little experience is needed because we are all used to seeing this aortogram. So safe in experienced hands, but the prerequisite is a good echocardiographic assessment of the size and shape of the PDA. And also the disadvantages, we may not have a very good angiogram of the PDA, so we can work a little bit towards getting the best angiogram possible, going antegrade. And then case selection is also very important. So we should try and avoid the single venous route for complicated cases, like whenever you don't have a proper echocardiographic definition of your landmarks, by this technique you may want to change it to a arterial plus venous route. And then large PDAs where you need, we're discussing of hypertensive PDAs, so large PDAs where you need hemodynamic assessment, definitely you'll need an arterial line. And patients that have additional hemodynamic lesions also where they need a hemodynamic assessment, we need an arterial line. And then this should be avoided in small infants with large PDAs, where we think the device size is going to be very big because they have a potential for the aortic disc to cause some coarctation. So small infants, large PDAs, avoid the single venous route. And then when the ampulla is small or the descending aorta is small, some degree of aortic hypoplasia, also we should avoid this technique because we will not be able to detect the post device situation of the aorta. Then again, so small ampulla I've said, and then recanalized PDAs also require both lines. So when we attempt this procedure and then we are not able to get a good angiogram, then we may want to add the arterial line. And whenever you think that we are not getting a stable device position, device deployment, or the device size appears inappropriate on attempted deployment, or there is device dislodgement, or we are not happy with the procedure, then we may want to switch to a combined approach. Then the other much rarer approach would be the arterial only. This we can do when we are unable to cross the PDA from the venous side, or sometimes the PDA is too small to be crossed or allow the sheath, the delivery sheath. And then the long tubular, like the type E, long tubular abnormal shaped tortuous PDAs also we can approach from the femoral artery. And this approach, femoral artery approach, we should avoid in small aortas, because we are putting the device from the aortic end, so we will not have the, so the PA end of the device will be deployed, followed by the aortic end, so we may not have control over the aortic end of the device. And this approach usually, very commonly we do for coils, and sometimes vascular plug and ADO2s. So those devices that can be screwed on both sides can be deployed through this arterial approach. I'll show you a case later. Then some situations we may require an arteriovenous loop, where again crossing is not possible from the venous side. So this is a case where this shows an angiogram in the descending aorta, and then antegrade crossing was attempted, but after multiple attempts we were unable to cross the PDA from the venous side. So then this one shows crossing from the retrograde, so descending aorta to PDA, and then we snare these wire that has come retrogradely, and then the rest of the procedure is normal. So we snare this wire through the venous femoral vein outside, and then come antegradely, and then the rest of the procedure is just like the single venous route. So again, the delivery sheath is going through the ductus, through the wire that was snared, and then finally the device was able to be deployed. Not able to advance. Not able to advance. Close and open. No, it won't respond. No, sorry. I'm sorry, whenever I try to run the videos, the PowerPoint is stopping. I'm sorry for that.
Are there many slides, Kavita, or you can?
Oh, slideshow. I'm sorry. Yes, okay. So quickly about the angiographic projections we use. So crossing the PDA can be done in the AP view, and defining, so getting a good angiogram, whether it is single venous route or arteriovenous route, is important. So the most common view is the straight lateral view, as was shown. So straight lateral view. Another important view is a 30-degree RAO view, because sometimes in these projections, like for example here, the straight lateral view has foreshortened the PDA. So the definition of PDA, the length and the diameter is not very clear, and the RAO view here in this has actually brought out the ampulla very well. So this is very good for measurement. And sometimes it's vice versa. So this one on the lateral view, it's easily measurable, and on the RAO view there is some overlap. So you have to take both views, and then when you're after deployment, if you want to check the LPA, you should do a PA bifurcation view, which is cranial LAO. Is my time over? So quickly, device selection depends on the size of the PDA, the morphology of the PDA, whether there's ampulla present or not, and the descending aortic size. So we've discussed about the measurement, so I'll slip. So the first important thing we have to do is get an accurate measurement of the PDA, both echocardiographically and angiographically. So this is the narrowest diameter of the PDA. So this is the PDA, and again this is lateral view showing, and then something like a tubular PDA will have uniform width, and then the length of the PDA is measured. So some pictures to show that. And then so the device type, when you base it on the duct size, anything less than 2 millimeters. I mean, we used to do coils, but now I think, since we have the piccolo, then the coils are, very much not so often used. And then ADO1 can be used because it goes to 14 and 16, the maximum size. You can go anywhere up to 12 mm ADO for ADO1. And if it's a bigger than that, then your choice would be a muscular VST occluder. And for ADO2s, you can use between a PDA size of 2.5 and 5.5 mm. And for the long tubular PDAs, AVP 2s and 4s are recommended, and these are the approximate PDA sizes that can be used. And of course, the multifunctional conars we can use as appropriate. And then it also depends on the morphology of the duct. So this conical PDA type A Krishenko, where there's wide ampulla and it's a conical shape, the most common one we use is ADO1, so the single disc device. And then there's a window type, so very short neck it has, so ASD devices are preferable, but again, there's no hard and fast rule, it all depends on our assessment, and so there's no rule of the thumb, so assess carefully the morphology and then you decide, because for some things you can have choices that can be multiple. For a tubular PDA that has a uniform diameter, vascular plugs work well, ADO2s and sometimes muscular VSD devices. Now these saccular ductus, I haven't actually had a chance to do, but I think my MFO will suit. And then elongated ducts where there's a narrow PA end. Sometimes coils are useful because the PA end is very narrow. And then this F for the fetal form of the ductus, some cases have been reported using AVPs. So it all matters on your assessment and also your experience. So you have to be comfortable with the device you're using. So how do we size the device for a PDA? So I think everybody's familiar with this ADO1. So this is the aortic retention skirt, this is the PA end. And so 8-10, when we say 8-10, the PA end is 8 and the aortic end is 10, and then there is retention skirts on either side. And so the size you pick up is mostly 2 to 3 millimeters more than the PA end of the duct. So if my PDA is 5 mm on the PA end, then I would pick like a 6/8. So 6 on the PA end and 8 on the aortic end. And we've discussed hypertensive ducts typically tend to use +4 millimeters, but it depends on the morphology, I guess. And for muscular VSD devices, again, 2 mm plus. AVPs, you have to go higher, or approximately twice the diameter of the PDA. And coils, I won't go into details. So where the device fits is also very important. So for an ADO1, which is a conical shape, and this is the narrowest part of the PA, make sure that the PA end fits through this. So what holds the device in ADO1 is the stenting. So the narrow part of the PDA holds the device in place. So if you release it proximal to this narrow part, then it will not be stable. So make sure that it is stented. For ADO2, that is a double disc device. Ideally both these discs should be on either side of the PDA, but of course it depends on this length. But this can be conformed to the PDA shape. And then the vascular plugs, and sometimes the ADO vascular plugs can be intraductal. So especially for the tubular variety, this is intraductal, so it's all within the duct. So this is a cartoon of that, and this is the double disc like the ADO2 can be fit into aortic side of the ampulla and then the PA side of the ductus. So this is an example of an ADO2. I won't go into the case details. So it is nicely fitting into the aortic retention disc is here, and this is at the PA end of it. Then this is a tubular PDA. So this is arterial only access. So through the artery in the pigtail, you see a very tubular ductus. This is an RAO view, and vascular plug is suitable for this. So I'm sorry. I think in the interest of time, I'll skip. So I was going to show a vascular plug there. It's again not moving. Okay, PDA will skip because we did this. I'll just move on to, yes. Couple slides only on procedural problems. So inability to cross the PDA may happen, and sometimes we may have to cross, use different wires or cross retrograde and snare it. Inability to pass the sheath happens with the small PDAs or when there's a spasm of the PDA, so you can give the baby a little rest and push some volume. And kinking of the sheath can happen in the RVOT when you are trying to pass the device. So a braided sheath would help alleviate this complication. Sheath and device incompatibility, the device manufacturer gives you the sheath size, but typically for Amplatzer you should use +1 from what the manufacturer has given. Vascular injury and thrombosis when we do the arterial route, and then residual leaks. So 89% 1 to 10 to close.
So residue leak around stable, but if it is an intraductal, intra-device shunt, you can leave some of it. And then embolization happens when there's a size mismatch. So the assessment of size is very important. Even on echocardiography, I think the recommendation is to size it on a two-dimensional picture, not on a color, because color overestimates. And then improper placement, tension on the cable. This is important because when you release, you cannot have a tension, as this happened to me actually. The device just recoils. So when you release the device, when there's tension on the cable, the device really shoots into the descending aorta. So be careful with that. And one important problem, LPS stenosis or coarctation of the aorta, rare but more common in low birth weight patients, especially when you're dealing with large PDAs. And coarctation can happen when the aorta is narrow. So, get a detailed assessment of aorta and LP anatomy prior to procedure also. When the ampulla is small, this can happen, or sometimes when the device is delivered arterially. So that's why, to avoid these complications, these two assess the duct and P anatomy very well during the procedure. Some papers have recommended if the weight of the child to PDA ratio is less than 0.8, should be approached with caution, more so in the neonates. Then some other authors have said descending aortic diameter should be at least 10 mm when you're using an ADO2. And some centers measure the pullback pressures to make sure there's no coarctation or LPS stenosis. And then aortography after device deployment, both to define your LPA and to define your descending aorta, and good echo imaging. I think we do less of aortography. You can rely on your imaging to look at LPA. So make sure you image LPA, get the Doppler velocities. Anything less than 2.5 should be okay. But for coarctation, there should not be any flow acceleration. Coarctation, same things. I think I should stop here. Yeah. So quickly, tips and tricks. Through the talk, yes, we've discussed. So good echocardiography imaging is very important. Measured in 2D, not color. Echo-guided venous puncture is good to learn. Straight tip wire for crossing. And sometimes if your catheter recoils when you're doing a venous approach angiography, you can use a Y connector and put a coronary guide wire, like a road map, so that the catheter doesn't come back into MPA. Poor angiograms, please don't accept them. Tracheal air column you can use as a landmark. Appropriate device, as we discussed. Avoid tension on the table and on the cable. And for when you're using soft devices like ADO2s or vascular plugs, you're not going to expect that at the tug which you get for ADO1. So a little increased pressure when you do, the device comes back into the PA. So don't expect to get that resistance. Then check color flows and Dopplers post deployment prior to release. Intra-device shunt is okay, but around the device means the device is unstable. So around the device residual leaks you should not accept. Then have plan B. If that procedure fails, keep rescue equipment available as we've been discussing in the morning, and then have surgeon backup even though it is a PDA, because you should never assume anything. Like Sudeep was saying, whenever we think everything is fine, something happens. So, and then people always say, never give up. But I think sometimes knowing when to give up is also important. Bhagavad Gita, Krishna says, Manasastu para buddhir, means sometimes our mind says, no, I can do this, or I should do this, I'll be able to do this. But we should use our intelligence and try to decide when is the right time to stop. I think it is more important to understand when it is right time to back off in the cath lab. And yes, so also, just like we have caution about radiation, we should leave our shoes and ego outside the cath lab and go, because cath lab can be very humbling. Thank you very much.
Thank you, Kavita. Very lucid. For interest of time, we will avoid questions. Very lucid, Kavita. Thank you so much.
Thank you. I'm sorry for exceeding the time.
No, our next speaker is Dr. Amitabh. He's good. Very senior cardiologist from Kolkata. He's going to speak on RVOT PDS stenting, pulmonary atresia. You're trying to rest.
I'm sorry to Dr. Bakru. Apologies for allowing me to present before her. I'll be talking on the RVOT and PDS stenting. RVOT and PDS stenting. Though the topic says that RVOT stenting in pulmonary atresia, I thought it would be slightly difficult, so I've dealt mainly in RVOT stenting in tetralogy. So I'll be dealing with the pulmonary stenting first. When in 1981, FDA first approved prostaglandin. At that time the prostaglandin was used to keep the duct open in case of pulmonary atresia, babies with pulmonary atresia or in transfusion bleed arteries. But what after that? What next? So when ductal stenting first came, pioneered by Masni Alvi and other stalwarts who first do these procedures, we will go for a ductal stenting to keep up, we use the coronary stents to keep up the ductus patent so that the baby can go to the next stage. So this is I'll show first a routine one. We usually nowadays we take the axillary axis either from the left or from the right, depending on the sidedness of the arch and the way in which the duct is facing. So this is a common one, which is the left axial axis. You can see the duct is quite stenosed, and we have passed a coronary wire, and the stent has been put in place. What next? So the stent is expanded and gradually takes its shape, so that the duct actually remains patent till the baby is the next stage of operation. So here is an example where there is a change in approach. Our assessment was wrong, so we took the left axillary axis, and later on we found that the approach to the duct was very difficult. We could not approach. Usually we approach through a right coronary catheter, or sometimes we might have to use different combinations of different catheters. But in this particular case, we had to change our approach. We could not negotiate. Luckily, the child, this is an example where you can see that the catheter was actually taking a kink, and we were not unable to approach the ductal origin. Hence, we took a change in approach. We did a repeat angiogram, and thereafter we came down from below. From a venous axis, the patient had a VSD. We approached the VSD, and through the VSD we approached the aorta and went through the arch to stent the duct. So this is a change in approach. Here we can have some of the difficulties which we usually face during ductal stenting. That means the choice of the stent. Obviously, we have to cover the whole length of the duct, covering the aortic portion and the pulmonary portion, because even if 1 millimeter is missed, there might be complications where the ductal tissue, though we can consider it negligible, but it has tremendous potential to occlude either at the aortic end or the pulmonary end and can stop the flow. In that case, the stent has to cover those two things. At the same time, if you carefully look at the third picture, that is when the stent in a totally curved position is covering the aortic and the pulmonary ends, as soon as the stent is dilated or the stent is inflated, it takes a straight course. And that's what happens is it rises a bit above 1 or 2 millimeters above the aortic flow. If it rises, if our estimation is slightly wrong, then it can block part of the or even the whole of the aorta, which is not good. And even then, it can go inside one of the preferably into one of the branch pulmonary arteries, which makes the next step difficult. That means there might be differential growth of the pulmonary arteries, which is the main essence of a ductal stenting. Either the RP will grow higher or the LP will grow higher, and the operation might be far more difficult. Furthermore, if you are not in very good liaison and if you do not have good amount of dinner parties with your cardiac surgeon, then the cardiac surgeon might scold you during the operation, because it will be very difficult for him to extract the stent or the remnants thereof from the pulmonary artery during the surgery. So these points, very little, but has to be taken into consideration. This is an example of a repeat balloon dilation of a stented duct. What happened is this particular child, we did a ductal stenting during infancy, during early neonatal age group, and there was differential growth of the branch pulmonary arteries, or rather the branch pulmonary did not grow well, but the baby's weight was only about 4.5 kilos, which was precluding him to go for a total repair. This was a VSD pulmonary atresia. So we decided that we would go for a repeat ductal stenting and dilate the duct a little bit more. It was very difficult because whenever the duct is protruding above the base of the aorta a little bit more, 1 or 2 millimeters, it's very difficult to wire it. And we have to take the same approach, the axillary approach. Luckily, we could wire it, and then we put a second stent and dilated it to another 1 millimeter more for a prospective prospective pulmonary artery growth. And this is a restenting of a stented PDA, another approach. From the lower end, that is from the femoral approach, we restented because of the same reason. This is a ductal stenting means closed ducts, though it might sound apparently abnormal and as if apparently undoable. As you can see on the angiogram, the duct is not seen except a thread or maybe half a thread. We have collected out about 12 cases like this. What we did was we initially with a normal coronary wires, regular coronary wires. Then when the RCA catheter was held by someone absolutely at the neck, we used a Khaya. So there is for the CTO wires, and thereby we could actually close open the closed duct, just like CTO cases, and could stent the ductus. This was another example where the duct was ultimately stented and the baby went on well. Now we're coming to the RVUT stents. The RVUT stents for a pulmonary atresia, we have to perforate the valve, which I have not shown here. I have chosen the cases where there is a severe tetralogy of Fallot, where the baby is not suitable for a total repair, and because of the baby's weight, the baby is not suitable for a BT shunt as well. There has been tremendous debates whether a BT shunt is better or a ductal stenting is better, because there has been several overflow and underflow situations which precludes a BT shunt. In today's world, a BT shunt preferably would get a second spot compared to a ductal stent, RVUT stenting, because it would give you a more valuable and predictable increase in the pulmonary sizes and the pulmonary growth compared to the BT shunt. Here, we chose initially when we started the program, we used to do the peripheral stents. Here, this is an example of a severe tetralogy fellow, where the baby was only about 3.5 kilos and the branch base has not grown well, where you can see well in the angiogram. We chose a peripheral stent. This was the initial part. We chose a Hercules 7-80 with an optimal positioning. At that time, we were concentrating more on the RVOT, right ventral outflow tract, so that we could cover the whole of the right ventral outflow tract. Otherwise, the whole exercise will go in vain. And obviously, we have to take care that the stent doesn't slip either below or above. This was a post-operative case. I have included this case to show the spectrum. This was post-operative case with the repeat right ventral outflow tract, where we have used the Cook formula 10:30, and it has taken into shape. Obviously, the radial strength of the stent has to come into action here, and this is a post-operative case. The radial strength has to be taken. This is a post-operative right ventral outflow tract obstruction. We used an Andra stent, and in fact, we had to use two stents. This operator was Dr. Shivakumar at our center during the program. This is a post-operative RVOT where it has two Andra stents because of the huge radial strength required. But what are the pros? What are the cons? We have to remember this is extremely easy to perforate the right ventral outflow tract. Just like in case of finding a place in a busy streets, we can go from one street to the another. Here, though one is holding the catheter as to the best of the knowledge and belief to the extent of the RVOTO, in finding the RVOTO, the coronary wire which we often use to cross has actually gone elsewhere, and it has perforated the pericardium and has gone elsewhere. So this is a dreaded effect, and as you can see here, this is a narrow RVOTO with very, very extremely small branch pulmonary arteries, but there has been some amount of leak in the pericardium. So what are the lessons learned? We have to delineate the target, assessment of the RVOT, pulmonary valve annulus and MPA in the branch pulmonary arteries. We have to rule out coronary compression. Here also there is a controversy. When I asked some of my colleagues, from some of our senior colleagues, they said when you are doing it in an emergency, you should not remember where is a coronary artery, whether it is creating of this or not, because you have to save the life of the patient. And obviously, in a small child, you cannot take care of that much. But when you are doing an RVOTO, on repeat RVOTO, recurrent RVOTO, or in post-op cases, we have to take care of that one. While the RVOT is dilated and compressed from within without a balloon, angiography assumes the RVOT and the choice of stent. Crossing the RVOT, preferably we use a JR or TIG catheter, which actually has a tertiary curve, which gives us an advantage. It can go right up to the right ventral outflow tract, but the chance of perforation of the thin RVOT should be kept in mind. Preferably from the RV mid cavity with a JT thermowire or a restrictive thermowire or even a coronary wire. Blocking now comes to the situation where the blocking the whatever flow was getting, whatever flow was going through the RVOT, whatever available forward flow, we are like to stop it for a while, even for a few seconds, and that can cause a huge cardiac arrest. The choice of stent smallest possible, enough to cover the RVOT, pulmonary valve annulus. Even though if we can spare the pulmonary valve annulus, that is more so, but if not, we do not care at that point of time, and should not be hanging well into the RVOT, which will cause more of an arrhythmias and can cause severe problems. It should just be with the main pulmonary artery and the RV cavity. The needs reasonable radial strength to keep the wave clear. We use coronary stents, peripheral stents, Cook's formula, and Andra stents. And this is we use the right coronary catheter and the TIG catheter mostly. And trackability, needs to be considered for the stent. They should be well trackable. The cardiac arrest scenario requires a firm support, either an ultra steep wire if the child is bigger, or if we often use a V18 wire or a Grand Slam wire. You should not hang too much in the right ventral outflow tract. And the prospects of future interventions like room for redilatation or a further stent placement or pulmonary valve replacement should always be kept in mind, so the stenting should be optimal. Thank you very much.
Amitava, thanks for that quick one and covering both the aspects of ductal stenting as well as RVOD stenting. I think since he has to go and catch a flight, I will let you go without a question. Okay. So I think we'll move on to the last talk of this session, and that will be given by Shweta on PDA device closure. Oh, Bhargavi is talking. Okay. On PDA device closure in preterm babies. So over to you, Bhargavi.
Thank you, everyone. We had an excellent talks from my previous speakers regarding PDA. So my talk will be crisp regarding the preterm PDA. So we have a preterm 28-weeker, 900 grams. So this child did not cry immediately on birth. So positive pressure ventilation was given, surfactant was given. Day 3, now there is a tachycardia and the story reversed. Now there is a tachycardia and bounding pulses. We can see that there is an X-ray where there is a pulmonary edema is there. And at this point of time, neonatologists will call us what is happening to this baby of 900 grams. So coming to the PDA, Nirada madam has described the systemic hypoperfusion and pulmonary overcirculation. So what happens due to this? There will be bounding pulses, wide pulse pressure, hyperactive precordium, and also persistent tachycardia. Mainly, most of our preterm neonates at this point of time will be ventilated. So there will be increased ventilatory settings and higher FiO2 requirement at metabolic acidosis step in. So this is the point where we have to assess what is happening, how much is the pulmonary overcirculation or systemic hypoperfusion. In the echo, the parameters mainly focused is the ductal size, LA, then the shunt direction. This is very, very important in a preterm. It should be left to right. Don't go with a preterm PDA of bidirectionally shunting or right to left shunting, and Doppler flow patterns, and also the volume overload of left heart, that is pulmonary overcirculation by LA/O ratio, and systemic hypotension also should be assessed by the Doppler assessment of listening ATA and also SMA. So these are the Doppler assessments, but we know the classification, Krichenkov classification of PDA. What is the difference in this last slide of PDA, fetal PDA, F-type PDA? So this is, it's a long tubular. You will have dilated both the ends. You will have a pulmonary ampulla and aortic ampulla. If you take a clock, it is like 10 to 4 o'clock position. This is the angulation that differs from the remaining all PDAs. So in this PDA, when to go for device, when to go for the surgery. That is the next one. So as we saw first case, there is a pulmonary overcirculation. So neonatologists, they have dealt with everything. They balance the fluids, balance the ventilation, balance the circulation, maintain the preload, and there was a need of vasopressors. Here, there is a danger that it is means systemic hypoperfusion is so much. And they have given paracetamol 2 doses, they have tried ibuprofen, still same situation. So next is what? So here comes, is it surgical closure we should do or transcatheter closure? This is a discussion what will happen. So surgical closure ligation is a gold standard, but now the trends are changing towards the transcatheter. Why? Because at that situation, child will have a more edematous, will have thrombocytopenia, bleeding disorders, and going ahead with the surgical ligation, you have its own complication. Like Chylothorax can be there, pleural effusion, pneumothorax, hypertension which we have to control in a 800 grammer or 900 grammer. It's very difficult to control in that neonates. And the most important thing, sometimes we don't know is it a lymphatic duct which we are going to ligate or LVA. That is also one thing which can happen. So those are all the limitations, but still I would say surgery will be a gold standard. So at this point of situation, it should be a multidisciplinary approach. You are not the one who can take a decision. We are just like a plumbers. We are going and doing the procedure, that's all. The decision should come from neonatologist who is seeing the baby continuously monitoring the pressure. So neonatologist, cardiologist and anesthetist, very, very important. So these are the persons who are maintaining in the cath lab the ventilatory requirements, metabolic status, hemodynamics, and also the vascular access. Next thing is cath lab team should be informed. Everything should be on the shelf. Everything should be ready. And most important is transport team. These babies are very labile that you can't transport from one NICU room to another NICU room also. So transport team should be there. Maintaining the thermoneutral environment, we should transport these babies. So here we can see the echo. Definitely the left heart is dilated and this is the duct. So in this duct, when you are assessing for device closure, what we assess is what is the length of the duct and any narrow point, what is the diameter of the narrow point. These two things are very important in assessing a preterm PDA. Any restriction is there. I am saying mild turbulence is there in that echo. If there is no turbulence continuously and diameter is more than 4 mm, don't attempt a device closure in those cases. So now the thing came. So that baby received two doses of paracetamol, still same X-ray. So we have taken for the device closure, neonatologist and cardiologist along with anesthetist. So the vascular access. Here comes the vascular access in less than 2 kilo. Best is through a ultrasound guided. So we'll understand. So vascular access to be taken under ultrasound guided and 4-inch vascular access to be taken. And when you are shifting the baby to your cath lab or if you are doing bedside also, thermoneutral environment should be maintained. Because slight hypothermia causes metabolic acidosis and whatever you do, it will be reversed back because PA crisis can happen when there is a hypothermia. So there will be like warm blankets or cover up the child and the transport in the incubator with the monitoring. So these are all necessary in a preterm PDA. So procedure steps, we will take a venous axis, femoral venous axis, ultrasound guided. There is no need of arterial axis. So, and complete hemodynamic workup is not recommended. So, what I want to say is the procedure should be quick. The child should not be there in the cath lab for more time. We should do procedure and come out. All the hemodynamics you assess clinically and echo guided in the NICU. And the procedural is mainly on the transthoracic echo. When you are deploying the device, you have to see arch flows, LPF flows on transthoracic echo. Although angio you do, but minimize the exposure of radiation and also limit the use of contrast because there is renal impairment in these children. So this is the angiogram. So we went ahead. Femoral axis. We went RA, RV and then MP and crossed the duct. And we have given, this is a 4-French implanted delivery system. We have given an angiogram and assessed the PDA. Again and again, PDA device is through only echo, not through the angiogram. Don't change your decisions in the cath lab. So this is the PDA which I was telling. So this is actually review of review article completely. So I was telling the preterm PDA is like 10 to 4 o'clock position and which diameter is just here there will be most of the time 70% the constriction will be at the pulmonary ampulla, just distal to the pulmonary ampulla. So this diameter should be required to understand the device size. So this is about the device. This is the Amlazar Piccolo which is the FDA approved one. there are some devices placed like vascular plug 2, 4 and MVP, but those are all not FDA approved because what happens, the longer length of the device causes either aortic or pulmonary site stenosis. So this was the only FDA approved. We have like 3 sizes. It will be 3, 4, 5 the diameter, and the length will be for each one 2, 4, 6. So these are the lengths and these are the diameters. So the retention skirt, this is the retention skirt. It will be for 3, 1 plus, for 4, 1.25, for 5, 1.5. So that is the calculation we have to see. And same thing, the device diameter should be selected like 1 mm larger than the narrowest diameter of the PDA. And if you have a length less than 12 mm, then the device length should be 2 mm, not more than, like, don't take a 6 mm length device for a less than 12 mm length PDA. If you take longer length devices, there will be either aortic or pulmonary obstruction. So this is how we do the device closure. See, we opened one disc. We are coming towards the PA, but we are seeing the aortic flow. This is must while doing. It should be done like it should be a team approach. At least 2 cardiologists to be there, one to assess the echo while doing and one to do the procedure. So then the post deployment, we have to assess how is the arch flow and how is the LPA flow, and then don't accept if the velocities is more than 2.5 meter per second. Don't like it is 3 or 4, don't leave the child like that because it is an obstruction only. So again, transport the child properly in a thermoneutral environment to the NICU. So when coming to the device protrusions, it can be left side or aortic side. Pulmonary side or aortic side. So velocity should be less than 2.5. You have to serially monitor. If you have an LPA obstruction, you see how the perfusion is there. If there is a perfusion is worsening, obstruction is worsening, it's better to retrieve the device. Not possible, go for surgical removal. That is a best thing. Aortic side also same thing. If not possible, go for surgery, but difficulties are in less than 2 kilo, going and doing a surgery is also difficult at that point. So that is why transcatheter retrieval trial was given in this one. So contraindications, if you have a PDA, length less than 3 mm, short duct, don't go for device closure. If your narrowest point is more than 4 mm, that means it is very large duct, and age less than 3 days, you have to medically manage. Don't go abruptly jump and do a device closure. This recommendation came during that FDA, less than 700 grams, don't go for device closure. And if there is an active infection or cardiac output is dependent on the PDA, then also we should not go and do a device closure. So this is our institutional data of 26 cases which we have done of preterm PDA. Most commonly used device is 5'2", that means length is 2 mm only, we can see. So that is more important. And our data, we had one mortality. Actually, this is 550 grams because 24 days of stay, almost 1 month of stay. Then we have taken a combined, actually from the neonatology forum. Remaining babies are doing well, all the preterms. So preterm PDA is another important is you are preventing bronchopulmonary dysplasia. So that is very important. If you leave the duct like that for many days, they will go to BPD and they will be oxygen dependent. So the mean weight is 1100 grams in gestational age. What we have seen is 26.4 weeks. This is the birth gestational age. So take home points is determining the hemodynamically significant PDA is very important. Now in the neonatology forum, they want to sometimes close all PDAs from day 2 onwards. Sometimes they want to wait. But it's better if there is a hemodynamically significant, go for medical management, then go for either device or surgery depending on the child condition and duct size. Transcatheter procedure approach is there in selected cases. I will not say all cases should go to transcatheter. and preventing bronchopulmonary dysplasia is also needed in the closure of the PDA. Thank you.
Great talk and great experience that you could share. Any questions or any comments? I have only one question for you. In any of your cases, did you encounter tricuspid valve injury?
No, sir. We have not, till now, touchwood, we did not encounter tricuspid valve injury. What we do is we go through pressure guided cross the catheter. We'll not go through the wire. Most of the cases we went through pressure guided. We did not encounter till now any tricuspid valve injury.
What do you mean pressure guided meaning?
So under fluoroscopy in the cath lab only, but still initially we used to take a JR catheter and then pressure, we cross the tricuspid valve, then the wire will go and cross the pulmonary artery and the duct and the PDA. That we used to do.
Because that is one of the important complications of this procedure, apart from, as you very rightly said, device embolization and protrusion of the device on the aortic and the pulmonary end. But great results, and I think we must all thank you for sharing your data. And I think with that, we come to the end of this session. Thank you to all the speakers and the audience and my co-panelists. Thank you, ladies and gentlemen.
Now I would like to invite Bharat Dalvi sir to present mementos. So, Dr. Kavita Chindala ma'am. Dr. Nitin Rao sir. Dr. Amol Gupta sir. Dr. Rama Kumari ma'am. Dr. Adilakshmi ma'am. Dr. Anuradha Sridhar ma'am.
So let us move on to our final session on coactation. I would like to call upon the chairpersons for this session, Dr. Nageshwar Rao sir, Dr. Navanita ma'am, Dr. B. Srinivas sir, Dr. Bharat Dalvi sir, Dr. Amitabha Chattopadhyay sir, Dr. Kavita ma'am. Over to the chairpersons.
Yeah, I'd like to invite Dr. Prashant, who's my colleague and teammate. He's going to talk about the anatomy and imaging assessment for coagulation. So Dr. Prashant is a senior interventional cardiologist at KR Hospital.
I think we are at the fag end of the wonderful workshop. Today, at outset, I would like to thank Srinivas sir and the Nims team for inviting me for this wonderful workshop. Today, I am going to speak about coaptation of aorta, anatomy and imaging relevant to the our management and treatment protocols. So, as you know, the aortic coarctation is the localized narrowing of the aortic lumen by the reach, which is mainly because of the medial thickening, and constitute around 5 to 8% of the total congenital heart disease, out of which around 7% are present in a critical condition in the neonates. Most commonly in the males, more common in Western population compared to the Asian population. If we understand the embryology, usually it is a disease of the fourth and sixth arch, because fourth arch forms the isthmus portion of the aorta and the sixth arch forms the PDA. So there are two theories which were proposed, that is a ductal tissue migration theory and hemodynamic theory. And ductal tissue migration theory, as you know, the ductal tissue migrates to the aortic lumen, and as the duct constrict, there will be a narrowing, and that will lead to the coarctation, but it doesn't explain the other associated features like aortopathies, other congenital heart problems. The hemodynamic theory proposes that there is a decreased flow across the isthmus portion with concomitant increase in the through the PDA into the descending aorta. So that will cause a isthmic hypoplasia. But both of the theories doesn't hold true for all the cases. This is the pathological specimen of a coarctation. As you can see, there is a duct, and opposite to the duct, there is a severe narrowing just below the left subclavian. So there are different ways the coarctation can be classified. One is a discrete or a long segment, and the discrete can be classified into the preductal, juxtaductal or paraductal or postductal. While as the long segment can be classified whether there is only the isthmic hypoplasia, whether the hypoplasia extends to the left carotid and the left subclavian, and whether there is a complete tubular hypoplasia along with the isthmic hypoplasia. Also, it can be classified as a discrete vest, or discrete vest with isthmic hypoplasia, and there is a long tubular hypoplasia of the isthmus. The other way to classify the coarctation is simple coarctation, where it is an isolated coarctation. There is no associated lesions. While as the complex coarctation, where there are associated congenital heart problems, and most common of the problem is a bicuspid aortic wall, which is present in almost 75 to 80% of the cases, and that is the reason why most of the adult coarctation presents with the aortopathies. The second most lesion which is common is a patent ductus arteriosus, and usually it is seen in the infantile age group. The other problems, other congenital heart diseases like when VSDs, or in a cyanotic heart disease where it is a truncus arteriosus or Taussig-Being anomalies, or Schoen's complex where there is a LV inflow as well as outflow obstruction. Another thing which needs to be considered is whether it is present in the syndromic region. The most common syndrome which is associated with coarctation is the Turner syndrome. And why it is important? Because if you see a female coarctation, you should rule out the Turner syndrome, because they are associated with medial hypoplasia, and these type of coarctations are more prone for dissection and aneurysm formation and rupture. So they need a covered stents. Along with that, we should know that 2.5 to 5% of the cases can have Berry's aneurysm, and these patients can land up in serious cerebrovascular accidents. The type of presentation we see is a neonatal presentation where they can present in a shock-like situation where it is a duct-dependent lesion, and once the duct closes, the blood flow to the descending aorta decreases, and they will have decreased urine output, LV dysfunction, metabolic acidosis, and all. If the duct is patent, they can be relatively asymptomatic, and many of the patients go without any murmur, and they will be picked up on follow. Some of the mild cases of coarctations may be completely asymptomatic, while as the bimodal presentation is the population has a bimodal presentation, and they can present later in the life with hypertensions, leg cramps, claudication pain, or CVA because of the various aneurysm. Why we tend to miss coarctation till the adulthood is because we forget to palpate the lower limb pulse. And some otherwise they can be missed in a case of large PDS, aortic stenosis, where when you have very slow and feeble pulses in all four limbs. In a case of aortic regurgitation, where you can falsely palpate the femoral pulses, and in case of CCF. So, how we investigate this patient? First is a clinical examination, and followed by the rest of the investigations. So, as my teacher always used to say, it is a ritual. The Shisha should touch the feet of gurus. So, every cardiologist, especially the pediatric cardiologist, should touch the feet of the patient. So that you will not miss the coarctation. And along with that, you should feel both radials, and then you can diagnose any of the coarctations. Like, if there are the lower limb pulses are absent, it is a post subclavian coarctation. If your left subclavian along with the femorals is absent, it is a pre-subclavian coarctation. And if you have all the four pulses absent with carotid pulsation present, you are dealing with the aberrant right subclavian. So if the next investigations what is relevant is a chest X-ray, and in a neonate it may not contribute much because they will have basically right ventricular hypertrophy and they will have plethora. So overall it looks like X-ray of a CCF doesn't give a particular idea, but when we see the chest X-ray of the adult, you can see a figure of three signs, which the upper hub is because of the dilated descending out and the left subclavian. This is the ridge, and this is the post-stenotic dilatation of the coarctation. And along with that, in an older kid, we can see rib notching, usually which is present after the age of 5 years, and usually it is present from the 4 to 8 weeks. First two ribs are excluded because they are mostly supplied by the cervical trunk, and this is because of the dilatation of the posterior intercostal arteries, which will form the ridges. So if you see the chest X-ray carefully, and if you have bilateral ridges, it is usually juxtaductal coarctation. If you have unilateral right-sided only rib notching is present, you are dealing with the pre-subclavian coarctation, that is preductal coarctation. And if you have only the left-sided rib notching, you are dealing with the post-ductal coarctation with aberrant right subclavian notch. The most important investigation in a coarctation is the echocardiography, and it is a first-line imaging modality. It is because it is easily available. Everybody of us is trained, and it helps in evaluation of site, severity, associated abnormalities, and hemodynamics. And most important views for the assessment is subcostal view, suprasternal view, apical fourth chamber view, and the parasternal views, long axis as well as short. This is the subcostal view. As a pediatric cardiologist, we start our intervention from the subcostal view, and you can see there is a continuous flow in the descending aorta, which give you primitive idea that you may be dealing with a coarctation. And if you go by the descending aorta tracing, this is the normal descending aorta tracing, where you have sharp upstroke, sharp downstroke, and there is some diastolic reversal. While in the case of coarctation, you will have slow upstroke and very delayed downstroke. So that is the way you can identify the coarctation. And when you see this tracing, you can see the suprasternal view, and you can see there is a continuous flow below the left subclavian. and the gradient is around 4 meter per second. There is no diastolic tailing. That is why I will tell you later. So this is the apical four-chamber view of the same patient. You can see here there is a severe aortic regurgitation. That is why you are not getting the diastolic tailing in this case, because the diastolic pressures are very low. And this is a case of a bicuspid aortic wall with coarctation. If you see the echo of a newborn, you will have the right heart dilatation. Why? Anybody can tell? Because as such in a newborn, right ventricle, right heart is a dominant. But when you have a coarctation like lesion, the LVAD will go high, so there will be increased flow across the PFO to the right side, and you will have right heart dilatation. And this patient, when you have a patient which presents with a respiratory distress and the right heart dilatation without any PAPVC, you should always suspect a coarctation. There is a narrowing post of plane and there is a critical coarctation with a gradient more than 4.5 meters per second. So this is why they will have right heart dilatation. So in a case, if you have a VSD and there is a severe LV dysfunction, you should always suspect whether you are dealing with a coarctation. So when you have a shunt lesion with a LV dysfunction with no other cause, try to rule out the coarctation. And in these cases, the coarctation gradient may not be significant because there is no flow across the coarctation segment. Similarly, if you are suspecting a coarctation and you are not getting gradient, you must be dealing with some other condition. In this case, as you can see, there is a severe LVH, poor LV function. This patient had a severe aortic stenosis. So once you diagnose a coarctation on the echo, now we need to do a further investigation so that we can, decide whether we want to go for a stenting or we want to go for a surgery. And the next few investigations should give us idea about type of coarctation, what is the size, what is the length of coarctation, what is the distance from the left subclavian artery, whether there are any aberrant vessels or not, whether the investigation should give accurate measurement about descending aorta, transverse arch, ascending aorta, coarctation segment, isthmus. As well, I forgot to write here. As well, we should see the the investigation which can give idea about the femoral arteries and the common femoral arteries. And as well, if the investigation can give us some functional assessment. So we have two options. One is a CT aortogram and MR angiogram. What is common for both of them is, we can cover wide area. Once the patient goes for a CT or MRI, you can evaluate entire aorta including branches and collaterals. They have superior imaging qualities. I don't find any difference between the CT as well as MRI angiogram. And the 2D and 3D reconstruction is possible, and they can assess the other extra vascular structures like coronary arteries, Takayasu disease, because this coarctation patient in adult will have early coronary artery disease. What is the difference between them? The CT angiogram, it is universally available. It is will have a short scan time. Patient will be out from the CT very easily, less cost. It is good for the claustrophobic patient. Along with this arch anatomy, they can evaluate coronary and they are compatible with metals. While as MR angiogram, it is better if you want a tissue characterization, you want a functional analysis, whether you want AV pathology like bicuspid aortic wall and everything you want to assess. If the patient has an iodine allergy, if they have renal impairment, the 4D angiogram is different. So basically, MR angiogram is preferred for the post-treatment assessment because you want to assess the aneurysm formation. This is the CT angiogram. As you can see, this is a arch and when there is a narrowing of the aorta, there is complete disappearance and descending aorta is not. So here as well you can see the coarctation, and this is a 3D reconstruction of the same. So that this will give us idea where to put a stent, whether we have to sacrifice the subclavian or not. So here, as you can see, it is a just post left subclavian coarctation, where we might have to sacrifice the subclavian if we put a covered stent. This is a pre-ductal coarctation where it is before the left subclavian artery, and there is a along with that there is a transverse arch hypoplasia with calcification. So this is a MR angio where you can see a dilated ascending aorta with there is complete interruption of the arch. This is the 3D measurement. You know why the surgeons they don't dare to touch this patient. See the collaterals, number of collaterals in the posterior on the back in the interscapular area, and also in the anterior side from the internal mammary arteries. These are the posterior intercostals, and you know this is there is a complete interruption of the aortic arch, okay, with a wide gap, and there are a lot of collaterals. So surgical will be difficult here. We need to do a transcatheter closure. So this is a post-MR image of this coarctation with a post-surgical grafting. Now the new with technologies 4D flow MR angiogram can help us to get even the pressure gradient across the coarctation segments, as well as we can see the flow across the segment and collaterals. The diagnostic angiography, because stenting will be covered by Sir Nitindra sir, so I am just dealing with the imaging. The diagnostic angiography is nowadays rarely used because we have got now CT and MRI angios. It is gold standard for the pressure gradient across the coarctation segment, and if you don't have a CT scan, 3D rotational angiography can give you a good assessment about collateral circulations. So these are some of the angiograms where you can see the coarctation segments. It can be done from the radial route or from the femoral route, and these are the collaterals. How to diagnose the coarctation in the fetal life? This is just for the preparation and the management in the post neonatal age group, and even with the best technology, we can detect only 35 to 40% of the coarctation in the intrauterine age. So, in the fetal life, ventricular asymmetry, if the right heart is bigger than the left heart, if there is an arterial disproportion, you can see the femoral artery is big and the aorta is very small, and you can see that there is a isthmus is very narrow. You can see here. Along with that, if there is a presence of LSVC, bicuspid aortic wall, BSDs or retrograde flow, we should always think of coarctation. So in brief, if we have a neonate, we usually the mode of treatment of choice is surgery. Balloon cocktoplasty is indicated only if there is a LV dysfunction or sepsis. If it is a children less than 25 kgs, we prefer balloon cocktoplasty. Later, it is endovascular stent. So to summarize, the coarctation has a bimodal presentation. So you should be aware how they present. The coarctations can be pre, juxta or post-ductal. Evaluation of associated lesions and syndromes helps in prognostication and management, and multimodality imaging modality helps in proper planning and the management of coarctation. Thank you.
Thank you, Prashant. Very lucid presentation. Quick question. Do you do imaging in all the cases? For example, infants, if you plan on doing a balloon, and then post-procedure, post-stenting, what should be the time intervals that we want to get an advanced imaging?
Not in all cases we do a CT or MR. Usually, CT and MR, if we are planning the endovascular stenting, that gives a better idea. In a case of post-surgical or post-stent patients, if we are suspecting any obstruction to the flow, then only we do endovascular stenting. Do a CT or MR angio. Otherwise, we just do a echo.
Conversely, do you do stenting without imaging, directly angiogram based? Is it still done or is it obsolete? I think it's obsolete, but is there a situation where you may do like?
We personally, I have done around 3 cases without CT angio.
Why would you do that?
We took on table with a whole idea of placing a covered stent. So means with the idea whether if it is possible, we will sacrifice the left subclavian. But most of the times, we nowadays prefer doing a CT angiogram before we go for a
Thank you. Now we go to the last presentation of the day. Dr. Nitin Rao will present, will talk on coarctation stenting.
Thank you,
Though this program is based predominantly a device closure program, but still I felt, as I told you also when we were talking on the phone, that this is a very important aspect of congenital intervention, and it's not an easy thing about decision making or even actual technical skill wise. It needs quite good experience and expertise. So I thought I need to include this also, and it's not very uncommon also. Thank you, Nitin. Thanks for bearing with us till the end, for giving a very good, important talk. Thank you.
Thank you. First, I'd like to congratulate Srinivas sir and Nims for this organized wonderful meet. It's very heartening to see this quite good attendance, really good. My talk is, if I do extend, please, then I can stop anytime. 15 minutes, I try not to bore you. Stents in coarctation, like Prashant already covered, it's a bimodal. Coarctation is bimodal presentation, either infancy or adulthood with hypertension, and common cause having young children. And we have lot infantile coarctation is always such. There's no doubt about that. Older children, you can think of balloons, you can think of surgery. But like I said, beyond 10 years, beyond 25 kilos, we'll be more comfortable. But things are expanding now. This was traditionally, you either do end-to-end, or you could put a patch of subclavian flap, or really they put a graft. This is very obsolete. It's something when you got something like interrupted aortic arch or something, those cases undergo this. This is really not done. Aneurysms and recoarctation are more common with patch or end-to-end resection and subclavian flap. And we see some cases, so therefore the idea of percutaneous interventions came out. So percutaneous treatment of coarctation intervention early indicated mainly for adults. Adults offer children free coarctation, not much of data on children actually. Now it's expanded. And few data on intervention children are there. And we've had some studies, lots of us are doing, but not much of data actually in the literature. So the first balloon was in 1982 by Singer. And there was a registry called VACA registry in almost 25, report by Brian McClellan from Canada and other centers. In the 25 centers, 970 procedure outcomes. The native versus recurrent coarctation balloon angioplasty results were comparable to surgery, so only balloon angioplasty. That good effect on BP, big pinwidth came down, the outcome was predicted, and it was quite a good result. Then there was one, in fact, there was very few studies in intervention in children. There were two studies, one in 2007 and one in 2001, old stool 85 to 90, where they said the balloon interventions were more with balloon than stent. So this is the older study. This was quite something unexpected. But now things have gone over then. Now, Audrey Marshall from Boston was the first person who actually did a primary stent implant without doing a balloon. So it was practiced to do balloon earlier, but now she's the first one. Then the gradient came down. It's actually a very small child. Gradient came up 25 to 5. Stents, stents, as you know, in adult stents are uniform, usually controlled dilatation. It can take common dissections and perforations. Can be reset later and less invasive. The problem is the stents, you get very fixed stents lengths of them. You've got a very short segment, you've got to put a bigger device. You've got very long lesion, like in aorta arteries, you may not have one stent enough. Those are that happen. But it's always better than surgery, less invasive. The disadvantage of surgery stent is a bulky, rigid frame, and therefore it's a large profile. A smaller child, you can't avoid that. Even the best of stents will have a larger profile. There's always shortening of dilatation. And technically, you have migration or flaring of the end of the stent. We used to have the palmar stents earlier. Sometimes balloon rupture may also go. And the stent won't grow with the child. Even if you dilate later, it won't grow. This was this concern earlier. Which is why people are a bit concerned, a bit hesitant about doing it. Ideal stent, it's not the ideal word. One which has a low profile, it's biocompatible, resistant thrombosis, with minimal proliferation and easily trackable with less shortening. But this is not the ideal word. But we do have some stents nowadays that are close to that. We try to do as much as possible. Like I said, you don't get the ideal stent length the way you have an adult cardiology stent, coronary stent. So you have to always oversight, you have to always go up. So stents that we use are classified as self-expand, balloon expandable. Self-expand, you don't do balloon, they just expand and you get the sheath back. Balloon expander are more rigid, more bulky, they have good radial strength, larger delivery sheath, there's some amount of shortening that occurs. But one thing to remember, when you have larger vessels like the aorta, pulmonary artery, you should avoid self-expand, you should put balloon expander because you have more control. In the peripheral artery, like what the radials do, peripheral arteries, you can do self-expand, but to be avoided in the central vessel. These were the earliest stents we used, Palmer start stent we used, but the edges were very sharp. The risk of perforation was there, the risk of balloon rupture was also there. Then we came with the Cheatham Platinum stents, specifically have grown leaps and bounds in cardiac heart disease. They were made from 0.02 wires arranged zig fashion, and the shortening is very less. The edges are very round, so the risk of trauma and balloon rupture is much less. These are the image of Palmer start. I'll just run through this. You have the one stent that's not available in India. It's called Mega LD. Mega LD and Maxi LD. These are very good stents, very low profile, but they're not available in India because of some license issues. These can be read later very well. Small stent we can use very well, but unfortunately not there. You only have the balloons, but the stents are not yet there. I don't know what status now, but it's not there. It's a very good stent which we used earlier, but it's not. Like I said, stents can be either balloon expanded, either covered or uncovered. You do a covered stent when you got something like a dissection or you got an aneurysm. Otherwise, uncovered will also do very well. You may have, most of the stents are mounted stents, but you also get bare stents that you have to crimp onto the balloon later. So, like I said, one of the common stents is the CP stent. It's very expensive, but it's there. And now we have this stent called Andro stent, has good radial stent. It was available for some time, then stopped in Britain. Again, it's available right now. The cost is a factor, but it's very good radial stent. We used for a couple of years, we used one had a aorta that is long segment, but it went off very well. But this one stent that's very good, but cost is a factor, available is a factor at some point of time. Now we use a stent called Zephyr stent. Zephyr stent, Indian stent from Sergeant Medical Corp. It's a very good stent. Best advantage is the cost is very low, but unfortunately it's not mounted. It comes with bare metal stent. So you've got to crimp it onto the balloon, and that's a little bit of concern. Then this is the Palmer stent. You have this stent called B-graft. B-graft is a covered stent. It's very costly, almost 3 lakhs, and it's recommended for dissection of aorta nerves. But if you have, it's good if you can. We've never put it so far because of cost. We used to get one stent earlier called atrium stent. We used to get covered and uncovered. It fell out of favor in between. Atrium stent was actually collapsed. It didn't have good radial stent. Lot of reports, we've had a good result, but lot of reports that the stent would collapse, stent would migrate. But luckily we've been okay. We've done a lot of atrium covered stent. Most of them did very well. So this one this is called bib balloon. It's very costly. It's a balloon in a balloon. You have a balloon, one inside, one outside. Basically, the inner balloon is to stabilize the position. Once you are sure, then you can expand the outer balloon. So it's good to use, but it's costly to use. So these are CP stents. You get covered, uncovered stent. you get various diameters. And CP is one of the most time-tested, get various sizes. It's a very good stent, very good to use, but it's costly. Now this is the stent B graft by Bentley Corporation. This is the size. It's very good. You can read it later. It's extremely good, low profile. But the largest goes to 14 French sheath. But it's very costly. When it came out, they said about 3.2 lakhs. They can come down, but not much. One stent we have not used. We'd like to use it. The quality stent, like Prashant said, patient selection is utmost important. You should know your limitation, know what to do. You should select ideal stent. It cannot be close to some vessel. You've got to see that you've got a good landing zone. And everyone does biplane lab, but most of us don't have a biplane lab. So we do what we call a spin angio. Taken multiple looks at spin angio. This delineates your collateral. Then it helps to address a landing zone, what you can. We always do want a sedation anesthesia because when you inflate the balloon in the aorta, there's always a lot of pain. You have a patient. I always expect to be done in general anesthesia, have a good sedated patient doing that. You put an 8 French sheet, put a pigtail catheter, and then but one thing is we put a temporary pacemaker catheter, TPI lead. This gives a lot of stability. No, people now don't do it nowadays, but we do it. We either put a TPI or we get adenosine because it causes temporary hypertension. So the stability of the stent is there; it does not migrate here and there. So, like you take you access either femoral, rarely brachial if you can't get femoral access. If you can't cross from femoral side, it happen and take measurement. Most important, narrowest diameter, transverse arch, post dilatation also. So this is the narrowest diameter. This is pre and post. You take this transverse arch, especially in children, because you should not exceed the diameter of transverse arch. Adults you can go. One thing, even if you got post, that doesn't matter. The stent overhangs it doesn't matter. It usually adjusts very well. Initially, when you start, you wondered whether this would have any effect on post invalidation, but that's okay. That's actually good. And like I said, pre-dilatation was something commonly followed. Like we don't do it nowadays because there are reports that if you do pre-dilatation, you actually have a stent embolized later. So better to avoid unless it's very tight. Like I said, it's a TPI. And you always oversize so that you have good standing. We park the wire distally mostly. A lot of people like to put in the right septal artery so that you have a good aligned variable for the stent to pass. Then you use the balloon, big balloon. You use the contrast in 1:3 dilution. And you have two ports, one, the blue outside one, blue is indigo, that is the inner. And outer one is on. So you know which balloon you're inflating. So you know which balloon you're inflating. The O over here. Then we do under pacing adenosine. Like I said, balloon expander was we always prefer balloon expander. We've done one self-expander, but that was quite bad. I'll show you that. So always oversize. Then either to bare metal stents or pre-mounted, then most of the stents are pre-mounted, but you get Zephyr also as bare, which you have to crimp on the balloon. And like it's covered or uncovered, you've got an aneurysm, you've got something like a aorta, maybe you can use it. So this, now various types of morphology you can cover. You can have short segment, you can have long segment. The long severe segments also you can get away. Because these are old adult patients, you can put in nice long stent. You'll actually get good result. It should be possible. Sometimes when you got severe kinky, if you are lucky, you can get the wire across. You may be able to get the. You may be able to get it if you can get the wire across. So this is the image of a kinked aorta. The wire straightens out. Sometimes you may think it's an interrupt aortic. This is one shoe from one shoe. Actually, there doesn't appear to be continuation. You can see with a small wisp across. If you are lucky, if you get a wire across, you may be able to put a wire across. You can see this patient, one lucky patient, we could get a wire across. And finally, a stent was also done. So this is a good result, but you're not lucky all the time. Sometimes when you go to a near atresia, like you have severe PS with near atresia, this may also be able to get. It all depends when you can manipulate the wire across. It's a question of luck. You may be able to get across, you may not. Now, when you have, this is a patient who underwent surgery and there's an aneurysm after surgery. This is a very good patient for a covered stent. You can put a covered stent, you can get a good result. And with you can dilate the lower end of the stent also, that stent is in place. So this is the final result. So you have an aneurysm thing, and this is done quite. But there is some dilatation here also. But this is okay. Sometimes what happens if you do overdilate, you may have stent fractures also. This is a patient who underwent a stent, but the stent actually fractured. So then you have to put another stent with another stent or another covered stent, and you actually get it. One should always keep in mind, like interventions, you have to keep in mind no limitation. Always better be safe than be sorry. Keep all complications in mind. First, do no harm. You always keep all in mind. These are real complications that can stent embolizing stent migration. It may slip off the balloon, especially when you have to mount the stent on the balloon. When you're putting through the sheath, it may actually move up. The sharp edge of stent may also cause balloon rupture, may cause perforation at times. You may have dissection of the aorta, you may rupture of the aorta if you're not careful. Vascular issues because large sheath is also there. Now there's a lot of interest of this. The stent called growth stent was used for infants. This was in early 2000, 2007, 8, in Germany. That these were stents, but the suture material was used was very absorbable. So that suture stent was absorbable. So that lot of data did very well in older children, but somehow fell off. It didn't do very well. They had a lot of. I was at that center that time. They had a good data. And they did, but it didn't really pick up. Initially growth stent and later CP stent. There, of course, finance is not an issue, so they can go ahead. But for us, practically it's not possible. Now, just like in one few cases, so the 25-year-old male was injured in hypertension. The echo showed a coagulation and PDA. You can see this is the juxta. If you can see that this is the coagulation, this is the PDA. You can see the subclinic artery is also coming here. So 3 lesions here. But if you can see better, this is the collateral flow of the subclinic coming from circular pins. So we thought we'll go ahead with the stent, and we managed. The one when you put a TPA catheter, if you put a TPA, once the stent is down, in sheath is down, you can actually inject contrast much more distant. So this is what this is the atrium stent. Atrium stents take very long to open up. It doesn't open fast. This is the stent, and you can see this is the end of the PDS close. You can see a slight close subclinic still there. So he did very well on follow-up. And even there was no vascular issues, limb issues. He did very well. He did drop on follow. He's doing well. This was another 16-year-old girl. She had, like Prashant said, she had severe bicuspid aortic valve with severe AS and severe coagulation. The plan was to do BAV first. Why BAV first? I used to always do distal region first. The reason was because suppose the aortic, you have a problem with BAV, then you have to do aortic valve replacement. No matter to do both in the same setting. Otherwise, you would like to do coagulation first. So when the balloon went up very well, followed by we dilated the coagulation, then to the stent. Like this is not very well visualized. So we did something. This is a spin angio. Spin angio. We moved from RAO 30 degrees to lateral 90 degrees. We can see this is not very well, but if you can, this is how we have to deal how close it is to the subclinic artery. This one spin angio. This is not a pulmonary angio. You can see this very well. We had to deploy stent here. So this here is the very well zone. This is what we do by spin angio. So anyway, she underwent a PBAV, and then we did a pre-dilatation with the balloon first. We put a very short Zephyr stent. We mounted an Atlas balloon with the stent. So very short stent went off very well. We were very close to the subclinic artery, but it went off well, no issue. And these people had a lot of financial history. We came from Raipur, sponsored by government of Chhattisgarh, so we had to be aware of finance. This is what happened. This is a good result. This is another boy who had an 8-year-old boy. This went off okay. I'll run through it because I want to show you next. We did dilatation approximately distal good result. Now, this is a lady who was 30-year-old lady, was recently hypertensive diagnosed. She had a pregnancy at 20 years of age, uneventful. No diagnosis so far. Then she came to us with coagulation. The plan was to that this was about 12 years back. We didn't have, we had a self-expanding stent that we use a Boston stent. So you can see this very discrete disc. So we went and we put, I don't know if you can see that the stent is here. This is not, we tried to put a stent, but when we cover stent, we remove the sheath, the stent, so when you remove the sheath, the stent migrated. You can see the stent has gone up. This is the coagulated stent has gone up. So actually it's migrate. This is the issue that can happen with self-expanding. And you see that so we are still nowhere. So we had to go back again. We had to put the longest. The first stent was 40, then it was 60, 14 to 60. And see, then the stent has opened up. The narrowing is still there. Right? This is how self-expanding stent opened. So then we did the balloon dilatation and it opened out very well. She comes to follow up, she's doing very well. There's no grade, hypertension medications are all gone. But this one complaint you have to keep in mind. Stent migration, stent embolus is there. And there are reports of aorta rupture also, but we never had problems so far. So to summarize, cooperative stenting can be successful in selected patients. Adults and older are very well. Always safety is first. No limitation, no went backup. And keep all common in mind always. Because patients first, then our egos. Thank you. Thank you.
Thank you, Nitin, for the wonderful presentation. What is your experience with post-stenting aneurysm? Do you do some routine imaging?
No, there are some reports we have not had so far. Of course, there are reports in outside literature. In fact, they are more with balloons. You have balloon angioplasty, less with stent. With surgery and
so do you follow them up with the CT, MR, because we don't pick them up on echo?
Yeah, we don't pick them up. We've done 1 or 2 CTs, we do 1 or 2 MR, but most of them done that. But we mainly do echo. We look for the grain, and then there's one child. She had a aorta, the girl, and she had a lot of narrowing. So we did a CT, but she's okay. Most of them.
This growth stent you mentioned, how small can you go with that?
You can go now no one is doing. When I was
it's in a trial, no?
Yeah, they did about 56 patients. It is very good, but they stopped because it was absorbable sutures. That's that one.
If stent is needed or required, and the patient cannot afford a CP stent or even a Bentley, etc., what will be your choice?
The best stent what we use now is Zephyr stent, because Zephyr.
This is a very practical situation.
Zephyr, they will give it at less cost also. But
have you tried peripheral vascular stents for coagulation?
Peripheral, all are self-expand. You don't have that side.
Many years ago, we have done about Dr. and myself, Dr. Sashgirov sir, our team has done about 32 patients for the lumen extents. And in fact, we have published that in Indian Heart Journal also, that series, with very good intermediate midterm results.
This self-expansion, I told the whole of the financial cost. And see, the AIMS group and Bangalore, they do a lot of self-expansion for even aorta attacks. But I'm a bit safe because you don't get that much radiation. But you can.
Once the patient attains to an adult life, adult age, and aorta has attained to adult size, it doesn't matter whatever you do. The problem is all in when you need to stent in a child, where the child may in future need repeated dilatations to keep up with the growth of the aorta.
Peripheral stents are even cost is better. So that's a good option, but I'm a bit scared. We never used.
Any other comments, Prashant?
Zephyr stent.
Zephyr stent is same.
Yeah. Oh.
These are Zephyr
and yeah, good. And Zephyr stent has very good radial stent also. Not lumens. Zephyr has very good radial stent.
Any other comments? If there are no comments, we will close this session and will conclude the program, today's program. And I request Kavita ma'am to hand over memento to Dr. Nitin, Dr. Prashant. So, as a formality, I need to say a few words by way of vote of thanks. And I thank everyone, especially I thank the administration of our institute, Dr. Veerapagar, our beloved director, Dr. Lizagar, our dean, and Mr. Superintendent and other administrators who have helped us in every way and ever since we conceived this program and encouraged and supported us, especially our director garu. Thank you, sir. And then my thanks goes to Dr. Rama, our HOD. You had a big hand for all her support. She is with me. She has been with me for this program, and in fact, she keeps on saying we got together as a unit, sir, as a team, and I agree with her. And we have been doing like that. We keep doing this, Rama. And my I thank Dr. Sai Satish Garu, who, as I have told in the morning, also has always been supportive of me, whatever I do. I thank Dr. Purushottam, especially, who has recently passed out of the examination and still he is with us and has done a lot of work. And thank you, Purushottam. And then, of course, I have five just ఇక్కడ అందరు నుంచోండి. Give them big hand to the woman power of our department, ma'am. This is the woman power in our department. We have curated and we are developing them. Okay. No, our department is dominated by them. Okay. Thank you, Dr. Sunita, Dr. Manikrishna. Okay. Sunita, Manikrishna, Kuma, Nusha, and Rachana. Thank you very much for all the support you have given to us. And then Usman and his colleague for their unfailing support always. And then my own technical staff from Cath Lab and non-invasive area, Soumya, Disha, and Gadar and everyone, Om Prakash, Varma. And then last but not least, no conference would be a success without the presence of the audience. And we have seen what wonderful audience we have had. We have had jam-packed hall since the post-lunch session till almost PDA session was over. And I thank all the audience. This conference is successful if audience go more wiser and more illuminated or enlightened with the knowledge after the session, after the program. Thank you very much. To close this.